showcasing breakthroughs, debating challenges, and most importantly, inspiring one and another. On behalf of the organizing team, I, Dr. Sunidhi, Senior Resident, Department of General Surgery, and with me, Dr. Rupali, Junior Resident, third year, Department of General Surgery, Subharti Medical College and Hospital associated with, will be the facilitator of the CME. Briefly telling about our institution, Netaji Subhash Chandra Bose, Subharti Medical College, is one of the finest medical colleges of Northern India. It is a daughter institute of Swami Vivekananda Subharti University, Meerut, founded by Dr. Atul Krishna Sir and Dr. Mukti Bhatnagar ma'am. Under their leadership and guidance, University today runs 200 plus courses. Our college is located within the vast foreign campus and furnished with latest and best available audiovisual teaching aids. The medical education unit of college regularly holds workshops and CME to continuously upgrade the knowledge of their faculty. Now, moving on with our first session, radiology session, basics of imaging in hepatobiliary disease. To chair this session, I would like to call Dr. Ashok Kumar Singh sir, who is Professor in HOD, Department of General Surgery, Sri Thamkar Mahavir Medical College and Research Center, PMU. He is a lifetime member of ASI, IAGS, Amasi and ISC.
ये चलता रहेगा ना,
I will
एंड नहीं करना,
ask
एंड नहीं
our
करना,
resident escort sir
रिमूव
to
करना है,
speak.
रिमूव करके पैनल लगा देना। ठीक है, जैसे रिमूव कर दूँ फिर कहाँ से स्टार्ट करूँ, यहीं से करूँ, ऐड टू स्टेज से। ठीक है, ये करना बस नेट करेंगे, मैंने अपने वाले लोग डाल रखा है इसमें।
The other chairperson will be Dr. Vikas Singh sir,
अच्छा,
who
एक
is
चीज़
a
और
professor in
जैसे वो
and
लेयर उठती है ना, उसकी वेव जो उठती है, वो इसकी जो वेव उठती है, वो वेव नहीं दिख रही इसमें। यहाँ से नहीं उठी, मैं बताता हूँ, जाओ सेटिंग्स पे जाओ।
I request Dr. Sanjay Pandey sir, who is professor and head Subharti Medical College, Department of Surgery. Unit.
ठीक है वो।
Now I request Dr. Harinder Sandhu sir, Assistant Professor, Department of General and Minimal Access Surgery,
बेटा फोटोज ले लेंगे,
Himalayan Institute of Medical Sciences, Dehradun.
साथ में मिलकर रहता है पर्सन।
The speaker for this session will be Dr. Mukta Mittal ma'am. She is working as a professor in the Department of Radiodiagnosis and in the Subharti Medical College.
जाएंगे पूरा वीडियो मैनेज करते हैं, मैं लाइव कर रहा हूँ।
Thank you, sir, for inviting me on this forum. And I wish you a very good morning to all the senior faculty members, to my dear friends, and of course the residents. We all know that hepatobiliary diseases form a major chunk of the patients presenting for imaging to the radiology department. And there are a number of imaging modalities, and it is important to know which imaging modality is to be taken up as the first one, so as to get the optimal and good results.
जब फोटो लेगा ना, फोटो जब लेगा तो यहाँ से
in the next 30 minutes, I'll try to cover
फोकस करके फोटो क्लिक करके तब फोटो लेना,
the imaging modalities, the role of
यहाँ से
each
लेना,
imaging modality.
यहाँ से जब मेज हल्की सी यहाँ से लेना है, अपना जूम और कर सकते हो।
This slide I've included mainly to summarize the number of the plethora of imaging modalities which are available, starting from the basic, that is the X-ray, ultrasound, CT and MRI, which all of us are quite well aware of. Along with that, we have a few others like the ERCP, the PTC and nuclear medicine, and of course some which are of just historical importance and are obsolete now, although we have done it during our MD, but nowadays nobody advises and does these imaging like oral polycystography. Plain X-ray, as you all know, has a very limited role. It has been replaced by the other imaging modalities. It may be helpful in picking up the radio dense calculi, as in this case, which is a very low percentage of gallstones are calcified, like about 10 to 15%. So it has got a very limited role. At times, it may show the presence of air within the wall of the gallbladder in the lumen in cases of emphysematous cholecystitis. Or there is even a triad which can be picked up on an X-ray in cases of gallstone in the form of air in the biliary channels with a small bowel obstruction and the gallstone which is the cause of obstruction. We can see pneumobilia, and we can also at times see the porcelain gallbladder, which is the calcification in the gallbladder wall. Now coming to the most important and the most preliminary and the basic imaging for the hepatobiliary system, which is the ultrasound. And preparation, as we all know, the patient has to be fasting for some time so that the bowel gases are reduced and ensures a good gallbladder which is full and visible. Now, why is it that the ultrasound is the favored imaging modality? We all know it is easily available, low cost, with no risk of radiation, can be repeated, can be done at the bedside, and it has got a real-time capability, which is very good for intervention radiology, as will be told in the following lectures. And at the same time, with the addition of Doppler ultrasound, we can also see the blood flow dynamics, but then it is operator dependent. Now this slide I have just included to show how a normal liver looks on ultrasound, and we can obviously also divide the the liver into various segments, as into the 8 segments by the hepatic veins. Now on ultrasound we can see the diffuse disease of the liver, like case of fatty liver, where we can see that the liver is becoming more and more bright, and then it can be graded on the basis of the level of increased ecogenicity. At the same time, we can also see the ecotexture, and this reside on the liver parenchymal disease, as this is a normal liver, which is quite homogeneous, and a coarse liver with nodular margins, which can help us to tell that it's a case of chronic liver parenchymal disease. We can also add elastography of fibroscan, which can also tell us about the stiffness of the liver on ultrasound for liver fibrosis. Along with that, ultrasound is the modality of choice for picking up a cyst and differentiating it from a solid lesion, also whether it is a simple cyst or it's a haggated cyst, like in this case, where we can see the typical water lily sign, or in picking up the liver abscess, where it can tell us the number, the volume, the amount of liquid compact component which is present, which is important for planning or stick drainage, and it can also help in guiding the drainage. Then in solid masses, it can help us in picking up the most common benign solid mass like a hemangioma, which you can see here, which looks slightly more bright as compared to the normal liver. And in cases of hepatocellular carcinoma, we can add a Doppler, and we can also see the presence of vascularity. In addition, we can also pick up, like in this case, the presence of a portal vein thrombus. This is a case of CLD with FCC, and this is a portal vein thrombus with stenosis. Further, ultrasound has an important role in picking up metastasis, which can be either more bright than the liver, then they are referred to as hyperechoic or hypoechoic, as in the previous case, which is most commonly seen in cases of adenocarcinomas. And there is the addition of contrast-enhanced ultrasound can further help in characterization of the masses. We can use a contrast like an echovis and see the progressive filling up of the lesions, as in this case where we were able to diagnose the hemangioma with more accuracy. Now coming to the gallbladder, ultrasound remains the primary and the most important imaging for the evaluation of the gallbladder disease. And this is how a normal gallbladder will look, and this is a typical appearance of a stone with the distal shadowing, and ultrasound is considered as the gold standard for the diagnosis of chorionic cases. Along with that, we can pick up sludge or the signs of acute cholecystitis. Now, since it is a real-time ultrasound, we can also demonstrate the positive sonographic mercury sign, which is pain elicited by the pressure over the sonographically located gallbladder, along with the presence of a gallstone and dilatation of the gallbladder with pericholecystic inflammation. We can also pick up gallbladder polyps or adenomyomatosis and asymmetrical mural thickening of the gallbladder or a mass in the gallbladder, which will favor it to be a gallbladder carcinoma. In the biliary system, along with the gallbladder, it can also help us in telling whether the biliary system is dilated. As in this case, you can see that the ciliary is dilated, and this is the location of the ciliary, where it is anterior to the portal vein, and these are the biliary channels which are dilated. We can pick up a case of Merosi syndrome, as in this case, we are able to see the distended gallbladder with a stone impacted in the cystic duct, causing a dilatation of the proximal ciliary and the normal ciliary distal. Polylocal cysts, like in this case, and can be picked up well on ultrasound, along with small masses like cholangiocarcinoma. However, ultrasound is not the only imaging modality, and we have other imaging modalities like CT. Now, why is CT often better than ultrasound? Number one, it gives a very good visualization of the anatomy with a very good contrast resolution, and it is excellent for vascular assessment when we do a CT angiography, and it is more sensitive and specific for detecting liver tumors, abscesses, metastasis, vascular abnormalities, and is considered to be the gold standard for trauma patients for picking up liver lacerations, where we can pick up active bleeding also in the trauma setting. This slide I've just included to show the division of the liver on the basis of the hepatic veins into the different segments. Now, a few words about the patient preparation, which I think the residents should be well aware of before we proceed for elective CT scan. The patient should be nil orally for 5 to 6 hours, and we need a serum creatinine level basically to assess the kidney function, because we are going to give an IV contrast agent, and the serum creatinine should be within normal levels, that is less than 1.5 milligram per deciliter, and in case it is more than 1.5, we have to calculate the eGFR and then proceed with the contrast study. We are using an iodinated contrast, and we are doing a multiphasic CT. Now, what is the basis for a multiphasic CT of the liver is the dual blood supply to the liver. That is, majority of the blood supply is by the portal vein, while only about 20% is by the hepatic artery. So on this basis, we have planned a multiphasic CT scan, in which we do a non-contrast CT first, mainly to see whether there is any calcification or hemorrhage. Now, this is important because a hemorrhage will also be seen as hypertension on CT, and once we give the contrast, we are not able to pick up whether it's hemorrhage or contrast. So we need to take a non-contrast CT prior to proceeding for a contrast evaluation, and then we can take the different phases: the arterial phase, the portovenous, and the renal phase. Now, the basic role of the arterial phase is that since most of the hypervascular tumors, they will enhance via the hepatic artery, which is when the normal liver parenchyma does not yet enhance, because it is not, the contrast has not reached the portovenous system. So hypervascular tumors are very well demonstrated in the arterial phase. Now, these hypervascular tumors maybe most commonly we have to give HCC or hypervascular metastasis, like from a renal cell carcinoma or carcinoid or thyroid malignancy. And even some benign lesions can show arterial phase enhancement, like an adenoma or an FNH, but they will have different characteristics. Vis-a-vis a portal venous phase, in this phase the liver has enhanced, so we will be able to pick up hypovascular lesions like majority of the metastasis and a delayed phase. I will be just showing you a few cases. A few of them are from our own department. This is a case of hepatocellular carcinoma. Here we have taken a plain, the first image is showing the plain CT. We are seeing no hemorrhage, no calcification, no fat accumulation. And then on the arterial phase, we can very well see the enhancement of the mass lesion. Now this is an arterial phase because the contrast is very well seen in the aorta. And on the delayed, on the photometers, on the delayed phase, we are seeing that the tumor is showing washout with a residual gradient, which favors hepatocellular carcinoma. This is a case from our department, which is showing the similar arterial enhancement with a washout. And in addition, we are also able to see the portal vein thrombus. This is the portal vein which is showing a filling defect, which on the arterial phase may show enhancement, favoring it as a tumor thrombus. Now, radiologically, on the basis of the enhancement characteristics, we at times report the CT as lyrics. The slide was included mainly to show the importance of the various lyrics categories, which reflects whether the lesion has a probability of being an HCC, and we can define the lyrics criteria from LR1 to LR5, where LR1 is a definitely benign lesion, while an LR5 is a definite HCC. This is determined on the basis of the CT scan, whether there was enhancement, what type of enhancement, what type of washout, and the size of the lesion.
उधर बैक साइड बताओ, बैक साइड में बताओ, ऐसे बैक साइड में करना, इस साइड में बताओ, थोड़ा सा बताओ, या तो इस साइड में बस हो जाओ, बस हिलने के लिए मना कर रहे हैं।
These are some hypervascular nets which have been picked up in the arterial phase.
ये जो बैठे हैं इनकी ले ली थी फोटो,
जो सब बाहर बैठे
पूरे के पूरे इनकी ले ली, जो बैठे तुम
seen as
इनके
a
आगे
centripetal
चले गए,
lesion showing gradual centripetal progressive enhancement becoming isolates to the liver on the delayed phase as compared to an FCC which shows a contrast washout. These are some cases of metastasis, most of the adenocarcinomas, which will be seen in the photovenous phase. Then in addition, CT can also help us to tell us about the cyst or the presence of an abscess. Here we can see the difference that there is a simple cyst, which is of homogeneous fluid density, while here we are seeing a peripheral enhancing lesion with surrounding edema, favoring it to be an abscess. Now here the CT has a role that it can tell us about the exact location, whether there is a risk of rupture or it has already ruptured, and other complications of a hepatitis. Case of cholangiocarcinoma, this is again from our department, with IHBRD. We can see that the biliary channels are dilated along with the portal path. There are some malignancies like a cholangiocarcinoma which do not enhance early but show a progressive late enhancement because of the presence of fibrosis, and this helps us to differentiate an HCC from a mass-forming cholangiocarcinoma. Now, besides liver masses, CT can also help us in picking up gallstones, although most of the gallstones are not visualized on CT because they are not really, do not contain enough calcium. It can show a complication like a gallbladder perforation. This case is again from our department where you can see a small discontinuity in the gallbladder wall with a gallbladder perforation. It can show us the Mercedes-Benz sign where air is seen within the gallbladder. So what are the clinical scenarios where CT is preferred? CT is preferred for liver tumors, for characterization of SOS, whether it's an HCC, metastasis. In case of an absence of cystic lesion, it helps to define the exact extent, wall, whether there is any presence of gas. Then for staging of malignancies, particularly gallbladder or cholangiocarcinomas, in cases of trauma, and in cases of transplant evaluation. In addition, it is also helpful for identifying a mass at the pancreatic head level or ampulla in cases of biliary obstruction. Coming to the next imaging, we all know about MRI. Now what is the role of MRI? MRI is not readily available in all the institutes, and at the same time it is quite costly. So what are the conditions where MRI is preferred? MRI is particularly preferred for evaluating the biliary tree without contrast with the help of MRCP, and it is for a special role in detection of biliary leak. Then assessment of liver fibrosis. In fact,
दोनों के
MR
एक
elastography
साथ
is
ले लेने
considered
की
superior to an ultrasound
ये उसकी ऐसे
elastography.
मार दिया एक अलग
For
एक ही
fat
जूम
and
करके
iron
उसको मार दिया
quantification, it is now considered the gold standard for liver fat and iron quantification. Then in picking up a suspected HCC in a cirrhotic liver or in pediatric patients for polylocal cyst because there is no risk of radiation, and in characterizing a few indeterminate lesions seen on CT and ultrasound. This is how a normal MRI will look, where you can see the liver on a T1 weighted or a T2 weighted image, and this is how an HCC or hepatocellular carcinoma would look. Hypointense on T1, hyperintense on T2, and this is, we can also do a contrast enhanced dynamic scan and see the arterial phase enhancement on MRI. We'll pick up hepatic metastasis. Now, MRI has a very important role even in characterization of liver nodules which are seen in cirrhosis, like the dysplastic nodule versus an HCC with the help of diffusion and contrast enhancement. Coming to the most important role of MRI, which is MRCP. This is how a normal MRCP can demonstrate the anatomical details in the gallbladder and biliary channels. Now, this is gained a lot of widespread clinical importance, and it can visualize not only the intra and the extrahepatic biliary system, but also the pancreatic ductal system without the use of any contrast or radiation. The patient again needs to be fasting for 8 to 10 hours prior to the examination, mainly to reduce the gastroesophageal secretions, to reduce the peristalsis, bowel peristalsis, which can result in motion artifacts, and to promote distension of the gallbladder. It can be done even on an 1.5 or superior MR Tesla systems. And this is how it is an excellent modality for picking up polylocal cases in a case where we can see gallstones along with signal voids in the CPD, again on the same patient on facial scan. It can also show us the presence of Mersey syndrome and a biliary leak where it is considered to be the gold standard for making a biliary leaks. Again, we are seeing collections of biliomas, and it has also got an excellent role for evaluation of the malignancies like gallbladder carcinoma. We can see the biliary channel dilatation with the mass, and there is a special role of diffusion imaging in MRI, which is seen as this image is showing the diffusion restriction with corresponding effect on an ABC favoring it to be a highly cellular mass likely malignancy. We can pick up polylocal cysts, Carol's disease, and even a biliary stricture. Now, these are the main imaging modalities. I would just like to share a few words about the other imaging modalities. As I told you, oral cholecystography we no longer use. It is obsolete now, and this is how the image used to come with multiple filling defects in the called stones. Then PTC, which has been replaced by other imaging modalities, and its role is mainly in the intervention nowadays, which will be covered in the next lecture by Dr. Sachin. So I don't need to go into too much details. Again, in invasive procedure, we put in a needle and it can help in drainage of the biliary system. Then a T-tube cholangiogram, which is if the CBD is explored at cholecystectomy and T-tube is put, we can do the T-tube cholangiogram after 7 days. Now this is important that we have to do it after 7 days because by that time the artifacts due to blood clots or air bubbles have been absorbed. And if we see a filling defect, the CBD can be explored and this can be taken out. This filling defect will suggest that it is a tactics. Intraoperative cholangiography, endoscopic ultrasound. Now, biliary endoscopic ultrasound, it's a high frequency imaging in which at times you can add the color, and it's an excellent modality for evaluation of the extrahepatic biliary tree and pancreas, and it allows direct visualization of the duodenum, and at the same time it can help in fine needle aspiration cytology. Then ERCP, it's important for biliary stenting and for strictures and leakage. for drainage of pancreatic cirrhosis, for dilatation of the duodenal papillae, and in cases of sphincterotomy, and at the same time used for tissue sampling from the delivery of the pancreatic papillae system. And this is how a normal ERCP, you can see the CVD, you can see the pancreatic duct. And this is how, this is the endoscope of the ERC during the procedure of ERCP, and this is showing the CVD with the filling defect suggestive of a polyfocal disease. Now, a word about nuclear medicine. We all know about PET-CT, the role of PET-CT in staging of various malignancies, for picking up metastasis, distal metastasis, which might not be picked up on a routine scan of the abdomen. We can see the entire body for metastasis. Like in this case, there is a case of CA colon with metastasis in the liver. Now, the important thing I want to stress is about the hepatobiliary scintigraphy or polyscintigraphy, in which we are giving liver and biliary channel specific scintigraphic agent, which is subsequently excreted and helps in detection of few pathologies of the hepatobiliary system, like it's got an excellent role in cases of neonatal hyperbilirubinemia in differentiating whether it's a biliary atresia or a neonatal hepatitis syndrome. Then in cases of acute polycystitis, it is considered to be even at times better than acute ultrasound in picking up cases of acute polycystitis or in cases of biliary. Now, this is how a normal scintigraphic image would look. The contrast, the radio tracer is given, taken up by the liver, and subsequent images are taken at 5 minutes interval. We can see the hepatic accumulation, then into the gallbladder, the CVD, and subsequently into the duodenum, showing a normal scintigraphy, as compared to a case of like hepatobiliary atresia, where there is no visualization of the gallbladder and no contrast is seen in going into the duodenum. Only in the contrast, the tracer is all accumulated in the liver. A case of acute polycystitis, where we can see, this is a normal HEDA scan, which is showing the gallbladder and the CVD, while here you cannot see the gallbladder as such, and the contrast has gone straight into the CVD and the small bowel because of non-function of the gallbladder. At the end, I would just like to stress a few points. Basically, for the residents, that when we are investigating a case of gallstone, first line remains an abdominal ultrasound, which can show us the gallstone thickening, complications, and peripolycystic fluid, at times even perforation, but it is less sensitive for CV stone, for which we can go for an MRI. In case of an obstructive jaundice, these are the questions which need to be answered. That is whether it's biliary obstruction is present. If it is present, what is the anatomical level? What is the cause? And what is and whether the obstruction appears to be malignant. USG remains the initial modality, which has to be supplemented by CT or MRCT, and in some centers even endoscopic ultrasound. Just a few words about role of imaging in hepatobiliary trauma, as is the abdominal trauma in general. We all know if there is a stable, we do a fast, the patient, if it is positive, CT is the gold standard for picking up the cases of abdominal trauma. And if it is negative, we can just do a serial fast, while if the patient is unstable, we straight away can go for up fast to operating, straight to the operating room. So the role of imaging is mainly with fast, which detects the free fluid in the perihepatic and perisplenic spaces. And CT scan is a primary imaging modality for evaluation of patients with biliary and hepatic trauma in stable, if the patient is stable, and it can also help in grading of the liver injury. This is how these are the sonographic images which we have taken by in a case of fast, where we are seeing for the presence of any fluid. As in this case, we will be seeing the fluid in the hepatorenal pouch. We will label it as a fast positive, and if the patient is stable, they can go for a CT scan, which will show us the degree of liver laceration, whether there is any vascular injury present or not. So at the end, I have in my lecture tried to tell about the basic basic role of each imaging modality in evaluation of the biliary system, and it is important, particularly for the residents, to make judicious use of which imaging has to be done at what time, so as to get optimal results and also to reduce the patient cost and discomfort. Thank you for your patient hearing.
Thank you, Dr. Mishra, for such a illustrated and comprehensive description. Yes, it is very important to decide which investigation has to be done in hepatobiliary disease. I'll say just one comment to all my seniors and junior colleagues, especially surgical people. They should always discuss, they must make a very good rapport with their radiologist. They should always discuss what you want to see, so that the radiologist may help you in the diagnosis as well as in the treatment strategies. It may look very exhaustive when to go for ultrasound, when to go for CT. Cramming it up might be a difficult task, but definitely a simple phone call to the radiologist may help you a lot.
Wonderful. Just one query which I had in mind as a postgraduate as well. In obstructive jaundice, MRCP serves very nicely. It tells you exactly, as far as the surgeons are concerned, we need to know about the site of the distal obstruction or the extrahepatic dilution. What is the best modality for the cholestatic jaundice that we usually see?
Cholestatic, we will not see any biliary dilation, right? That's what we are expecting.
Yeah.
We will just see, it will be basically obstructive without dilation of biliary tract.
So in that, what is the best modality in those cases to get to know from our friends that how do we decide on that? Because the patient bilirubin is usually, let's say, beyond 15 or maybe 18 or
Primary will be an ultrasound. First, we would like to see an ultrasound. Whether the biliary channels are dilated. Whether the biliary channels are not dilated, we will not be able to, and there is no role of other division. You want to know?
does HEDA scan help us in that?
Whether there is any excretion or that is basically a functional screen. So it can tell us about whether the tracer is being excreted or not, or it is just being concentrated in the liver itself. There will be no excretion in the CV and the urine.
We say that HEDA scan is the one thing which is going to help us a lot. So if there is something like fulminant hepatitis and cholestatic jaundice, let's say these two things, because one is a purely medical case, other one is a surgical case, unless and until you prove it. So does HEDA scan differentiate between both of them?
HEDA scan can tell us about the functional state. Basically, it is not excreted. That it can tell us that it is not excreted. It is not because of the mechanical obstruction, but it is because it is non-functional or either the biliary system or the blood. That is all.
So in cases of fulminant acute kidney, so does HEDA scan that also tells that it is within the liver? Will it be collected within the liver?
The contrast will be collected in the liver.
So then the picture is going to be almost the same in both the cases, in cholestatic as well as hepatic failure.
Hepatic failure, it will not pick up the contrast.
That will not be.
It will not pick up the contrast. And the biliary system will not go past that. Basically, I think the liver scan is a part of the liver. It will tell you more about it.
The reason I don't understand, because this was one cases which at times it becomes difficult. Patient presents as obstructive jaundice, and it's more of a dicey. And then we ask, what next? So the only thing what we think about is maybe HEDA scan. Unless until you go in for a biopsy, cholestatic jaundice cannot be confirmed. You have to do it. Because in one patient might recover with medication, but another may be
चश्मा
patient
लगा लिया
for
क्या
only
नाम है
one thing, and that is liver transplant.
लग गए अच्छा
So
स्क्रीन
that-
से हमारे भी लगे हुए हैं
Thank you. Thank you.
Thank you so much.
हाँ सही है पी लो
I will request to Dr. A.K. Singh sir to felicitate Dr. Mukta. Now, I request Dr. Sanjay Pandey sir to felicitate Dr. A.K. Singh sir. I request Dr. Sanjay Pandey sir to felicitate Dr. Vikas Singh sir. I request Dr. Sanjay Pandey sir to felicitate Dr. Harinder Sandhu sir. Thank you so much, Mukta ma'am, for such a wonderful lecture.
Now, we will proceed with our next session of radiology, that is a diagnostic and therapeutic role in hepatobiliary disease management. To chair this session, I would like to call Dr. Hemant Nautiyal sir.
I would like to call Dr. Shashank Mishra sir, Professor Unit Head, Subharti Medical College, ex-Head of Department, Subharti Medical College, Department of Surgery. Dr. Ankit Mishra sir, Associate Professor, Hind Medical College, Barabanki. Dr. Krishnamurthy sir, Executive Officer and Head of Emergency Medicine Department, Subharti Medical College. The lecture on diagnostic and therapeutic role in hepatobiliary diseases will be taken by Dr. Sachin Agarwal sir. I will call him on the stage.
आप जब इसको प्ले करेंगे ना प्ले तो चल रहा है नहीं चला सर
Good morning, everyone. I'm going to present the hepatobiliary intervention in the simplified way for the understanding of resident. I have learned lots of things in the Subharti also by doing and learning by my senior like Dr. Shashank Mishra sir, Pandey sir, Maheshwari sir and Dhanesh sir also. And I'm going to tell some few things about the hepatobiliary intervention. First of all, there is a lot of how to classify hepatobiliary intervention. We can classify hepatobiliary intervention in a various way like diagnostic or therapeutic intervention or hepatic or biliary intervention or vascular or non-vascular intervention. I try to simplify and incorporate all this classification in a one slide like diagnostic and therapeutic. In diagnostic we can do non-vascular and vascular intervention, and in therapeutic, non-vascular and vascular intervention accordingly. First of all, I am going to discuss hepatic intervention. After this, I will discuss biliary intervention in a similar way. In hepatic intervention, first of all, I am going to discuss diagnostic, like non-vascular intervention, which include FNAC and aspiration. FNAC and aspiration have a limited role nowadays. Few indications are left for FNAC, like diagnostic and characterization of primary or secondary lesion in a case of a patient with inoperable patient, or like patient with metastatic suspected metastatic disease, to confirm the metastasis in liver. Further indication of FNAC and aspiration are staging of non-primary or obtaining the sample for microbial culture in suspected case of infective etiology. There are very limited contraindication of FNAC. If we have a very deranged coagulation profile, this is the relative contraindication. We can also do the FNAC with the correction of coagulation profile. Advantage of FNAC are area of interest are more representative tissue can be obtained as compared to the blind FNAC, and small lesion can be also targeted. Necrotic tissue can be avoided, and minimal procedural complication are there with the FNAC. We can diagnose the inoperable lesion if a patient presented with the fulminant disease or like metastatic disease, in which diagnosis is sufficient. Diagnosis with FNAC is sufficient. This is the real-time investigation if we do under the ultrasound guidance. However, there are few limitations of FNAC, like it is operator dependent, it's required lot of experience. Sometimes the lesion may not be targeted appropriately, or sometimes we can obtain limited amount of sample which are difficult to commented upon. FNAC can be done under the guidance of CT, ultrasound or fluoro. Fluoro nowadays very limited use of fluoro guided FNAC. We predominantly do the CT and USG guided FNAC. Among the CT and USG is the preferred modality of choice. However, in some cases, the lesion is obscured by the air, or obese patient, or difficult lesion which are not visible on ultrasound, we can do CT guided FNAC. In FNAC, we do the pre-procedure evaluation, taking the consent from the patient, and evaluate the clinical and radiological data and choose the lesion from which we can do FNAC with minimal risk or maximum information. We preferably do FNAC with the 22 to 27 gauge needle. Under the, we select the transducer, whether we required linear transducer or convex curvilinear transducer. There are few hardware we required, like syringe, FNAC needle, slides, local anesthesia, and betadine. This is the example of FNAC in which there is a large lesion in the large lesion in liver with the known case of CA colon. We can see the FNAC needle which is hitting the target, which come out to be metastatic adenocarcinoma. There are post-procedure care. There is no post-procedure care as such is required. Compression of the local site is sufficient, and for pain we can give the SOS painkiller, which is sufficient. Next investigation is biopsy. For biopsy, we must localize the lesion beforehand. Like before we decide the biopsy, we should have the appropriate investigation like ultrasound, CT scan or PET scan, anything which required to planning the biopsy. After that, we have to decide the correct instrumentation, like कि how long needle we required, हमें कितना gauge की needle चाहिए या कितनी length की needle चाहिए to hit the target and take the appropriate sample. After that, we decide the technique. In technique, we can decide, we should choose between the ultrasound and CT guided biopsy, which is the better modality. Preferably, we do the ultrasound guided biopsy because it is a real-time investigation with the minimal complication, and we can avoid the vascular injury. In some cases, it is difficult to do the ultrasound guided biopsy like lung biopsy or lesion which are deep-seated or which are not clearly visible on ultrasound. There are few contraindications we are going to discuss for biopsy. Now, how to localize the lesion? First, we should now, as I told you, fluoroscopy guided biopsy are also obsoleted. We should localize the lesion either ultrasound guided or computer CT guided. Ultrasound guided is the preferred method because it is a real time है और इसमें हम पेशेंट को मिनिमल कॉम्प्लिकेशन के साथ पेशेंट को कमांड भी दे सकते हैं और हम रियल टाइम में बायोप्सी कर सकते हैं. कंप्यूटेड टोमोग्राफी में लिमिटेड इंडिकेशन है जहाँ पे हमें अल्ट्रासाउंड गाइडेड बायोप्सी नहीं कर पा रहे हैं, ओबेस पेशेंट है, गैसी स्ट्रक्चर है इंटरवीनिंग, तो हम सीटी गाइडेड बायोप्सी करते हैं. सीटी गाइडेड बायोप्सी के लिमिटेड इंडिकेशन है. इसके डिसएडवांटेज ये है कि दिस इज़ नॉट ए रियल टाइम. यहाँ पर हम मार्कर स्किन पे प्लेस करते हैं और प्लान करते हैं कि किस एरिया से हमें बायोप्सी करनी है. उसके बाद हम पंचर साइट पे राइट और लेफ्ट का लोकलाइजेशन करते हैं. इंस्ट्रूमेंट हम क्या यूज़ करते हैं? कोएक्सियल बायोप्सी गन वी यूजुअली प्रेफर इन विच 20 वेरियस साइज ऑफ biopsy gun are available like 23 to 16 gauge. We usually prefer 18 gauge biopsy needle with coaxial gun, in which we use 10 to 15 centimeter length coaxial gun and we do the biopsy with the help of coaxial gun. Advantage of coaxial biopsy gun is we can do multiple sampling. Nowadays we required IHC staining, NGS staining, NGS वगैरह, तो इसलिए हमें multiple sample चाहिए होते हैं, तो we are doing with the help of coaxial biopsy gun. Automated biopsy gun we can use, but it is a limited indication. In this automated biopsy gun, we have to take repeated puncture to take the biopsy. Before going for the biopsy, we should prepare the patient, in which we should decide the patient should be outpatient or inpatient. During the liver biopsy, we never do the patient on outpatient basis. We always admit the patient beforehand and we do some basic tests like coagulation profile, viral marker, and we keep the patient fasting. And we give the pre-medication if patient is apprehensive, or after that we take the informed consent of the patient. During the procedure, we clean the patient with the isopropyl alcohol and betadine, and after that we inject the local anesthesia at the site of biopsy, and we position the patient according to the targeted site, and we do the biopsy afterward. These are the biopsy hardware we do. This is the coaxial biopsy gun, which have two with the help of this we can take two size of sample, 10 mm or 20 mm. This is the cutting notch, which is zoom. After that, contraindication for biopsy are severely deranged coagulation profile like deranged PT-INR, bleeding diathesis, or patient uncooperation are the main contraindication. In some patient with the deranged coagulation profile, which is very common in the chronic liver disease, we can do vascular biopsy like TJLB, transjugular liver biopsy. In this transjugular liver biopsy, we pass the biopsy needle through the transjugular route and take the biopsy from the liver with limited complication. In this, we do not puncture the liver capsule, so chances of bleeding risk are very less. In this technique, we puncture the right jugular vein and catheterize it, and catheter is passed into the hepatic vein, through which a long biopsy needle is passed down into the catheter up to the tip. After this, we rotate the catheter and the needle is advanced through the hepatic vein into the liver parenchyma and biopsy has taken. This is the graphical representation of transjugular liver biopsy. This is the graphical representation of transjugular liver biopsy, and this is the transjugular liver biopsy instrument. This is the another example of transjugular liver biopsy. After that, we are going to discuss the therapeutic intervention in the hepatic diseases. First of all, I am going to discuss non-vascular intervention like pigtail aspiration, tumor ablation, and PAIR. In pigtail, we do the pigtailing in most commonly in the liver collection like liver abscess. In this, there are few indication for pigtailing of liver abscess. Like if lesion is more than 10 centimeter, if liver is impending rupture and presented with the peritoneal sign, and left lobe lever is usually always drained with the pigtail catheter because can be rupture into the pericardium, or they are very prone to rupture in the peritoneum also. Before doing the hepatic abscess pigtailing, we do some patient preparation like PT, INR, CBC and blood grouping. We also correct the bleeding diathesis if patient is having deranged coagulation profile and keep the patient NPO for 4 to 6 hours. Hepatic abscess aspiration has a limited role because it has a certain disadvantage because in a single aspiration there is very large chances to complete aspiration of the pus from the liver. So it's required repeated aspiration. That's why we prefer to do the pigtailing. It is required only in few instances, like if a small loculi is remain after the previous intervention, or we required only organism for culture and sensitivity. In hepatic abscess, multiloculation is not a contraindication. Single or multiple catheter can be inserted into multiloculated abscess, or it can be loculi can be broken at the time of intervention. Few contraindication like same any hepatobiliary intervention like uncontrolled bleeding diathesis and lack of drainage route, like if there is a vascular structure coming in between the liver abscess and drainage path, or if the lung parenchyma is nearby, which can be traumatized at the time of intervention, and if there is inability to aspirate more than diagnostic sample. Technique, we are using ultrasound guided and CT guided drainage. We prefer, as I told you, we prefer the ultrasound guided drainage because it is a real time modality. There are two techniques of drainage of pigtail liver abscess. First is single time puncture with the trocar technique, and second is Seldinger technique. In trocar technique, we insert a single drainage catheter mounted on a stiff metal cannula with pointed styliate needle. The assembly is inserted under the image guidance into the abscess cavity, and catheter is disconnected from the metal cannula and styliate needle, and catheter is pushed further into the cavity and secure with the suture or fixation device. This is the diagrammatic representation in which the catheter mounted on the styliate and guided needle is inserted into the liver cavity, and gradually the styliate is withdrawn and catheter is placed in the liver cavity, and after that we will fix the catheter and connect with the urobag. In the Seldinger technique, it is usually done in the difficult liver abscess like caudate lobe abscess or abscess in the difficult position which is surrounded by a vascular structure. In this technique, we first insert the needle like 18 gauge trocar styliate needle. After that, we remove the styliate from the needle and we insert the guide wire within the puncture needle, and after that we dilate the tract with the appropriate dilator for the pigtail catheter, and after this we insert the catheter on the guide wire. This is the diagrammatic representation of the abscess drainage by Seldinger technique. In this technique, we first insert the needle into the drainage insert the needle into the abscess. After that, we pass the guide wire within the abscess, and we remove the Seldinger needle, on which we pass the multiple size dilator and dilate the tract, and after that we insert the cannula within the abscess and we remove the guide wire at the end. When to remove the drainage catheter, we have a certain indication when to remove the drainage catheter. If the drainage catheter is malposition, we can remove at any time. Otherwise, we usually remove the drainage catheter if output is less than 10 to 15 ml for 24 hours, and we can do the check ultrasound or CT scan to see the residual abscess. There are few examples of CT guided abscess drainage. We can see a large abscess in which the catheter is placed. There is another example of a peripancreatic pseudocyst in which the drainage catheter was inserted with the help of Seldinger technique. Now we go for a tumor ablation. Tumor ablation is the technique to burn out the tumor in some cases of liver tumor like liver abscess, oligomats, and other metastatic disease. We can do the tumor ablation with the three methods, predominantly by RFA, microablation, and cryoablation. RFA is most commonly used technology. The basic principle of radio frequency ablation is generation of heat and necrose the tumor tissue. And in cryoablation, we generate the cold energy and ablate the tissue and causing by the mechanism of cell injury. In the in the thermal ablation, there are two predominant methods: is radio frequency ablation and microwave ablation. The principle of radio frequency ablation is we apply the alternate electric current which oscillate the tissue ion and generate the friction heat, which causing the cell injury and causes the cell death of the tumor tissue. This is the graphical representation of a radio frequency ablation, in which the electrode is inserted into the target tissue and heat is generated, which ultimately causing the cell injury and tumor ablation. Limitation of radio frequency ablation is there is a due to the quick charring of the tissue, there is increased resistance which open the circuit and limit the ablation zone, so the viable tissue can be remain at the periphery of lesion. It's a depend on the thermal conductivity of tissue. If the tissue is very poor conductor of electric energy, in that case the ablation is very less. Third limitation is heat sink effect. If the tumor is very close to the flowing blood vessel, the blood vessel will cool down the tissue and limited the effectiveness of radio frequency ablation. Fourth disadvantage is ground pad is required for the monopolar system, which can close the circuit. May require slow and lengthy treatment and too effective kill treatment. Microwave ablation is work on the principle of electromagnetic field application. In this, the electromagnetic field oscillates the water molecule in the tissue. By the oscillation, they generate the friction energy and causing the ablation of tumor tissue. This is the instrument which is showing the microablation machine. Advantage of microablation over the radio frequency ablation is it is a faster technology. It is typically required 2 to 8 minutes with high powered system and create a much larger ablation zone as compared to the radio frequency ablation. It generates higher temperature without limitation related to the electric impedance. It is less sensitive to the tissue type, whether it is electric conductive or not, and relative insensitive to the heat sink effect. This is the comparative table of the radio frequency ablation and microwave ablation, which I have already discussed. Third is cryoablation. In this, a probe is inserted into the tumor and a gas like argon gas passes through with the probe, which is expanded rapidly within the tumor and drop the surrounding temperature, which causes direct membrane injury or osmotic dehydration of the tissue, as well as vascular damage of the tissue, which result in tumor death and tumor necrosis. In this, the process consists of alternate freezing and thawing of tissue, commonly 10 minutes and 8 minutes, a multifaceted cellular death mode, which we have already discussed, cell membrane disruption, apoptosis, cell dehydration, and vascular injury. Predominantly used gas for cryoablation are argon gas or nitrogen gas. Advantage of cryoablation is it is well tolerated, minimal pain, and it is preferably over RFA and microwave in renal tumor, and it causes ice ball phenomena, which is readily visualized on ultrasound as well as CT, so the ablation margin can be limited at the time of procedure. Disadvantage of cryoablation is it is very expensive and required gas availability and storage. Ablation time is much longer than microwave and radio frequency ablation. Tumor ablation indications are in liver, very early and early stage hepatocellular carcinoma, we can do tumor ablation like Barcelona Clinic liver classification system. We can do very early stage performance scale 0, early stage tumor, intermediate stage tumor, and advanced stage tumor. We can not do tumor ablation. Non-surgical patient with oligomats, we can do oligomats with the to the liver. We also can do the tumor ablation with the disease-free survival for long period. Pre-procedure assessment, same the pre-procedure assessment, we should do the pre-procedure CT, PET CT or ultrasound to plan the treatment and hold the anticoagulant if patient is on anticoagulant or antiplatelet medication, and see the blood picture to correct the any bleeding diathesis. Pacemaker, if pacemaker is there, it is recommended that pacemaker device should be deactivated before the ablation. During procedure, moderate sedation is required because procedure is painful. So we do the pre-anesthetic checkup, and local anesthesia can be given at the puncture site, and after that the probe is inserted at the targeted site with the help of ultrasound or CT guidance, and ablation was done after that. Ablation can be done after that. Ablation margin should be more than 1 centimeter more than 1 centimeter with the actual tumor margin. This is the example of tumor ablation of liver mets. This is the tumor which is was ablated with the help of a radiofrequency ablation under the guidance of USG. See, the margin is more than the actual size of tumor, so that chances of tumor recurrence is very less. This is the another example of radiofrequency ablation of CT guidance. This is the probe inserted into the liver tumor, which was post procedure. This is the image of post procedure, in which we can see the subtle hyperdensity, which is suggestive of hemorrhage, and hypodensity surrounding the lesion, which is suggestive of tumor margin, ablation margin. This is the another example of radiofrequency ablation. This is the lesion which is very close to the IVC. This is the PET scan showing very good uptake of the lesion, and radiofrequency ablation was done with the help of a probe, and after the follow-up we can see there is no lesion. Lesion is replaced by the hypodense tissue, which without any enhancement, and on follow-up PET CT there is no uptake of FDG. Post-procedure management, immediately post-procedure CT is usually not required, but in some time we require the post-procedure CT if we suspecting some complication like pulmonary hemorrhage, pneumothorax, or intrahepatic hemorrhage. Same day discharge can be done, or discharge can be done on very next day after the evaluating the patient. Bed rest is required for 1 to 2 days, and vital monitoring is strictly required. Pain control can be done with the simple analgesic or intramuscular analgesic. For evaluation of tumor response, we do the check CT after 6 weeks, in between 4 to 8 weeks, in which we see the tumor margin. If we see the non-enhancing area at the site of tumor, or only peripherally rim enhancement, which is without any nodularity or thickness, we consider it is a very good response. If the enhancing rim is very irregular and thickened or nodular, we should suspect the residual tumor. This is the example of follow-up. This is the tumor. This is the post-ablation follow-up CT after 6 weeks, which showed the very smooth peripheral rim enhancement, which was disappear after the 6 month, which was disappear at the 6 month follow-up. Complication of radiofrequency ablation are life-threatening hemorrhage, immediate peri-procedural complication hai, and pain, and in case of the lung metastasis, it can hemopsis and pneumothorax can be happen. Delayed complication of radiofrequency ablation are pneumonia, abscess formation, tumor tract shedding, and in case of liver tumor ablation, biliary stricture, abscess formation, and tumor tract shedding can be happen. Other complication of ablation are systemic inflammatory response occurring 2 to 10 days after ablation procedure. Self-limiting fever, myalgia, and fatigue can be happen, which is very well respond to the antipyretic. Now we going for the pair. Pair is the full form of puncture, aspiration, injection, and re-aspiration. This is done in hepatic hydrated cyst. This is the graphical representation of a pair, in which first we puncture the cyst, then we aspirate the cyst, and then we inject the scolicidal, and after that we re-aspirate the fluid. The indication for pear is good for the hepatic hydrated in case of the hydrated cyst is larger than 4 centimeter, and if it is unilocular and there is no biliary communication. Biliary communication is a contraindication for pear procedure because it can cause biliary stricture. Other relative indication for pear is if the cyst is an accessible site for surgery in a high risk patient with comorbid disease, and it is a relapse after surgery, or it is failed to the drug therapy. Pear is not good in if the cyst is less than 4 centimeter, cyst with honeycombing, solid matrix or calcification or rupture cyst, and if the cyst is located superficially because it can cause peritoneal hydatosis, or it can cause anaphylactic reaction if the cyst is punctured during the procedure. Main commonly used scolicidal agents are hypertonic saline, alcohol, and povidone iodine. And this is the case of the pear in which first we puncture the cyst, we aspirate the cyst, and after that we inject the scolicidal, and we re-aspirate the fluid. This is the follow-up case. In the 0 day, this is the first picture after the procedure, and within a month the membrane is detached from the exocyst, and in the 5-month follow-up the cyst is almost completely disappear. After that, I am going to discuss the vascular intervention of hepatic liver lesions. In vascular intervention, predominantly 2 type of intervention is there. First is vascular intervention for liver tumor, in which we can discuss the vascular tumor under 2 headings: transarterial chemoembolization of tumor and transarterial radioembolization. In the case, the basic principle is we inject the tumor tissue with the help of the intraarterial catheter with the chemotherapy, and after that we plug the feeding artery with the help of embolizing agent, and the chemotherapeutic agent act at the tumor, and it cause cell injury and tumor reduction. TACE is mainstay of therapy of unresectable SCC. TACE is a local intraarterial delivery of chemotherapeutic agent followed by embolization of feeding artery, which I already told. Commonly used chemotherapeutic agent are adriamycin, mitomycin C, and cisplatin. Technique of TACE, we do in the TACE, celiac and mesenteric arteriogram are performed to see the vascular anatomy and feeding artery of tumor. After that, catheter is selectively placed in the feeding artery, and chemotherapeutic agent mixed with the lipoidol is injected directly into the feeding artery. After that, the feeding artery is embolized using the gelating sponge. Tumor is in the TACE, tumor is embolized with the intraarterial embolizing material in a single or multiple session. Proved to be less effective palliative treatment, especially for large and peripherally located HCC due to development of collateral circulation. Transcatheter arterial embolization of tumor may be done as an emergency procedure in some cases of bleeding liver tumor. Predominantly, TACE is done in the intermediate grade hepatic tumor, as well as patient waiting for the liver transplant, or only the patient with inoperable tumor for a palliative intention only. This is the example of TACE in which we can see the selective arteriogram. There is a tumor blush is seen, which is dark or black in color. After the TACE, the tumor is gradually reduced in the size. In D image, we can see there is a very less tumor blush. Tear is the basic principle of tear is same as the TACE. In this, instead of giving the chemotherapeutic agent, we give the radioisotope within the tumor. Preferable isotope are iodine 131 plus lipoidol or yttrium 90. In tear, result of many studies have shown that TART or tear are same to be safe, effective, and promising therapeutic option in patient with inoperable HCC. It can be work very well in patient with the portal vein tumor thrombosis or patient with decompensated liver disease with hepatocellular carcinoma. Now I'm going to discuss in brief the vascular intervention like in the pathology like Budd-Chiari syndrome and portal hypertension. In Budd-Chiari syndrome, we do the transjugular intrahepatic portosystemic shunt and balloon angioplasty for hepatic vein and IVC. In TIPS, it is artificial flow-resistant intrahepatic shunt between the portal vein and hepatic vein. TIP reduce the portal pressure and hence reduce the complication related to the portal hypertension such as varicose bleeding, ascites and hydrothorax. This is the graphical representation in which a catheter is placed within the jugular vein and reaching up to the hepatic vein, and a shunt is placed between the hepatic vein and portal vein. So the artificially created shunt is portosystemic shunt is created. This is the example of test on DSA. This is the shunt we can see which is communicating the portal vein with the hepatic vein. This is the another example of TIPS in which shunt can be seen as a echogenic structure which is communicating the hepatic vein with the portal vein radicle. Indication for TIPS is refractory acute bleeding of esophageal varices, bleeding from gastric varices, refractory ascites due to cirrhosis, and refractory hepatic hydrothorax, Budd-Chiari syndrome, and hepatorenal syndrome. Absolute contraindication for TIPS is right heart failure, severe pulmonary hypertension, uncontrolled systemic infection or sepsis, and unrelieved biliary obstruction or hepatocellular carcinoma involving the hepatic vein. These are the relative contraindication, and this is the table showing the complication of TIPS. Most common and treated complication is hepatic encephalopathy, which is very common, and other few complications are thrombosis, occlusion, hemorrhage, transcapsular puncture, etc. Another intervention in Budd-Chiari syndrome is if there is an obstruction at the level of IVC or hepatic vein, we can dilate the hepatic vein and IVC with the help of balloon angioplasty or hepatic vein stenting. In balloon angioplasty, through the transjugular approach, the guide wire is negotiated through the stenosis and balloon is inflated to relieve the stenosis. This is the example of dilatation of IVC in which the catheter is placed through catheter and guide wire is placed through the stenosis, and after that balloon dilatation is done. Next is biliary intervention in brief. In biliary intervention, we can discuss in under two headings, PTBD and percutaneous cholecystectomy. PTBD can be done in benign as well as malignant biliary obstruction. I am not going to discuss the benign or malignant biliary structure in detail. Key purpose of PTBD is to decompensate the obstructed biliary system, if possible to develop a communication between the biliary tree and bowel which allow the physiological bile flow. PTBD is done, percutaneous drainage is the first step of PTBD, in which the patient bile is diverted to the external environment through the percutaneous approach. In this, the indication for PTC is preoperative procedure for resectable malignancy to decrease the jaundice, and prior to neoadjuvant therapy, because some of the chemotherapy is contraindicated in high bilirubin or as a only palliative technology. It decreases the pain, and jaundice and occurrence of cholangitis is decreased with the help of PTC. Indication for PTBD is high biliary obstruction, failed endoscopic drainage, post-operative cases like biliary obstruction, recurrent malignancy, and multiple segmental stricture. Contraindication for PTBD is same like any other hepatobiliary intervention like bleeding disorder, or relative contraindication are allergy to iodinated contrast or ascites. This is the relative contraindication because PTBD can be done after the drainage of ascites. In the PTBD, first we do the baseline investigation like CECT or MRCP, in which we identify the level of stricture or obstruction and planning accordingly. This is the example of a obstructive biliopathy in which the cause is CA gallbladder, which is infiltrating into the confluence. And this is the another example of biliary obstruction in which the cause is cholangiocarcinoma at the site of confluence. This is the same patient with the cholangiocarcinoma at hilum. Before going to the procedure, we do the USG screening to assess the site of biliary radiation, presence of ascites, patency of biliary confluence. We should do the PTBD. In the case of PT-INR should be less than 1.5. If 1.5, if it is more than 1.5, we do the corrective measure like fresh frozen plasma infusion, and we drain the ascites before going to the procedure. I'm not going to discuss detailed technique. There are few images which are showing the PTBD. This is the confluence stricture in which left side duct was punctured, and check cholangiogram showing there is a dilatation of right and left hepatic duct. First of all, the external drainage was done. After that, the internalization of the catheter was done, which is draining the bile into the intestine. This is the another example of biliary drainage in which there is a separation of confluence. In the second stage, there is internalization of catheter and stenting was done. This is the case of a PTBD in which stenting was done. We can identify the stent with the radiodense marker. This is the linear radiodense marker which is shown as in this case. This is the another case of confluence separation in which both side of stenting was done, right and left sided stenting. There are few complications can be happen during the PTBD. This is the case of a gross hemophilia after PTBD in which all the biliary radical fill with the filling defect. After the check cholangiogram, we can see there is a communication of a biliary radical with the hepatic artery, which is suggestive of vascular communication. This is the another case of complication in which biliary radical communicating with the portal vein. There are few complications of PTBD. In this case, we can see extravasation of contrast into the perihepatic space. This is the another case of PTBD in which the catheter is fractured. There is a breakage of catheter. This is the another example in which the catheter is dislodged outside the CBD. There are few late complications also there like cholangitis, hepatic abscess, septicemia, and drainage catheter or stent blockage. Next is last is percutaneous cholecystectomy. This is the palliative method in which we can place a small catheter within the gallbladder to externally drain the bile from the GB. This can be done with the help of two approach, transhepatic or transperitoneal. We prefer the transhepatic approach because it is provide the cushion between the GB and external environment, and risk of bleeding, risk of biliary peritonitis is very less in this approach. This is the example of percutaneous cholecystostomy. There are the few complications and patient care after biliary intervention. Thank you.
Thank you, Dr. Sachin, for very informative and excellent presentation regarding hepatobiliary intervention as a part of interventional radiology. Now the house is open for any question or suggestion.
The house is open for any question and suggestions.
Sorry? Okay.
जो रेडियोलॉजिस्ट हैं इस समय यूज करने लगे हैं लोग ऑन्कोलॉजी में, तो क्या ये अमीबियासिस वगैरह में वर्क कर सकता है?
नो सर, अमीबियासिस में रेडियो फ्रिक्वेंसी एब्लेशन का रोल नहीं है. इट इज़ ओनली हेल्पफुल इन द सॉलिड ट्यूमर बिकॉज इट्स वर्क ऑन द प्रिंसिपल ऑफ सेल नेक्रोसिस एंड सेल डेथ. And in amoebiasis, there is no such lesion which can be ablated.
And what about the stenting?
Sorry?
Stenting अगर part of the liver failure हो रहा है और उसके side में
stenting tips is the indication for liver failure also, but it can same thing, it can cause the hepatic NCAF.
Thank you.
With the
Thank you.
Good.
Welcoming Honorable Vice Chancellor sir to the event. सर को क्वेश्चन पूछना था.
Yes.
जी. Sir, endoscope.
Now there is a US ultrasound is very commonly used for hepatobiliary as well as another diseases, malignancies, to rule out diagnostic as well as therapeutic intervention nowadays. So what is the role of US?
Definitely, sir. There is a very much overlapping with the US and radiology approach. US is taking over most of the modality like in trans gastric cholecystostomy. They are doing trans gastric biliary drainage as well as very other procedure. But I am not doing US, so I don't have.
As I know, endoscopic ultrasound is more accurate and more safety and more success.
Sir,
as well diagnostic as well as consent the intervention.
Definitely, sir. There are few certain disadvantages there. We require sedation as well as sometimes general anesthesia during the EUS, which is not required during the radiology procedure. First of all, second, it's required lot of expertise, which is now not readily available till now. That's why I'm.
Yes, thank you.
Good morning, sir. Indeed, it was a very elaborative slides. Sir, I have one question regarding FNAC. Sometimes when we get a GB mass, so we order FNAC as a pathological confirmation. But I have seen like most of the time we get very insignificant result or like inconclusive. We repeat also, but again we get the same thing kind of. So what's your take on that, sir?
Sir, actually, this is actually due to if we hit the necrotic tissue predominantly, or it is if we do hitting the lumen, not hitting the target tissue directly. If we take the cell block at the time of FNAC, chances of the positivity is very high. Otherwise, we can take the biopsy if patient is inoperable. Second.
So like, I mean, basically, so should we order it like, I mean, in a small mass or like in a larger mass only we should order it?
Sir, it depends upon indication. If you are planning the surgery, definitely you will go for the surgery first and then get the histopathology report, which is better. If you are thinking the patient is inoperable or you have any confusion in the diagnosis, then we can do the FNAC first. If it is inconclusive, then we go for a biopsy. Biopsy is definitely more chances to getting the positive sample.
So can we go directly to the biopsy there?
It is not indicated directly biopsy.
Okay,
actually.
Thank you.
So,
and sir, one more question
okay.
regarding radiofrequency ablation of the liver metastasis. Till what size cutoff you do the RF?
Sir, we are do the limited number of cases. We are right now we are doing very limited, but it is 3 centimeter is the oligomats, 3 centimeter is the main cutoff.
Thank you.
So we've been working together and we already discussed everything. Telling something about Dr. Sachin, if you are doing complicated surgeries in your institute, Dr. Sachin is the person you want to have in your institute. एक्चुअली तो ये मिनिमम इन्वेजिव रेडियोलॉजिस्ट अगर कोई टर्म होता है तो बॉस वो हैं. मेरा एक आपसे पहली तो शिकायत है, जिस हिसाब से आप काम करते हैं आपने अपनी टीम की फोटोज़ नहीं डाली जिस हिसाब से आप इंटरवेंशन करते हैं, बिकॉज ऑलमोस्ट ऑल इंटरवेंशन दैट यू शोन वी आर डूइंग हियर. माय क्वेश्चन इज टू रिलेट्स टू अ मोर बेसिक थिंग, बिकॉज वी हैव अ लॉट ऑफ पीजीज. हम लोग कई बार जब ओपीडी में बैठते हैं और हमारे पास एब्सेसिस के अल्ट्रासाउंड आते हैं, उसमें देयर इज सम कंसेप्ट ऑफ पार्शियल लिक्विफैक्शन और ऐसी चीज़ें. वेयर अ डिसीजन फॉर पिगटेल ले नहीं ले, इस पे थोड़ा सा गाइड करिए.
फर्स्ट ऑफ ऑल एनी लीवर एब्सिस मोर देन 100 cc should be drained by the catheter only. This is the most common indication. First by the pigtail. Second indication,
थोड़ा सा आपका ये इसी चीज़ पे गाइडेंस चाहिए फॉर द पीजीज.
हाँ. Second indication, if it is impending rupture or already rupture with the limited collection in the perihepatic subcapsular space, or liver abscess within the left lobe of liver which is impending into the rupture in pericardial space or perigastric space, should be drained with the drainage catheter. But sometimes we get the liver abscess which is more than 100 cc but minimal liquefied content. We can wait 2 or 3 days. Ultimately, it has to be drained with the catheter only. No indication for the needle aspiration. Needle aspiration have a very limited role. It is like needle aspiration wale abscess we can also manage with the medicine only.
So the take-home message would be कि even if it is not completely liquefied, better would be to wait for a couple of days, get a repeat ultrasound, and when it liquefies, then put in a pigtail.
Okay. Yes. Definitely.
Any other questions?
So what about the multiloculated abscesses? Like there are multiple
Multiloculated
cavities
abscess.
are there.
Okay, sir, we have done very complicated liver abscess here only. We put a patient with the 10 liver abscess came to us, almost 2 liter abscess in total.
I'm asking, like, say, if the
Single
cavity
abscess
is,
with the
if the cavity is big enough, we can put the drain.
Okay.
But sometimes the patient is very symptomatic and the cavities are very small in size.
Very small.
And like hardly containing 30 ml, 40 ml or like the 50 ml. But there are multiple cavities are there in the liver.
In that case, we can do the needle aspiration and follow up ultrasound. If the cavity persists or increase in size, we can do later on pigtail catheter.
Because I have seen many radiologists putting like number of drains in the same.
We can do if the liver indication ki patient is not responding to antibiotic as well as needle aspiration. We put the patient, एक patient था sir हमारे पास, we put the 6th drain in that patient. He was a chronic alcoholic and not responding to antibiotic as well as aspiration. Culture was repeatedly negative because patient was already on antibiotic. We put 6-7 catheter and ultimately patient survived and went home very well. It depends, sir, individual choice है. It's a not cut off कि ये करना ही है, इसमें नहीं करना. We have to follow the patient on the basis of the ultrasound or repeat modality. Accordingly, we will decide कि what I have is the best measure.
Exactly.
Thank you, sir.
Thank you so much, sir. Now, I will request Dr. Shashank Mishra, sir, to felicitate Dr. Sachin Agrawal, sir. Sir.
I request Dr. Shashank Mishra, sir, to felicitate Dr. Krishnamurthy, sir. I request Dr. Shashank Mishra, sir, to felicitate Dr. Ankit Mishra, sir. Now, after ending with our first radiology session, we'll proceed for the inauguration ceremony of our Subharti Surgery Update 2025. Every educational journey is incomplete without the divine blessing of Goddess Saraswati. Light is a symbol of life and knowledge. It drives away the darkness of ignorance from mind and illuminates it with knowledge. So, to mark the beginning of the auspicious journey, may I request the students to evoke the blessings of divine power with Saraswati Vandana. And I request Honorable Vice Chancellor, Sir, Major General J.K. Thapyal, Sir, and Dr. Satyam Khare, Sir, to proceed for lamp lighting. Dr. H.S. Minhas, Sir, Dr. Sanjay Pandey, sir. Dr. Sanjeev Kumar, sir. Dr. Krishnamurthy, sir. Dr. Rohit Bhatta, sir. Dr. Abhay, sir.
Now, I welcome Dr. Honorable Vice Chancellor Major General J.K. Thapiyal sir and request Dr. M.K. Maheshwari sir to felicitate Honorable Vice Chancellor sir. I welcome Dr. H.S. Minhas sir, Senior Medical Superintendent, Subharti Medical College and Associated Hospital, and will request Dr. Sanjay Pandey sir to felicitate this Minhas sir. I welcome Dr. Sanjeev Kumar sir, Medical Superintendent, Subharti Medical College, and will request Dr. Sashank Mishra sir to come and felicitate Dr. Sanjeev Kumar sir. I welcome Dr. Satyam Khare sir, Principal Subharti Medical College, and request Dr. Maheshwari sir to felicitate sir. I welcome Dr. Krishnamurthy sir, Executive Officer and Head of Emergency Medicine Department of Subharti Medical College, and request Dr. Rohit Bhatta sir to kindly facilitate Honorable Executive Officer.
Where is Bhatta sir?
Now, I request Dr. M.K. Maheshwari sir, Professor and Head of Department of General Surgery, Subharti Medical College, and Organizing Chairman, Subharti Surgery Update 2025. I would request sir to express and give us blessings for the event. Welcome address.
First of all, Jai Hind, everyone. And it is my proud privilege to welcome you all to the Subharti Surgery Update 2025, dedicated to the hepatobiliary surgery. All of you know that learning is a never-ending process, and today we gather as a community committed to revise what we know and to keep up with the recent advances of the specialty. Here at Subharti, our goal has been always to train dozens of residents each year to go out in the world and be efficient and pioneer surgeons, and we try to provide them with necessary skill set to save lives and honor the profession. We are privileged to host some of the leading voices in the field whose work contribute to push boundaries and redefine standards. Inspired by our university motto, that is Gyan, Seva and Sanskar, this conference aims to make our young residents and medical students capable enough to meet the future challenges of life. A special thanks to our organizing committee faculty and partners who made this event possible. At this juncture, I will definitely like to appreciate the efforts of Dr. Sunidhi Mishra, who was very instrumental to organize this CME. Once again, welcome to Subharti Surgery Update 2025. Let's explore, question, learn, and leave here sharpened and more inspired than ever before. Thank you very much, sir.
Thank you so much, sir, for your kind words. Now I request Dr. Satyam Khare, sir, Principal Subharti Medical College and Head of Department of Anatomy, to bless us for the ceremony.
Jai Hind. Honorable Vice Chancellor, sir, EO Dr. Krishnamurthy, eminent speakers from all over the state and various parts of the country, delegates, fellow Subhartians, PG students, and MBBS undergraduate students. I welcome you all in this surgery update. First of all, I would like to congratulate the organizing team and the surgery department for organizing an update on hepatobiliary disease. I must say you all must get some update from this workshop or this event, and all the best for organizers. Thank you.
Thank you so much, sir, for your blessings. Now I request Dr. Krishnamurthy, sir, for the words of blessing.
Good morning, everyone. And I congratulate Department of Surgery on being able to hold this event year after year. And I hope that this continues and it keeps on growing every year. और मेरा last में ये चीज़ है कि I hope everything gets on time because topics are very interesting. It is unlikely कि किसी भी speaker जो है वो अपने time पे ख़त्म कर पाएगा because of the questions. Thank you.
Thank you so much, sir. Now I would request Major General Dr. G.K. Thapiyal, sir, for the blessing of words.
Jai Hind, everyone. Executive Officer, Dr. Krishnamurthy, Vice Principal, Dr. Satyam, Head of the Department, Dr. Maheshwari, and all faculty members, invited guests, distinguished faculty members, and my dear PG students and undergraduate students. I welcome you all on behalf of Swami Vivekananda Subharti University to this CME, which is being organized by Department of Surgery. And this is the consecutive third year they are organizing this, and I congratulate the Department of Surgery for conceiving the idea of having update or continuous medical education program in their department and inviting people from different parts of the country. I believe this update is being attended by faculty members from different colleges. And the theme which they have selected is about the hepatobiliary diseases. It's one of the complex field of surgery they have selected. Initially, when the faculty member came to my office to remind me about this inauguration, I said the program has already started. What is the need of inauguration? Is it required? I also feel that it becomes an interruption when the professional discussions are going on. This kind of inauguration becomes a kind of a formality, but sometimes it is required. There are different views, whether it should be there or it should not be there. But one thing is clear: when we invoke Goddess Saraswati in the beginning of our program. That definitely gives a positive vibration, and that positive vibration helps in acquiring knowledge. And that is also a part of our program. So I thank you very much for having invited me for this inaugural program. One thing I would like to tell you from my side, yesterday I was in Association of Indian Universities program. There are about 50 vice chancellors had come. And this program was organized for a vice chancellor master class. And the topic was the AI, artificial intelligence in education and artificial intelligence in healthcare. There were many speakers who deliberated on this subject, and I was really amazed to know that how artificial intelligence, the data science, blockchain can create revolutionary things in the diagnostics, in the therapeutics, and in the rehabilitation and management of the patients. So my request to you, whenever you have an update and CME like this, integration should also be the part of this, like we are, unless we integrate our knowledge, it will not be a broad knowledge. So we need to integrate our knowledge with artificial intelligence, with the blockchain, with the data science, with the genomics, and the nanotechnology, what is happening in the different areas, particularly in the context of hepatobiliary diseases, how the hepatobiliary diseases, which is actually a very difficult area to diagnose, difficult area for surgery, and even rehabilitation and post-operative care is very difficult. So how we can help from different domain, different areas, that will be helpful. So we must explore, and we must have a collaboration and integrate with other areas like biomedical science, with geneticists, with data scientists. All these knowledge combined together, probably we will have a holistic knowledge about our area. I wish you all the best. This, I'm told that many PG students are attending the conference. It is for them because you are being empowered with this knowledge. And this knowledge is going to benefit you, and you are going to benefit the society by getting this knowledge. So I wish you all the best. Thank you. Jai Hind.
Ending with inauguration, I request Dr. Rohit Bhatta sir for vote of thanks.
Good morning, सबको मेरा नमस्कार. This CME is the result of a collective efforts of a lot of people, and it's my pleasure to deliver the vote of thanks here. First and foremost, I want to express our deepest gratitude to our respected Vice Chancellor, Professor G.K. Thapliyal sir, for accepting our invitation and sharing your insights. My sincere gratitude to the management of Subharti Medical College for financial and logistic help. Sincere gratitude to Professor Satyam Khare sir, Vice Principal, Subharti Medical College, and Professor S.S. Minhas sir, Senior Medical Superintendent, Subharti Hospital. Sir, your presence has made this event auspicious. Thanks goes to Executive Officer and CME Advisor, Professor Krishnamurthy sir, for his continuous guidance and encouragement for the event. I thank our Head of Department, Professor Mukesh Maheshwari sir, and our Senior Professor, Dr. Sanjay Pandey sir, for their invaluable guidance in making this event a resounding success. I thank all our senior faculty, colleagues, and our residents for the day and night effort. Your hard work and dedication are deeply appreciated. Special thank goes to Dr. Sunidhi Misra, our senior resident, for her ultimate dedication and hard work for this successful event. I thank all the distinguished speakers, chairpersons, and guests for accepting our invitation and coming all the way from different faraway cities. I thank to all for your wonderful packet of knowledge you are going to share us in this event for our audience. I thank all the head of departments and faculties, Subharti Medical College, for their graceful presence. I thank all the delegates for attending this CME and making this event successful. Your participation and enthusiasm has made this event truly special. Special thanks goes to our CME supporters, our pharmaceutical partners, Biogenesis Mediventure Private Limited, Coloplast India Private Limited, Infar India Private Limited, and Maxim Pharmaceuticals Private Limited for their valuable essential financial support. List is never complete and perfect. Lastly, but not the least, my sincere thanks to all the staff and volunteers who have been working behind the scene to ensure everything runs smoothly. Thank you all for your support. We hope you will enjoy the day. Thank you everyone.
Thank you everyone. Now we'll proceed for the breakfast and we'll be back after breakfast in 20 minutes for the next sessions to start.
Department of Surgery, Himalayan Institute of Medical Sciences, Delhi.
Good afternoon. First of all, I would like to thank Maheshwari sir and the organizing team for giving me this opportunity to present a talk on safe laparoscopic cholecystectomy tips and tricks. This is one of the most common procedures done by the general surgeons and the laparoscopic surgeons or even maybe the GI surgeons. Considered in the media and the public by a simple procedure most commonly done. But the morbidity and mortality I will not say high, but morbidity is very high if there is a complication in the cholecystectomy. The rates have been brought down from 5 to 10% in last 2-3 decades. Present data shows that still there is a 0.5 to 1.5% incidence of CBD injury, which complication which a surgeon fears. So, what are the tips and tricks? Though they were mentioned by the stalwarts 2 decades ago, but still not picked by the surgeons, and I will be re-emphasizing on those tips and tricks and how to do a safe cholecystectomy laparoscopically. So there are 10 commandments, you can say, 10 steps which you should know, and on the basis of which I will be discussing how you can do a safe laparoscopic cholecystectomy. First thing is this. This is the area, that is the Carrot triangle area which we say, is one of the areas in the human anatomy which has maximum number of aberrations or the normal deviation from the anatomy. So the area which will have more deviations, more congenital anomalies is bound to have more complications due to failure of these recognition of these anomalies in that area. So thorough knowledge of anatomy is very important before embarking on laparoscopic cholecystectomy procedures, and understanding the mechanism, how this variant anatomy or a difference in anatomy leads to these complications. Another factor is that in this surgery we often encounter a frozen area where we are operating, that is frozen Carrot triangle, and it adds to the complications further apart from the aberrations in the normal anatomy. Identification of various preoperative and intraoperative predictors. There are predictors that this could be a difficult case and you should be prepared to take these measures. So able to identify them starts from the preoperative workup so that you are well prepared to tackle the difficult case. Safe access into the peritoneal cavity is the first step, because we often see patients with cesarean sections, laparotomy or indications for other reasons where there are incisions in the abdomen. So safe access is the first step. Most of the time or many times we see patients will refuse the laparoscopic surgery that you have multiple incisions on the abdomen. So this is not possible. Yes, it is right, it is a relative contraindication, but if you are well versed with the steps which you have to take, you can still do in most of these patients laparoscopic procedures. And the one thing is critical view of safety. This was given around 25 years back by the Stephen Strasberg, who defined the CBD injury, especially in the laparoscopic era. Because as soon as after 1996, laparoscopic cholecystectomy started replacing the open cholecystectomy worldwide, there was sudden increase in the incidence of complications, especially CBD injuries. So he gave this concept, which was not got popularized, or the surgeons ignored his advice, and we continue to have high incidence of CBD injuries. So I will be stressing on this concept, and the next version of this concept is R for U line. I will be stressing on it, not as included in the textbooks also. Maybe the latest edition has a detailed description on this thing, so that we are able to decrease the incidence of morbidity and mortality. And there are some error traps. We often have heard from our teachers that it is a difficult gallbladder in the open cholecystectomy, do the fundus approach first. It is a safe approach. There is lot of literature that it is not a safe approach. Because ultimately you have to do the dissection in the Carot's triangle. Just feeling that you are away from the carrot, you are starting from the distal end of the surgery does not make it a safe surgery. So there are steps where you can still dissect the Carot's triangle or take the precautions, and this fundus first approach is difficult in the laparoscopic procedure. So it is not a standard of care that in a difficult laparoscopic or cystectomy or anticipated case, you start with the fundus first approach. Or there is one infundibular approach where you diagnose the cystic duct and the junction of the neck of the gallbladder as funneling, and you take it that this is the neck region and here I can go safely. It may also lead you into a trap of doing a CBD. Then the use of bailout strategies, what you should do if you are stuck up in a case, half done, and what are the bailout steps. And then there are some recent advances, few things are for last so many years, that is intraoperative cholangiogram. So I will just say, laparoscopic intraoperative cholangiogram is not an easy thing to do, especially when you are doing it on a non-dilated CBD. Because you are operating a case of polylithiasis, so CBD is normal. So if there is an injury on that, or there is a suspicion of identifying the CBD or the CHD, it is not an easy thing. Though it is written in the textbook, IOP is a very good thing. Only a surgeon who is doing regularly cholecystectomies or regular intraoperative cholangiogram will be able to do that procedure during the surgery when already you are tense due to difficult movements. So it has been now recently replaced by the endocyanine green dye contrast technology, and the future will be the artificial intelligence. So the last two steps are very important. Is concept of timeout. We have seen it in the sports, whether things are not going fine for a team. In the football team, the cricket team, they take a timeout. They huddle together, then replan their strategy. Right? So same thing should be done when you are stuck up in the laparoscopic procedure on any surgery. You should relook, you should discuss with the team, reassess the situation, then proceed again. Does not mean you are abandoning the procedure, but you have to reassess and discuss with the team members what should be done. So this concept is known as time out concept. I will discuss in the video also, and wisdom of converting to open. It is rightly said in the textbook that converting a laparoscopic case to open procedure is not a failure of a surgeon. It is a wise decision in interest of the patient. So many surgeons, senior surgeons, they think if I convert, residents are watching, junior surgeon is watching, they will think that I have failed in the procedure. It is not a failure of a surgeon. It is a success of a surgeon to complete the procedure safely by the open approach. So as I said, there is cystic duct variations in this region, and around 70% of the patients have normal cystic duct anatomy, that is the A. In rest of the cases, we see the cystic duct densely adhering and is parallel to the common hepatic duct. Cystic duct arising from the junction of the right and left hepatic duct. Cystic duct directly draining into the right hepatic duct. So these lot of variations are there, and they can lead to confusion. But if you know that these are the variations which I may encounter in a particular case, these can be detected in a MRCP. But we don't go for MRCP, and still it is not recommended in each and every case of cholecystectomy. So MRCP can give you this hint that there is this anomalous junction between the cystic duct and the CVD. So during the surgery, you have this in mind, because we say if something is in mind, then only your eyes will be able to see. So if you know this is structure, it is different, the location is not appropriate, this would be this. So this perception, known as mental model of a surgeon experience skills, acquiring the skills, is very, very important. That is becoming suspicious during the surgery. This could be this possibility, and this will lead to decrease in the incidence of the complications. So this is a very common anatomy for my residents or for young colleagues. We know, but it is not as simple as it is, because we have to explore this anatomy during the surgery. This is not a triangle, Carot's triangle. We frequently hear Carot's triangle, do this, and the surgery will be done. It will be simple. This is not a triangle. You have to create this triangle by tractions, right? And this triangle was originally, Carot's triangle was originally given by the resident it was his thesis topic to decrease the complication rates in the cholecystectomy, open cholecystectomy. And in this thesis, he presented to his mentor that, sir, if we identify this triangle, we can decrease the injury rate, and later on he became a famous orthopedic surgeon. He didn't continue in the general surgery, that is a different story. So, but the Carot's triangle which he said, the cystic artery was the boundary of the Carot's triangle. One boundary was cystic duct, another was the common hepatic duct, and another was the cystic artery, which has now been changed to hepatocystic triangle. So hepatocystic triangle, now we have a cystic artery is the content of the triangle rather than the boundary of the triangle. So because hepatocystic triangle is a more appropriate identification mark during the surgery, frequently we use Carot's triangle and hepatocystic triangle as interchangeable terms because the concept was first given by the Carot's, but in a true sense, hepatocystic triangle is different from the Carot's triangle, and anatomy triangle, this identification of this triangle is more important rather than the Carot's triangle. Another anomaly is the vessel. There are vessel injuries which leads to bleeding, which leads to complication, and the delayed stricture formation in the common hepatic duct also. So again, Moynihan is present in around 10 to 15% of the patients, where the right hepatic duct comes into your dissection area and then it goes back into the liver, and mistaking it for a cystic artery is a common mistake. But fortunately for the surgeon, if you clip this artery, there is no bleeding, it goes unnoticed. Because the liver is supplied by the left hepatic artery and mainly by the portal veins, 70% of blood supply. So what happens in the patient that he may come to you with a deranged liver function test, even with a normal liver function test, or he may present you with a liver abscess. Because ligation or clipping of this artery without knowing it can lead to infarct of the right segments of the liver, which will get infected, may get infected, and liver abscess can be the presentation in the post-op period. So identification is again important because once you have cut, though the textbook says it should be repaired, I don't know how many surgeons have repaired if the right hepatic artery is cut. They simply clip it and go with the surgery, and because the detection rate will be very low whether you have injured this artery or not. So what are the other variations apart from the Moynihan sum, that in the 5 to 12% of the patients we have replaced right hepatic artery. Right hepatic artery is a branch of common hepatic artery where it divides into right and left, but sometimes it originates from the superior mesenteric artery. So what happens, instead of coming from the medial side of the triangle, this artery travels parallel to the common hepatic duct and the CBD. And it creates a confusion with the CBD and the artery, and there are more probability of injuring this artery or even the quaternary injury to this artery. Regarding the left hepatic artery, which usually does not come into our dissection area, rarely it happens, it may arise not from the right common hepatic artery, it may arise from the left gastric artery. So these are the steps I will show you in the video. So the preparation for the safe cholecystectomy starts in the pre-operative period. That is, you must assess whether this case is going to be difficult or it is a routine laparoscopic cholecystectomy case. So from the history there are indicators. Like male patients we have seen have a difficult gallbladder, aged more than 65 years, repeated episodes of acute cholecystitis, repeated episodes of biliary colic. The patient may give you a history, I am having a stone for last 10 years, but often I get a pain, I take the medication, it's okay. So long history of polylithiasis, large stone there, these are the indicators that your lap poly could become a difficult lap poly during the surgery. Then there are physical markers that patient is having repeated episodes of fever, raised ASA, morbid obesity, raised CRP protein levels. So, but they can vary. In spite of sometimes these markers are there, lap poly's are simple, but probability is that they will be difficult. Other markers, most important markers to get are in the ultrasound. If in the ultrasound you see a large CBD stone, more than 1.5 centimeters, at the middle of the report it is stuck up at the neck, your surgery is going to be difficult due to chronic inflammation, long-standing inflammation. The gallbladder will become adherent to the common hepatic duct. There could be Meningitis type 1, even if there is no type 2, type 3 in that case. So Meningitis type 1 is very difficult to dissect in that area. So large stones stuck up at the neck is another indicator that your surgery will be difficult. thick wall gallbladder, shrunken gallbladder, cirrhotic liver. These are the ultrasound findings which should alert you that I am going to have a difficult case today. Then what you should do, if you have a prediction that this could be difficult case, so adequate instrumentation. You should be alert your team that I may require bipolar quadri, I may require a needle holder for the suturing. So prepare the team rather than when you are stuck up and then you are asking for the instrument and brother is saying or the staff is saying, let me bring from the another OT. You are already tense and then the situation is created. If you are prepared, I may require this. If it is not required, very good. If it is required, you are prepared. Mentally, your team is prepared. Second is never take a junior resident or a junior colleague you can take. Usually first year they show the camera, many times second year, third year. So in this predicted difficult case, take a senior resident or at least the third year, so they can show you properly the angles, different angles for that thing. Otherwise you get frustrated during the difficult surgery and you mess up with the whole thing. Senior camera assistant is the most important thing because you depend in the laparoscopic surgery on the angle shown by your camera assistant. If your camera assistant is not good, whatever are your skills, whatever is your seniority, you are going to mess up the thing because he will not be able to understand what you want to see. So please take a senior person, either your junior colleague, even your parallel colleague. And second is the second opinion. Keep the, for the junior please inform your senior consultant, unit head, that I am going to have a difficult case, please be there. If I require, I will call you. Rather than getting stuck up doing the injury and then looking for the senior who is already doing some difficult case or is away for some meeting or out of the operation theatre. And continuous interaction with the anesthetist. This is also very important because if you have a ASA grade 3 or 4 case, you may take a longer time to complete the case. It may go for 3 hours, even 3.5 hours, but the anesthesia risk is increasing for the patient because in ASA 3 and 4 grade patients, the longer is the duration of the surgery, higher is the complication rate and anesthesia complication. So in between, if you are proceeding in the right direction, you should interact with the anesthetist whether patient is stable or not. Shall I continue laparoscopically or shall I convert it to an open case so that I can finish it fast? So what is the critical view of safety? It is not a technique, which was proposed by Salzburg roughly 25 years back, in 1998, I suppose. And he said that you have to do anterior dissection and the posterior dissection. Before that, it was the concept of only anterior dissection in the callus triangle. And when he was studying on the type of injuries, CBD injuries, he devised this method that there could be posterior dissection can be added to it to make it more safe. So it is not a technique, it is basically a deliberate attempt to identify the structure and have a view where you can see through windows, through the structure that is cystic duct in the artery, and you could see the inferior surface of the liver. It means that you have done an adequate dissection and now you can go for clipping of the vessel or the cystic duct. This is the latest thing. I don't know how many residents and our young police know this is in the textbooks. This is the extension of the critical view of safety. People ignored critical view of safety, so surgeons came out with the concept that we should have a checklist. Whether we are adequately maintaining the principles of critical view of safety. So it is these safe anatomical landmarks, and it is said that you repeatedly check these landmarks during the surgery. Before starting the surgery, during the dissection, after completing the dissection, before clipping, again go for checklist of these landmarks. This diagram is given in Bailey Love also, very beautiful diagram. That is B stands for the bile duct and segment 4. That is, once you put the camera, you should assess what you are able to see. First step should be that, not that your assistant takes you directly to the callus triangle and you start the surgery. So it is B stands for the bile duct and the segment 4 of the liver. S stands for Rouvier circles. Strasberg initially didn't define the Rouvier circle. This is a very, very important landmark for a safe laparoscopic cholecystectomy, which is present in roughly 75 to 80% of the patients. In 20% of the patients, you have a very shallow sulcus or absent sulcus. So in that case, you have to imagine this line. Otherwise, this is a very good landmark, and in this landmark, behind this is a right portal vein and the posterior segment of the portal vein, and sometimes right hepatic artery also lies in this sulcus. So line starting from this sulcus and crossing the, it is going, that is R for U, that is rubeus sulcus, and it crosses to the umbilical fissure. So if you join this line, aim is to keep your dissection above this line. If you go below this line, you are going, the chances of injuring CBD or causing a severe hemorrhage or these type of complications. And F is your fissure umbilical fissure, and E is your entry structures, that is duodenum and these antrum, sometimes even transverse colon is also adhere there in difficult cases. So if you maintain and keep this figure in mind, I will tell you repeatedly, I am practicing this concept for last 3 years, and it gives you so much confidence in the difficult surgery. Repeatedly assess whether I am operating above this R for U line or not. It will save you complications drastically. So be safe principle is, to be safe, use time out. This is a very important concept. As I said, in sports you see cricketers, football players, they huddle up, plan there. So this concept came because when you're doing focus on a thing, you're doing a particular surgery, and you always want more zoom in, show me the structures in the lab. You lose the vision of the outside area. And your mind is stuck up, it becomes telescopic. Because you have something in mind, you are only focusing on these structures, and this leads to the accident. So time out means you ask your assistant to pull the camera back to show you the surrounding area also. To reassess whether what I am doing is right or not. You just imagine you are at the road, you see there are a lot of people in the park, few cars are parked here, parked there, and now you go to the second floor of the building, now you see from above. You see that few cars are here, fast car is coming from there, there is more density of people in this particular area. So it enhances your view. So this concept has come time out concept. Bring the camera back, reassess, then proceed again. And Dr. Prameet Bhatia, he repeatedly says this: more safety, more safety. So try to be as safe as possible, because once this CBD injury, we all know what is the mental state of the surgeon is. So, number of ports. You must have heard the standard prescribed is 4-port cholecystectomy. There is some people who do 3-port cholecystectomy, and some people have even done SILS, that is single incision laparoscopic cholecystectomy. I do 4-port, but I have done both these things. My training was with the 3-port cholecystectomy because my mentor was a 3-port cholecystectomy surgeon, so I have to do with his technique. But I decided that it is not a safe technique. You are trying to make your surgery more difficult, it is more of a marketing game. Just having one less 5mm port is only going to benefit a model who has to pay for Kingfisher connector, nothing more than that. These scars are not visible. It is a marketing strategy. I do 3-port, वो दूसरे सर्जन तो 4 छेद करते हैं पेट में आपके, and the patient happily agrees. Any patient will damn agree that 3 छेद से करते हैं, इनसे करवाएंगे. But the risk involved in that is too much that it is never recommended to go for the 3-port cholecystectomy. Yes, if you want to demonstrate something, it's a separate issue. Then comes the issue of SILS, single incision. The port which you put for the single incision is not a 1 centimeter port. It is 1.5 minimum to 1.8 centimeter port. So you have already increased the size of your umbilical port in order to prevent small 5 ports, and now you have increased the incidence of umbilical hernia in future for that patient, and you have made the surgery difficult also. Just imagine, out of 100 SILS procedure, if you happen to damage one CBD, you can imagine the consequences for that particular patient. So textbooks recommend, senior people recommend, go for the 4-port cholecystectomy. That is the standard of care, because your aim is, before cosmesis, is the safety of the patient. So this is, I am showing these, repeating these points in the video now, which I have said. So access, I am showing. Frequently we see deep type of stomach where there is a midline incisions. So first entry should be away from it, as away as possible. I have seen surgeons doing just supraumbilical. If there is an infraumbilical incision up to the umbilicus, it is always better to go away from that that point we have a Palmer's point. That is 3 centimeter below the left subcostal margin in the mid-clavicular line, and this point was devised by him not by the fluke or by chance. He did anatomical study of the lot of the cadavers and the live patients while operating, and he found this is the area which has the least congenital adhesions. That is omentum or the bowel loop adhering to this point in whole quadrants of the abdomen. So then he came with the idea, if you don't have an incision in the left upper abdomen, this is the safest point. Still you may have a bowel adhered there, congenital adhesion, but it will have a least possibility. So always go enter into the abdomen from this point so that your blind entry is safe compared to other entries. And then you can put the other course, standard 4 course, we all know, I think residents also, I will not go into the detail. And then you can start with your surgery. So this should be used for entry. One precaution should be kept, there should be rice tube to deflate the stomach. In one of our patients we entered into the stomach because there was rice tube was not there, stomach was distended during anesthesia. And splenomegaly should not be done. People have injured the spleen while entering to this Palmer point. So 2 caveats, put a rice tube, ask your anesthetist to desufflate the stomach effectively, and there should not be splenomegaly at all if you are going for this point. So then start your point, and this is you see the picture. That is be safe cholecystectomy. So first step is just observe the operating area from distance and assess these points. Right now you have a preoperative assumption because you presume this structure is there, because this structure is not lying naked that this is artery, this is that. First you have to presume it in mind, this structure is lying there, most likely this is there, this is there. Then only you will start the surgery, and slowly then you will be able to dissect these structures, remove the fibrofatty tissue, and you will do a safe surgery. Regarding use of the cautery, some people say, I have heard some senior people saying, cautery should never be used in the Carrot's triangle. Lot of studies have shown this is a myth. Cautery can be safely used in the Carrot's triangle. Your technique should be right. It should be small outburst, not holding the structure for the long duration and then causing the ischemic damage to the CBD or the common fatty duct. So it should be small burst. Preferably you should keep it at the cautery, not at the coagulation mode. If you are using a coagulation mode, it should be soft coagulation mode rather than spray coagulation mode. So in the cautery mode, the collateral damage is very less, and you are not going to cauterize the vessels here. Your aim is just to dissect the tissue. So the cautery mode is the preferred mode to prevent any ischemic injuries. And then you may start from anteriorly or from the behind. It depends. You may have small steps. Wherever you see the free tissue, lift that tissue, fire a small burst, and remove that tissue from the area of dissection. So it is not a hard and fast rule that you should first complete anteriorly, then go posteriorly. Some say you should start posteriorly and then come anteriorly, but I prefer wherever I find it easy. Because the more work done easily, you gain confidence and then you can come to that area which is having a difficult. So establishing the critical view of safety is the most important thing. So like you could use blunt dissection as well as cautery dissection, and at some places you may use a sharp dissection where you have already cauterized and trying to just break the tissue. It is more safe to just use a scissor to cut the already cauterized or coagulated tissue. So this is the posterior. You see I am way above the Rubier's sulcus. You have to be above the Rubier's sulcus at any cost. It will save you a lot of trouble. And imagine the umbilical fissure. So I always keep myself, this was said by so many surgeons before, but not maybe emphasized in the conferences that people were not following it. I was also not following it, just came to know about this technique, these landmarks 3 or 4 years back. So now you see the complete dissection has to be there, and cystic plate has to be dissected as per some surgeons. 30% of the GP fossa should be cleared before you take a decision for applying the clips. Even if you don't do 30%, 20% is enough, because accessory drugs directly into the gallbladder incidence is negligent once you are beyond 15 to 20% of the cystic plate dissection. Regarding the cautery instruments, Hook is sometimes very handy, more handy than your Maryland faucet. Some people use harmonic. Yes, it is a good energy source when compared to the collateral damage or the coagulation of the vessels, but it is a straight end. So dissection is more difficult with harmonic rather than with the simple hook and the Maryland. Remember this thing, all expert surgeons, they avoid using harmonic. They don't use, because it is not required there. It sometimes is more difficult to use as compared to the hip and these things. Then identifying the structures. Before clipping, identify the structures, maintain the critical view of safety, and regarding the clips, we all know we use clips. One caveat is only to have a long margin on the CBD side. Often I see residents in hurry where they incise, the tissue is more on the gallbladder side and less on the CBD side. So this may lead to slippage of the clip, and they will divide you of the benefit of double clip application, right? And if it is wide, cystic duct is sometimes wide, and then people are trying to use 400 number clip deliberately, half clip, half clamping, then half clip. Please learn suturing. Suturing will save you whatever is the width of the cystic duct. Use suturing so that you can assure. After suturing, there is a one tip. Suturing takes time. Everybody is not well versed. So after one suture, you will see that cystic duct has not decreased in the liver. Then you can apply it. When you can save the time of having a second suture there, right? So when you are cutting, keep your curve towards you. People try to keep a curve like this. That is convex side towards the CBD side. Always have a convex side towards the gallbladder side, so that the stump on this side is longer than the stump on the gallbladder side. And vision is always better. And then you start your dissection of the gallbladder, that is finally the cystic plate area. We all know we have to be careful. If we go beyond the cystic plate area, that is the two layers of the cystic plate, we will damage the liver, there will be bleeding, bile leak. But and if we go too much towards the gallbladder, we will have a perforation of the gallbladder. So the best trick is that standard technique is using the heel of the hook. Lot of surgeons, they teach, with respect to them, they may be right, they teach hook. Hook is meant to hook the tissue, take the tissue, fire a quadri and then hook the tissue. In a simple case, you can, whether you use a heel technique or a hook technique, you will be able to complete the case. But in a difficult case, where there is a dense adhesion between gallbladder and the liver, how you can put a hook behind it? You will not be able to put a hook. Then you have to use a heel technique. So once you master the heel technique, which is more safe technique than the hook technique, in a difficult case you are going to use a heel technique, then why not in a simple case you are using a heel technique just to save few seconds or half minute or 1 minute during the whole surgery. So please learn to use the heel technique. That quadri should be from the touching by the heel of the hook, not full arm of the hook, only heel of the hook, and should be short bursts. Don't keep the hook there for a longer duration, just 1 second. Fire the quadri, bring back the hook. See the fibers. Fire the quadri, bring back the hook. This is the best technique. You save time also. You save injury to the GB fossa, that is liver, and the perforation of the gallbladder also. And one advantage of this technique is also this. See, I am just taking a burst, touching and coming back. If you read the actual physiology of the quadri, if you have a good quality quadri, you don't have to even touch the tissue. Quadri fires around 0.2 to 3 millimeters away. Without touching the tissue, you fire the quadri, it will cut the tissue. The current travels through the tissue. So start practicing this technique. The hook seems very tempting. You go behind the tissue and hook it. You go behind the tissue and you hook it. This technique may take a little bit of time, but you have a good quadri machine and you learn the technique. It is always safe to learn a safe technique, like you say, copybook technique, right? Tendulkar had a career of around 25 years in the cricket. There were two more talented players than Tendulkar. One was Kamli and one was Sehwag. Their career was cut short because the techniques which they used were not the safe, that is straight bat techniques. They used the cross bat techniques. They were very fast players. They were more talented than Tendulkar. It is said by the experts. But because their technique was, so when they were young, they were able to use their technique to score fast and score big runs. But as soon as their reflexes decreased, The better bowlers came, fast bowler came. They are wrong technique and they were not able to change that technique. Because once you have developed a technique, it is the most difficult thing to adopt a new technique. So why not adopt a right technique from the start so that you have in the surgical field you have less injuries. So now the question is, if you have a difficult anatomy during the surgery, what to do? One I said, call your senior colleague, he may guide you. Time back, time out technique, reassess, ये ऐसा लग रहा है, you can take even the help of the resident. Resident sometimes are able to guide. Sir, यहाँ पे ये cystic ये वाली लग रही है. So the suspicion raised is a very valuable advice even by the first year resident, right? So take the second opinion always, opinion of your OT assistant. If you have a good OT assistant, he has assisted at least 4 or 5 times more surgeries than a surgeon himself, because he is assisting daily in the OT. Different surgeons, good surgeons, bad surgeons. So they know the tips and tricks of the good surgeons and the fallacies of the bad surgeons. They will advise you, sir, आप ये वाला instrument use करिए, इससे हो जाएगा. वो सारे ऐसे करते हैं. So don't hesitate, don't have ego problem and asking from your OT assistant. They will give you a valuable advice. So operatively, intraoperative angiogram, I said, very difficult to do. This is a very safe technique. That is indocyanine green. You inject this dye 30 minutes before the surgery. And you will be able to visualize this drug. And few centers in India, I know in South India, they are using it in each and every case. The cost is around 3,000 to 3,500 rupees for the dye, but you need a setup for it. Because separate camera costs around 60 lakh rupees, but in the new latest Carl stores and Stryker sets, this feature is inbuilt in that. So once you have purchased that set, you don't require a recurring cost for that, only the additional cost of 3,000 to 4,000 rupees. So in difficult, anticipated difficult cases, you can use this technique. It is a very safe technique without any complications. Anaphylaxis rate is nearly negligible with ICG, so it will help you in the surgery. And what is the future? Future is the artificial intelligence. And I assure you, within 15 to 20 years, you will be guided by the artificial intelligence during the surgery, where to work, where not to work. This is the deep learning machine algorithm prepared by Dr. Guan. And you see on the screen, the camera is guiding you, this is the safe area. Red area is don't go in this area, this is the safe area. So this is going to be the future at any cost within 15 to 20 years. They are developing these algorithms for the lab set and robots, they are going very fast on it. So these are the future things. When surgery will become more easy, mentorship will be easy because you will be guided by the artificial intelligence. But till then, we should learn these tips and tricks for the safe system. So take home message is thorough anatomical knowledge, understanding the variations, critical view of safety, concept of timeout, and converting to open if the case is still not, you are not able to handle the case, it is too difficult in the interest of the patient. Thank you. And special thanks to my senior resident who has helped me in editing all these videos. Thank you. Any questions? Yes, sir, this is great. 5,000 rupees is the cost, you can use it in 2 patients. Half an hour, 20 to 30 minutes before surgery. And by the time you drape the patient, it's IV, given IV. And by the time you enter with the scope, you will be able to see the full anatomy. And you don't have to operate on this mode. This is the light mode where near infrared light is used. So you see in this mode, this is my cystic duct, these are the other structures, and then you shift to the normal mode. So you will be doing the surgery in a normal mode, what we see, chroma and Clara modes, or some use Clara mode. So normal mode, and whenever you feel it is getting confused, you shift back to this mode by just pressing the button, and it will show you your cystic duct is going there, CSD is there, CVD is
there. Congratulations, Dr. Hemant, for a nice presentation. I am amongst the surgeons who was trained as a conventional surgeon. I had never seen a laparoscopy surgery being done during my PG. I had a conference at medical college. The few surgeons presented their live workshop. Then I was impressed and I developed interest in this. Initially, the instruments were not that fancy as they are now. Most of the time it was single chip camera, rigid instruments, and most of the time we were using 0-degree scopes, which was not as good.
Yeah, never use a 0-degree scope.
The transition is a lot, but and there was no more examples. Today you can click and you can see access to a number of videos from all over the world, right? So what I see, I have been doing a lot of work in last, I think in first surgery, in my first surgery in private practice was a laparoscopic cholecystectomy. And the first conversion, you would not believe, was 199th patient. In those 199 patients, I never converted, I never did I was lucky enough, I didn't have a complication. But the thing is, now what I see is the junior doctor, the new coming doctor, they are not interested in seeing the process. They don't observe. In conferences, if there is a gallbladder surgery being going on any session, I love to see. So I suggest, whenever you get a chance to see a surgery being performed, you must observe. Be impressed or not be impressed. If you are seeing a good work being done, you will be impressed and you will be motivated. And maybe you are not seeing as good work being done, so you will find a confidence in yourself that you are doing it much better.
What sir said is
So always see. The key is always see whenever you get a chance. And see the persons who are doing it wonderfully. Nice work being done, how you use a camera, where to place the ports in different situations. Because it's not a mathematics. You have to individualize the technique as per the patient needs. Sometimes you have to go, in a young unmarried girl, you have to go intra-umbilical port. Sometimes small children, you have to put a scopes in trophas at a different level. And or in multiple surgery operated patients, you have to use a different approach. So my suggestion, my experience is this: whatever you can observe, whatever you can learn, and you can, today you have got a video call facility. In case of difficulty, make a video call to a suitable person. There are few things as you can retract, you have to retract the gallbladder above. Is there any adhesions on the inferior surface of the liver? You have to free all of them so that there is no injury to the liver. Cystic lymph node is a very important landmark. Dissect out the cystic lymph node, you will always find an artery lying below that cystic lymph node, and it will guide you. Thank you very much for our nice explanation.
Hello. एक मैं सर ने एक पॉइंट बोला था, ऑब्जर्व वाला, उसको lateral rim में will tell you that is absolutely right. Or because of the internet and the YouTube, every videos and techniques are available. So residents think why I should watch here standing in the OT, तो room में बैठ के AC में बैठ के आराम से देखो. This has become a tendency. So I tell you one thing, I'm doing my research. New roster came after 6 months of rotation, so I was posted in one particular unit where the complication rate was high of every surgery. So I was little bit depressed. तो सीनियर से ऐसे क्यों बैठा? मैंने कहा बॉस उस यूनिट में क्या सीखूंगा जाके? वहाँ तो हर हफ्ते में कॉम्प्लिकेशन होती. बोले दिस इज द मोस्ट इम्पोर्टेंट पोस्टिंग वेयर यू हैव टू लर्न व्हाट नॉट टू डू. तो मीन जो you should observe as many as surgeons, pick their good points. Every surgeon has some strong niche. You will see how he is handling the instrument. He is good in this area. So if you observe the surgeons, assist the number of more surgeons you assist and observe, you will take out the points which are comfortable for you. हर सर्जन से कुछ सीखेंगे. Please try to observe and do live जो आप देखते हो OT में, that can be not be substituted by YouTube videos because उसमें बीच का गायब होता है कि जो टेंस मोमेंट थे उससे मैं क्या किया, उसमें उसके बाद का स्टेप आता है how we manage this. Okay, so that is very important for pass your maximum time in the operation theaters learning from the senior.
Thank you very much, sir. Sir is my teacher and डॉक्टर अनिल इज फादर ऑफ लेप्रोस्कोपिक सर्जरी मेरठ, तो मैं कुछ बोलने लायक नहीं हूँ, बट आई जस्ट वांट, मेरे को माइक मिला है तो हम सब लोग 1 मिनट कंडोलेंस रखें प्लीज। जो पहलगाम में हमारे देशवासियों के साथ अटैक हुआ है, और आज IMA ने भी कंडेम रखा था, बट हम अपने प्रायर कमिटमेंट्स से उनके साथ नहीं ज्वाइन कर पाए, तो वी शुड हैव 1 मिनट कंडोलेंस।
Yeah.
Regarding your 10th commandment, conversion, the problem everywhere is the residents are observing 100 laparoscopic cholecystectomies a month, but they are observing almost 1 or 2 conversions per year. That is the problem. In case of difficulty, they always say what to do. That is the big thing I am observing the residents they are facing. In a difficult moment, when opening up, they have got difficult to manage it. What to say?
That is the point, that how to take a decision when to convert. That is a very big decision you have to take. That's why I included one point, that is the grade of the ASC of the patient and continuous interaction with the anesthetist. If your patient is stable, you can still continue at a slow pace to complete the surgery. But the anesthetist says, BP thoda fall ho raha, this is a high risk cardiac case, COPD case, then it is safe to convert. The question comes when to decide. That is the point I think you want to raise.
No, the point is whether you are competent enough to convert to open or not. Not many people in today's era are conversant with the open position. That is the
So that's that they have to stay more in the OT, so they get the opportunity to see all the cases. At some surgery institute, the difficult case we show them that today we will do open case so that you learn the open surgery also. That is.
But for this we have teaching institute, there should be a rate of 5%. Like if we have both open as well as
We get those in the medical colleges.
Similarly in hernia surgery also, maximum number are doing by laparoscopy. So surgeons are forgetting how to do open repair. So 5 to 10 patients, either old age, who are not fit for anesthesia, we them intensely do the open repair.
In high volume center, usually you get those cases, cardiac ejection fraction of 25%. No anesthetic is prepared to get them the map karoge sir. You take them for open so that they also learn, they can start the case. Yes, I agree with you that the opportunity of early open cholecystectomy is decreasing.
Just 1 minute, we'll pray for the Holy Soul. Om Shanti.
Thank you so much, sir. Now, I will request Dr. Anil Pawar, sir, to felicitate Dr. Heman Hotyal, sir.
मैं अपना ऑफिस का काम करना, मुझे बहुत सारा काम करना। तो क्या करवाना बताओ? लैपटॉप लगाने वाले एक एक कोई नहीं बेटा, वो भी चलेगा। क्या करना है सुबह वगैरह? क्या करना है मुझे बता दो ना, मुझे बता दो। नहीं मैं करा दूँगा, मुझे बता दो, मैं कर दूँगा। पेन ड्राइव कॉपी करनी है ना, उनकी डाटा वाटा कॉपी करना पड़ता है, बदलना पड़ेगा ना लैपटॉप। नीचे लगा रहे तो चलो मैं लगा दूँगा।
I request Dr. Akhil Gupta, sir, to felicitate Dr. Anuj Sharma, sir. I request Dr. Dheeraj Pandyan, sir, to felicitate Dr. Anil Pawar, sir. ahead with next lecture of this session, I would request Dr. Medhavi Tomar sir to chair the session. He is the director of Star Hospital and current president of ASI Meerut branch. I request Dr. Poonam Gupta ma'am, professor in Government Medical College Noida, for the chair of the session. The lecture is on laparoscopic choledochal cyst surgery, operative tips and tricks by Dr. Vikas Singh sir, Professor General Surgery, RML Hospital, Lucknow.
Okay, after a long session since morning, and at the best I would like to thank Dr. Maheshwari sir and my own Gyanendra for having me out here. And before I begin my talk, I would like to say thanks to Dr. Gyanendra and Dr. Maheshwari again, and Sunidhi and team for coming over to Lucknow for that laparoscopic suturing skills that I organized on last Sunday. Thank you so much, sir. Regarding this particular topic, my job is much easier now as far as the topic is concerned. The reason being, thanks to Nautiyal to take up my laptop so that you could show exactly the anatomy and the radiology which was shown before. Because this is what we are trying to look for. So I will jump directly into what is choledochal cyst. And this is one diagram which we are supposed to understand. And this diagram is mainly at the lower part of the sphincter chordae, or the pancreatico-hepatobiliary junction. And this is the most anomalous part that has been talked about in the literature. And if there is a backflow of the pancreatic juices into the biliary channels, and that is what causes the weakness of the walls and resulting into finally the abrupt or asymmetrical or symmetrical dilatation, or the various types. And because this is what is, and that is what we want to know exactly, that where is it. As far as I will just touch on a bit of theory because we have most of the PGs. This is one of the most common classification that we use, that is the Todani classification. And in fact, like multiple images, that's why this is all Bloomberg that I am trying to note down. And what it shows is that right from type 1, 2, 3, 4A, 4B and 5, total 6 types that we are looking at. One of the commonest what we look for is the type 1 that we find, and apart from that in which we are able to do, and also apart from that at times we also find 4A as well, or even as 3 and 2. It is very difficult for a general surgeon to have the rest of the cases, because even if they come and the moment you get to know on your MRCP, you send it directly to a general surgeon or means a GI surgeon or a place where there is going to be a liver transplant. Because finally that is one of the best options available for these kind of patients. So I will not delve into again the details because this is something, the theoretical part which you are supposed to learn and memorize all these things. Talking of the symptomatology, that how do we get to know that this particular patient, as far as clinically is concerned, can have or may have one of the choledochal cysts. Because biliary systems, also called biliary dyspeptic symptoms, are very vague symptomatology. It is mainly the upper abdominal discomfort, may or may not be having a jaundice or some other features of cholangitis that the patient presents. So again, I will leave the infants or the pediatric population for Dr. Gyanendra and the team to handle. It's mainly the adults, I would say the young adults. Let's say that general surgery tackles something around 15 and above that we tackle. Ideally the age is supposed to be 18 plus, but we tackle something around 15 and onwards. So apart from the vague abdominal, upper abdominal pain one can have, there may or may not be jaundice. If at all there is an infection, the patient will present with something on the Charcot triad, typical of cholangitis, or patient may be entirely asymptomatic. And there may be only a lumpish feeling in the upper abdomen, and that is especially for patients with a lean and thin individual. While furthermore in adults, as the time passes by, because of the stagnation in the extrahepatic biliary system, there are chances of more symptomatology. And when I say more symptomatology means stone forming incidents or the sludge that forms, that can give rise to furthermore dysplasias and furthermore going into even malignancy also. Or again, I would say the last one, they might be entirely asymptomatic as well. Only once you get an ultrasound, they report that it is a dilated CBD. But that dilated CBD, once you get an MRCP or a good radiologist, they tell that it might be one of the possibilities might be a choledochal cyst. So there is always a tussle between a dilated CBD system only or a choledochal cyst. So that is a point of contention or more of a controversy at times with arises. Talking of again the complications, one of the most dreadful complications why at all it is being treated or surgically treated is because it has a tendency to develop or convert into a malignancy. That is first and foremost. Apart from that, repeated bouts of infection can cause extrahepatic or even anywhere around the biliary tree some or other kind of structure. Maybe single or maybe multiple as well. Because the things are coming from the reverse flow, that's why there can be ascending cholangitis as well, and it is very difficult to treat such patients only on the basis of conservative management. We need help of our gastroenterologist trying to put in maybe a stent for the time being to drain and then maybe have good, better antibiotics. And finally, the slide of the stone formation, and that is mainly because of the stasis, what is happening in the whole system. Evaluation, as we talked in the morning, ultrasound is one of the best modalities, but we need furthermore like how do we classify what type of colorectal cyst it is, and that is one of the best ways is to get it done as an MRCP. A good MRCP, especially the reconstructive image, is the one which is going to give us a lot more information as far as this is concerned. Also, in the morning also it was being talked about regarding the technetium-99M HIDA scan. That is something, the hold up of the child, that is what it's going to do, and that is going to be one more step as far as the objectivity of the findings are concerned. So in that way, that adds on to the knowledge. MRCP is one of the best ones. ERCP again, there is always something known as competency. And when we say competency, ERCP done in good hands with or without an endoscopic ultrasound can have better knowledge as far as the distal choledochal cysts are concerned, especially the choledococele that we are looking at. Because with endoscopic ultrasound, it can be delineated wonderfully. So these are the various surgical options. We will be talking about, remember, what we need is, as far as possible in most of the cases, we excise either almost, I would use the word almost complete excision, because that is what is possible at most of the time. Complete excision may not be possible, and you always, but furthermore, completion surgery might be required once you send it for histopathology, and in case if something abnormal comes by your pathologist colleague. Then the completion surgery might be required in the same set of patients, or patient can also be under surveillance with these kind of investigations over and over again, over a period of time till the patient lives. But in any one types, we are supposed to excise it and then do a bilioenteric anastomosis, either open or lab, or even gastroenterology friends, they can go in for just a drainage procedure, ERCP and stenting, that is equally good in certain select cases. So these are the various options which are available. It can be done various methods, either choledochoduodenostomy, it can be hepaticojejunostomy, choledochojejunostomy, it can be complete excision and then, but if there is too much of adhesion because of the repeated bouts of cholangitis, we even tend to leave the posterior wall of this, denude the mucosa of it, and then we do a bit of anastomosis. And that anastomosis is supposed to be mucosa to mucosa anastomosis, that is the rule of thumb as far as bilioenteric anastomosis are concerned. This is one of the very good things, something it can happen, that I have operated on a choledochal cyst and it was a type 2. And type 2 means it was only a supraduodenal and more of a diverticular sort of thing. And apart from removing the gallbladder, that has also been removed. But the point is that the CBD must be identified as per Be Safe line for you. As per that, you identify and ensure that you do not take the chunk of the CBD wall in that. And that is mandatorily to be sent for histopathology in such cases. Again, colpotosil, our gastroenterology friends, either they can, or in case the surgeon is good enough, they can go for transduodenal sphincterotomy or transduodenal sphincteroplasty, or even for the excision. The point to be taken care is, once you decide to excise, then you need to be good in doing a pancreatic duodenostomy on a repeat basis. That is one of the sidelines of tackling this surgically. In this again, this is one of the very common ones, the 4A and the 4B. The thing is, you are supposed to excise most of it, whatever is available extra effectively. I would say that because I am a general surgeon, so I am batting only for the general surgeons, because most of us are out here. GI surgery persons, they can go into the liver, go in for a segmental resections and others. But I would frankly admit that may not be possible at our ends. But that does not mean that we do not delve into such type of cases. Till the time we are confident in terms of removal of most of it, going in with a proper protocol, then yes, we must do such type of cases also after a proper expertise has been gained. This is another one. This is the one which I was saying, the type 5, in which mainly if it is not with a GI surgeon who is able to do an extensive surgery, it mainly lands upon orthotopic liver transplant. These are the patients who sooner than later will land up with a liver transplant team. Let's just go in with a video. I shall be pausing at a couple of steps. This is the case that we are looking at. This was done around 8 years back. Again, harmonic is one of the best instruments as far as peripolydopal, whatever dissection you want to do, that is one of the best ones. Even more than the surgeon, what is more important is your camera person. Choose your camera person very well. And what is required is stability of your camera, mandatory 30-degree camera and stability. That is what is important. And the surgeon must know exactly what you are trying to do next. And there is something which Dr. Shailesh Fundamnikar always says, predictive anatomy, because that is what we are trying to look for, because in such cases, usually anomalies can be as a common phenomenon. So we are supposed to look for, that's why if you notice, the screen is so much zoomed that we can see even the finer capillaries. Only the area of interest is supposed to be on the screen rather than the whole liver and the duodenum and everything. That is not required, because you are supposed to see through the tissues what is coming behind. Because this is the medial dissection which is being done. And if you notice, a traumatic instrument in my left hand, and I'm trying to pull it onto opposite side so that I can do a bit of medial dissection. This is the lower end. I would just pause because there will be certain issues with this. We try to come as far as lower down, right up to the surface of the pancreas. That is step number 1 in the initiation. If you are good enough in doing something known as the reverse scoring, you can go in for means beating it out within the substance of the pancreas. If there are difficulties involved, it might start to bleed. And as far as laparoscopy is concerned, unless and until you have a vision, you cannot proceed forward. And that's why there is no harm in leaving a small cup for having 2 things. It's always a good thing in something if you are leaving behind 2 things. There is always an anomalous pancreatico-biliary junction. If you are delving it for complete excision into the substance of the pancreas, and at that time, because of certain amount of bleed or because of the pancreatic substance, if you fail to identify the pancreatic duct and somehow you damage the pancreatic duct in excising your polydopal cyst, the lower end of it, then it's going to be 110% pancreatic fistula. So rather than having to deal with pancreatic fistula, wait and watch, and maybe the next one person should be able to do the good job. And that's why In this particular case, on the surface of the pancreas posteriorly after doing whatever the blunt and the sharp dissection, this was the point where I was able to reach. And then before cutting through and through, what I tried to do was, I just opened up bit on the surface of the pancreas with the help of a monopolar. Whatever the collected bile or the stasis bile was there, that moved out. So rather than completing the excision part of it from the lower end, stay sutures have to be taken so that you can close meticulously. Because in case if you have not traumatized the pancreatic duct opening, but still there might be pancreatic juices which might come into the peritoneal cavity and might cause problems in the post-operative period. And that's why it is mandatory that meticulous closure must be done. And that means that you need to have good intracorporeal suturing skills. And the suture which we use is mainly the PDS in these cases. So this, as you can see, that this we are behind the duodenum. The sutures are going behind the duodenum because that is where things were being pulled out while the dissection was being tried. And once we have taken a couple of stay sutures with full thickness wall on the surface of the pancreas, then we complete the lower transaction. Because there is always certain steps known as steps of irreversibility. So before cutting in, before using not any energy sources, you must decide, will I be able to salvage from here? Because once you cut it, there is no other point. You have to go in for a hepatotoxicity minimum. And that has been closed perfectly. So using a combination of both vital as well as PDS. And then we come on to above part, and above it is said, you need to go as high as possible. When I say the word as high as possible means, we need to be at the level of confluence. And the reason being, one simple reason, good vascularity. That is what we are looking at. And once we have opened up, in the meantime, a God piece stays over there, and then we come to the infracolic compartment to form a proper rule loop. And the length of the rule loop, what we are talking about, it says 40 centimeters. That 40 centimeters might vary depending on how big is the colon and the omentum. Whether you are supposed to go retrocolic approach or anticolic approach. Both the things, because by the time you have done this, it's already almost 2 hours. So if you are not well versed with your stamina, you will be thinking of either converting or abandoning the procedure. That usually happens. So once this jejunostomy has been done and a 40 centimeters rule loop or 50 centimeters rule loop has been made so that it reaches the hilum of the liver at the site where you have cut easily and comfortably without a pull or push on this loop. That is the length of it that we are looking at. And once we are done, this mesentery part is also supposed to be closed because then otherwise the internal herniation chances are going to be on a high side. So in this particular case, we went ahead with the retrocolic approach. And again in this, what is important is your assistance or the way you lift it up so that you can see the middle colic and then just either to the right or to the left of the middle colic, you enter and reach in the supracolic compartment. Again, I will just pause out here. If you notice, this is the rule loop which has gone up. This is the end part of it. So I have not made this enterotomy at the end. It is subterminal. And this is supposed to be approximately 1 centimeter. One more cheating tip, which if you want. If you notice, this is the anti-mesenteric border. But I have not made enterotomy on the anti-mesenteric border, rather a couple of millimeters a bit anterior on the anterior wall. That has a particular reason, because once we made it out here, this wall, the posterior wall tends to fall back. And once it falls back, it is very difficult to pull it up in each of your sutures. But if you open up a bit anteriorly, even if it falls back, it will remain up. And once the posterior wall remains up, it is easy to have a better anastomosis, especially if the posterior layer, which goes out of vision most of the times. That is one of the cheating tips, which after doing 15, 17 cases, we got to know that rather than struggling, go a couple of millimeters anteriorly, and there is no harm in that. मैं अभी ताली नहीं दे रहा हूँ, थोड़ा सा। Okay, again one more thing. It's all about that where do we place the port positions and all. Port positions again, somebody was saying in the morning, it is not that it is supposed to be marked on the port. First camera port can be initiation. Rest of the ports, depending on what kind of anatomy, what kind of abdominal profile is there of that particular patient, how comfortable you are, whether you are a right-handed surgeon or a left-handed surgeon, if you are ambidextrous, then which one is going to be more dominant hand, are you comfortable in passing needle in a clockwise manner, or can you take an anti-clockwise needle also? Because everything will count. So that's why it is mandatory to have 2 monitors in these cases on either of the sides, so that in case if you want to switch your places for a couple of sutures, you can switch on and see the other monitor. Because that will be required, especially doing at this session. Because by the time it is almost 3 hours post-surgery. So at 3 hours, the muscles are going to be sore and there is going to be fine tremors while you are taking the bites, and that too in the cortical means part of the bile ducts. You do not want any cut through in that because of your tremors or because of undue pressure out there. Like in this case, it is always said that you start away from you, because I am doing it from the left side of the patient, so I am starting from the distal end. It has a particular reason to start from the distal end, so that whatever you are doing, at least the next bite is going to be in front of you, especially both the balls that you are going to look at. That's why you always start from the distal point and then you try to come towards you. That is one of the best ways. And then again, if you notice, the anterior wall of the intraotomy is well visualized. Again, thanks to my cameraman that we were able to shoot this and see these capillaries also in this particular case. So it is not mandatory to take both simultaneous, but once they are side to side and they are properly opposed, you can take through the needle. The only thing is, accidentally with your left hand, you should not tear out your tissue. It doesn't matter whether you are doing an enterotomy or doing a cyst excision with a monopolar or with a harmonic or with a cold knife. Literature has proven that they do not cause any alternative means. Once the posterior has been done, always remember that unless and until you are able to see both layers, especially the mucosa of both layers, do not proceed forward. So that's why a gauge piece or a suction must be handy at all times. You can always wait, clean the camera again, see in crystal clear concepts, only then you go forward. So this is another corner that we are going to do, and it's right in front. That's why 30-degree camera and a good camera person, both the things are required. Some persons, they also use means bi-arm or the dual arm, but the more the length, it is difficult to manipulate inside. That's why maybe you can take 2 or 3 sutures, no problem, but half the length so that you can manipulate inside very comfortably. And once posterior layer is done, again, posterior layer is all continuous. Not many GI surgeons that even I have seen in not many conferences, once they do open, they take at least 15 to 20 sutures and everything with an artery forceps, and there are 10 artery forceps on either of the sides, and then they get confused which one to which one. Maybe they are good enough, but had it been with me, I would have really groomed the patient. But what has been proven as per the literature, even the continuous suturing is good. You don't need to lock the sutures. The only thing is, it is only approximation. You don't need to pull it like we do in abdominal wall closures and your assistant is pulling up like anything. So that is not required. It is only mucosa to mucosa approximation which is a must. And whatever is being done, it is supposed to be done only under crystal clear vision. I am reiterating the fact because whenever these cases usually do not leak, but if they do, then the hell is bent on you. So that is why it is always that no more energy sources over there. Whatever you have cut in one go and then try to see it under you and then go and for. In all the cases, we have done with Vicryl as well, but once the PDS was available, PDS was a better choice. And once we are doing it, all the time in the left with the Maryland, you can always poke and see exactly whether there is more than a millimeter space there. Because these anastomosis are supposed to be watertight anastomosis. And even then, there might be a couple of leakage because the edema is going to rise and that will settle down over a couple of hours or maybe a couple of days. Not many persons like this is one of the last sutures. If you notice and see the use of the Marylands that has been poked inside to lift up the wall and then try to take the bite through it. So whenever you are using a curved needle or for that sake any needle, it is on the you that this needle is supposed to enter at a definite point that you want and it must exit at a point where you are demanding it to. It should not exit any waste place. It is supposed to exit the place you want it to. And that is only said to be at that now the suture is going to be in a perfect manner. And once you have done it, there are persons, those who put in a drain as well into this. We do something known as a silo drain or the Penrose drain that can be kept. Persons even do like PTBD is being done beforehand and that can be placed inside and you leave that in place for a couple of times. Because if you notice this again, the last image, it was done only with 4 ports. It was done only with 4 ports. So depending, I will did it all from the right side, so that was I was comfortable. If you have an Atkinson's retractor, more than one of them, because that will keep your liver up. Or you can have one more retractor, a fan retractor, have a gauge piece on top of it, and ask one of your good residents, those who can stand for 2 to 3 hours at your stretch without having the distraction, if they can retract the liver up to the hilum so that it remains stationary. Because vision is the key, nothing else. Strokes will still remain what Dr. Nautiyal has already said, that it is the same cricketing shots which you are supposed to learn, be it for IPL, be it for Ranji, be it for World Cup, T20 or anywhere. The player remains the same, the strokes remains the same. So if you know your techniques good, you can do any kind of a surgery. Thank you all. Thank you.
Thank you, Dr. Vikas, for a wonderful presentation and making things so simple for the general surgeons. Any comments from the audience are invited.
Please stand for me.
Thank you, Dr. Vikas, for a nice presentation for general surgeons. Because now this is going to the derivative of general surgeons.
Very good. I'm a very strong proponent of general surgeons.
Thank you. The only thing is that most of the GIs, general surgeons, when they are exposed to such situation, it is a country to cut halfway or 75% of it and leave it. What is the message to the PGs, how to follow such patients in future and what you expect? Because many times I have said, surgeon has gone inside, put the T-tube, came out. Gallbladder just cholestomy, put a T-tube, dilated CVD, things like that. Another partial excision, another 75% excision, another intrahepatic he has left. What is the future for those?
So, future is always one. There is key to success is one, what I have been taught and what I preach. Preparation is the key for success. And that preparation, when I say, it is multi-pronged preparation. One, the thorough knowledge about it. And when I say knowledge, it is not you who counts, it is you and your team. And when I say my team, it is my colleagues, my residents, good residents, those who can put in their brain and heart into it to know exactly what are the various possibilities. Then comes the radiologist friend. Then comes the radiologist friend who can give an insight what are the various options or the adhesions will be there, what is the thickness of it, how easy it is going to be. And if you feel that you have never been exposed to such things, don't attend. My simple, if you have not seen these before, don't attend for the first time. There is always somebody who does it first. Even I did it first. But before that, 1,000 cholecystectomies, difficult one, lymphoma, gallbladder, choriotocolectomies, means anatomy of in and around the whole of the bleeding, extrahepatic bleeding channel is supposed to be crystal clear, and your hand-eye coordination is supposed to be fantabulous. Only then you attempt for these cases. Otherwise, do not attempt. You don't learn swimming in your seas or the rough seas. You start from your own chup-chap swimming pool में उतरो और maybe shallow end पे लेके learn, raise stamina and then slowly go in. That is one of my experiences. I do.
Sir, my senior and we have for 7 years together. And I have a very simple question, sir. Sir, suppose there is a stone at the center of CBD, large stone, and there is condition of CBD due to the stone. Then interactively, how will you proceed? Will you remove the stone or how will you study the dimension? Is it a total cyst and you will proceed for
That's a wonderful question. Again, I said it at the beginning that there is always a controversy as far as choroidal cyst, to say that it is a fusiform dilatation of a choroidal cyst or whether it is because of an impacted stone which is present. Because there is going to be a mixed picture. Then the rest of the parameters, they come into the play. Once I say rest of the parameters, they come into the play. You can confirm these things, let's say with a HIDA scan. Inflammation is going to be less. There is what is seen as in presence of a stone, chances of cholangitis or the recurrent attacks of cholangitis are more as in comparison with a choroidal cyst. Somehow they have also said the size of the dilatation as per radiology is, it is in millimeters that they say that if it is more than this, I would term it as query choroidal cyst. And if it is less than that, I would say that it is because of the back pressure changes. But the same thing again, if I need to make money out of it, I would term it as choroidal cyst and go in for a bigger surgery rather than putting it as CBD exploration. So that is another one more thing. It is always to err on a better side rather than on a smaller one. Thank you. Yes, Gavin.
Thank you, sir, for my one query. So you use population dichotomy for entropy. Doesn't it cause population necrosis?
I did say that. As per literature, you cut it, that is for both, either for the bowel, CBD or ureter, pylotomy, anything. You can use monopolar hook, you can use a scissors, you can use a bipolar, or even with a cold knife. Anything, the results are one and the same. Yes, what matters is the correct mode of application is important. When I say correct mode of application, because it is, this area is not bleeding. So in case if you are using harmonic, use as the 5 as the channel, because that is only as pure cutting and less coagulation. So if you are using 5 and you are using with that speed with which it is supposed to be done as we do with the blade, it is perfectly fine. It doesn't. This has been proven in literature.
And on this side was showing color change.
Doesn't matter. Doesn't matter. Remember again, you are taking bites not only through that, you are taking bites a couple of millimeters even beyond that. So that is very well accepted. So, mark my words, as per literature it has been well proven, multiple theses which have been done in the literature which says pylotomy or choledochotomy with this, and is there a chance of leakage? And it has been proven there is no. Even with a monopolar hook also, doing a choledochotomy or an excision is equally safe as with a cold knife. That's proven.
Thanks.
Sir, thanks for presentation, sir. I'm Dr. Priyanka, Associate here, Subharti Medical. So, sir, I would like to know post-operatively, how will you give this patient orally allowed to prevent the anastomotic leak?
It is just like doing any other case. Remember again, early ambulation is the key. On the same very evening, the patient will be comfortable to walk, because remember again, you are not doing much. There are certain points like jejunostomy has been done. With the lab, the amount of inflammation setting in is much less as in comparison with the open. You are keeping Riles tube may be required, let's say, for 24 to 48 hours. That's all. But oral sips can be given the very next day. You start with the oral sips, unless and until the Riles tube is pouring out, which Riles tube doesn't pour out. Because your surgery is being done, let's say, 3 or 4 hours max, and if that is the duration, pathophysiology doesn't set it. It is only an anatomical disruption which you are causing and which comes back within 24 to 48 hours. The thing is, patient needs to get mobilized, that is mandatory. And after that, Riles tube maybe the next day in the morning or maybe 48 hours, and then you can remove it. There is always a drain which is placed in the hepatomorsal spout, and you look for with the fingers crossed. But it is not something that I am keeping the drain of 32 size, expecting bowel to herniate through it. No. If my anastomosis has been made, you have to believe in yourself in that case, that if my anastomosis has been good, I am not leaving anything, any corners which have not been looked for, to relax.
Thank you, sir.
Right? Thank you.
Hello, sir.
Hi.
So I'm asking any experience of internal stent.
Internal?
Internal stent, the actually.
You mean to say only gastroenterologist? Are you a gastroenterologist?
No, I'm a surgical.
I think you are. Remember again, surgeons, they really are afraid of getting your patient stented before a surgery. Mark my words, even for a DK stent or biliary stent. Reason being, while putting in a stent, there is always exogenous source of infection. There is always a stasis that can result or that can induce cholangitis. And that induction of cholangitis can cause lot many adhesions on or around the CBD, especially in the hepatoduodenal ligament, and that can make life of a surgeon a bit more difficult.
I'm asking about the intraoperative stent, use of stent for intraoperative.
It is very tedious. You can put in, like most of the persons they do, they put in a small, even Riles tube, part of a Riles tube, a bit in the left duct, and rest of it goes into the bowel. And which is said to be as that it passes by its own when the peristaltic movements begin. That can be left, but I never felt a need for that.
There are very thin walled political cysts. So even if your middle entry will lose the bile from the area. So we can stand.
Penrose veins can be utilized. Penrose veins can be utilized. I said that depending on the availability and depending on how good you are in putting it. Because that again, putting in a Penrose vein, you will be making one more small enterotomy through which it is going through. So maybe it is not the suture place which is leaks. If your kismat is rubber, it might leak from the point where you have put in a Penrose vein after dilating it with a small artery process. So that's why I'm a bit afraid of putting in drains. Have good suturing and relax for some time.
Or transanastomotic stenting. So I think there's a, in my opinion, it's a big no, because it can cause ischemia of the anastomosis, and the literature doesn't support it. I think you should be confident enough in your stitching and relax, like Dr. Vikas said. I think that brings us to the end of this session. Wonderful talk. Thank you once again, Dr. Vikas.
Thank you, sir. Thank you.
Thank you so much, sir. Now, I will request Dr. Nerathobilary, sir, to felicitate Dr. Vikas Singh, sir. I request Dr. Anil Pawar, sir, to felicitate Dr. Medhavi Tomar, sir. I request Dr. Sushant Mishra sir to felicitate Dr. Poonam ma'am. Now, moving with the next session, in benign hepatobiliary disease, we have to chair this session Dr. N.K. Singh sir, Principal, Tirthankar Medical University. Dr. Dheeraj Balyan sir, Professor, LLRM Medical College. Dr. Dhanesh sir, Professor, Unit Head, Subharti Medical College, General Surgery Department. Topic of this session is bile duct injury, immediate and definitive management. I will request Dr. Madhuvara ma'am, Professor Surgery, GS Medical College, Habib. I request all the speakers to keep the time of the lecture to 20 to 25 minutes, plus minus 5 minutes for questioning, so that CME can be completed in time.
Good afternoon all. Thank you very much Dr. Maheshwari sir and Sanjay Pandey sir and whole surgery department for giving me this opportunity. And as instructed by our anchor, I have cut short time of my talk only to 10 minutes. But I have divided my talk in 3 parts. And first part is of 10 minutes which is allotted to me, that is bile duct injury, management of bile duct injury. So I have not written more detail about classification and all. All of you can go through for it in books. I have highlighted only main points. So only one-fourth to one-third of cases of bile duct injury, they are detected intraoperatively, and rest of the cases are detected post-operatively as bile leak and obstructive jaundice due to biliary stricture. Intraoperative recognition of bile duct injury is mainly by bile seen during Calot's triangle. If the bile is viscid, thick, greenish yellow, then it is definitely from gallbladder. But if it is golden yellow, thin and watery, then it is from common bile duct. Other alarming signs are vertical location of divided cystic duct, difficult to take gallbladder away from hepatic hilum, and third structure seen in Calot's triangle. So if bile duct injury is detected intraoperatively, then what should be the management? Whether it should be repair should be immediate or it should be delayed. So there are a few advantages of immediate repair and disadvantages are many. Advantages are it is late convenience and there is less morbidity, shorter hospital stay, less treatment cost and less inflammation and no sepsis. Disadvantages are treatment failure rate and complications are more, and overall treatment cost and hospital stays were even higher for patient requiring second surgery. And in case if patient requires second surgery, then it is more difficult for surgeon. So with intraoperative cholangiogram, intraoperative ultrasound, expert primary surgeon or expert surgeon on call, especially hepatobiliary surgeon, if it is available, then you can go for immediate repair, which can be laparoscopic or version, open. And if you don't have all of these facilities, then better is to do laparoscopic lavage, put at least 2 wide bore drain and placement of omentum near Calot's area. Then refer the patient to higher center hepatobiliary center with proper intraoperative notes and video. Now, if there is subvascular duct injury detected intraoperatively, then size of the duct is more than 3 millimeter, then it can be clipped or ligated. If it is equal or more than 3 millimeter, then it should be drained, that is videoenteric anastomosis should be done. Coming to common bile duct injury, if it is clipped but not divided, remove the clip, observe if there is no bile leak, then you can put drain and observe post-operatively if there is bile leak or stricture, then you can go for ERCP and stenting. If after removing the clip there is bile leak, then you treat it as lateral bile duct injury. What is lateral bile duct injury? An incomplete, partial or lateral bile duct injury with involvement of less than 1/4 to 1/3 of the circumference of the common bile duct. Repair of this is done with fine delayed absorbable suture. This can be with stent or without stent or T-tube. In complete injury of bile duct, if there is no tissue loss, then end-to-end repair can be done with or without T-tube. And if there is tissue loss, then bilioenteric anastomosis is preferred. Then what about the bile duct injury detected in post-operative period? About 70 to 80% of bile duct injury are recognized in post-operative period and they are present at bile leak or benign biliary stricture. In early post-operative period, there is external biliary fistula if drain is placed, or there can be biloma, biliary peritonitis, biliary ascites if the drain is not placed. So, apart from ruling out and management of sepsis and routine investigation, after stabilization of patient, MRCP is done to delineate the anatomy, classify the injury, predict the natural course, and guide to further intervention. So, initial management is mainly directed towards control of the sepsis and to control the bile leak. Aim of the management are drain any intra-abdominal bile collection, treat the sepsis, stop or reduce the ongoing bile leak, convert the acute bile duct injury into a controlled external biliary fistula. USG guided or CT guided drainage is enough in multiple cases. Relaparoscopy or relaparotomy is rarely required for diffuse peritonitis. Now coming to cystic duct leak. It can be due to residual or retained CBD stone, and treatment is ERCP, stone extraction and stenting. In incomplete clipping, that is partial circumference or inadequate loose clipping, ERCP and stenting is done. And if cystic duct leak is due to hole in cystic duct stump caused by thermal injury or sharp instrument, then ERCP and occlusion of cystic stump using glue is done. So spectrum of treatment varies from PCD, bilioenteric anastomosis, hepatectomy and liver transplantation. Early repair usually done for complete injury, no associated vascular injury, ligated ducts and dilated system. There are few advantages of early repair injury and a very disadvantage of early repair injury, like bile duct are inflamed, edematous, friable, so there are chances of leakage. Difficult to identify the duct. Patients are very sick to operate, associated with biliovascular injury, and technically it is very difficult. Chances of failure are more. Now coming to management of benign biliary structure, it requires delayed repair. The timing of repair for bile duct injury are variable. Immediate repair within 72 hours, intermediate 72 hours to 6 weeks, delayed 6 weeks to 6 months, and late is after 6 months. Delayed repair is preferred for benign biliary structures. So there are 3 mantras. Appropriate patient, that is patient without any sepsis and control external biliary fistula. Appropriate time is after 6 weeks, and appropriate surgeon is expert hepatobiliary surgeon or expert general surgeon. So MRCP is done to delineate the anatomy of the biliary structure. PTBD and PTBC are used. PTBD is done for sole purpose of drainage. Cholangitis, if cholangitis is present, and high output external biliary fistula. Percutaneous transhepatic biliary catheterization is done 1 day prior to definitive repair with purpose of preoperative or intraoperative cholangiogram and intraoperative detection of the duct. Possible transanastomosis stenting is done. So this is the classification of benign biliary stricture. Biliary enteric anastomosis principles are already told. This can be end to side or side to side. Side to side anastomosis is difficult on right or sectoral duct. Hockey stick, repair can be done laparoscopically open hockey stick incision is used with Kent retractor. Meticulous adenolysis is mandatory and usually recommended for right to left direction. Identification of duct is done by tracing the fistulous tract, looking for clips, then pre-place PTBC, palpation of duct, intraoperative VSG, intraoperative cholangiogram. Or you can also use saline stent with color dye installation, that is aspiration using the fine needle. Then identify the duct. Halar plate is taken down for exposure of hilum and left hepatic duct, usually for E1, E2 and E3 injuries. Then for E4, E5 and B injury, hilar plate take down continued to cystic plate for proper exposure of right main or segmental duct. Partial resection of river tissue anterior to the right portal pedicle is done and partial resection of segment 4 and 5 is done. For E1, E2 and E3 injuries, side to side or end to side anastomosis is done. Even for E1 and E2, hyalogenostomy is preferred if there is wide duct and good vascularity. When ducts are closed, end to side anastomosis preferred. For E4, you can go for side to end anastomosis. In E5 injury, end to side or side to side anastomosis can be performed depending on the dissection and presence of adhesions. So trans-anastomotic stent versus no stent. Not mandatory in dilated ducts, used in non-dilated duct 3 mm or less. For suturing 5 delayed absorbable sutures are used. Use magnification loop. All knots posterior anterior wall outside the lumen and use trans-anastomotic stent for non-dilated ducts. For bilioenteric anastomosis, stoma size should be 2 to 3 cm. Single layer interrupted absorbable suture is used. You can use Blumgard-Kelly technique, that is seromuscular anastomosis suturing. Hepatectomy in bile duct injuries. Indications are complex E4, E5 injuries where safe anastomosis is not possible. Symptomatic atrophic segment due to biliovascular injury. Liver transplantation. Indications of liver transplantation in bile duct injuries are bile duct injury not treated timely, developing secondary biliary cirrhosis and end-stage liver disease. With failed repeated surgery and non-surgical management, repeated episodes of cholangitis, intractable pruritus, progressive jaundice, poor quality of life, and acute liver failure. So take-home message is, while dissection of Calot's triangle, critical view of safety technique should be followed. Anatomical variation is more common in Calot's triangle. So if surgeons are getting any anatomical variations during surgery, they should report and publish about the variations so that other surgeons can learn from these variations. Know your limitations and don't hesitate to consult with other surgeons in doubtful conditions. Conversion to laparoscopic to open cholecystectomy is wisdom and not failure. Thank you. This is only first part of my talk. Now I am coming to second part, and this is my poetry for gallbladder lovers. So the main function of gallbladder is not only So function of gallbladder is not only concentration of bile. Gallbladder is also kuber of surgeons. So this point starts with, I am cultivating a harmonious relationship with liver bed and also in touch with gut. I store the bile coming from liver and I also concentrate it with effort. After supersaturation of bile with cholesterol, polylithiasis is my new version. Though I become harmful for my body, I am very useful for all general surgeons. Lab cholecystectomy for gallstone then became gold standard treatment for all general surgeons. I finance for good investment. To lose my own body, I don't have any fear because I really become an important part of surgeon's career. I finance for their home to purchase a car and luxury of life. I help them to educate their children to purchase gold diamond jewelry of their wife. Though due to complication of gallstones for my own, I am a big fraud. For all general surgeons all over the world, I am a great God. I am a great God. Thank you. Now coming to third part of my talk. So whatever you are earning from doing cholecystectomy, you can use in our event. Department of Surgery and Gynecology of GS Medical College and Hapur is organizing an international event, Celsicon NZ. It is an international conference which is held in Bharat Mandapam on 5th, 6th and 7th September. So just a small video of our venue. This is a room where G20 summit was taken place under leadership of PM Narendra Modi. So this is the auditorium we have booked for our venue. I will take 2 more minutes only. So this is the brochure of our conference. I have already distributed the hard copies. So I am showing you the highlights. So it will be a global summit of surgeons and gynecologists all over the world. Many renowned national and international faculty will attend this. There will be live operative workshop with 3D display. We are relaying live operative workshop in 3 auditorium, out of which in 1 auditorium there will be 3D display. Also there will be variable talks on secrets of holistic approach for patient care and surgeons by international NLP mind coach and renowned surgeons. There will be pre-conference workshop on robotics in wet lab and on simulator also, vascular suturing, upper endoscopy, colonoscopy, laser proctology in wet lab and lab suturing and knotting. Competitive surgical videos for surgery and gynae faculties. Top 3 videos will be selected and cash prizes will be given. For PG residents, there will be PG quiz, competitive poster and paper presentation, and presentation. All winners will be given cash prizes. Last but more important, there will be open forum on doctor and patient relationship with medical, legal, and social perspective. One more important thing, there will be fellowship exams, and unlike for other conferences, we are conducting fellowship exam in same conference, and convocation will be on the on 5th there will be exam, and on 7th there will be convocation in Bharat Mandapam, and we are not charging any convocation charges for this event. So early bird registrations, last date is 30th April. I would like to welcome and see you all there. Thank you very much.
Thank you so much, ma'am. Now, I request Dr. N.K. Singh sir to felicitate Dr. Madhubala ma'am.
I request Dr. Dhanish Kumar sir to felicitate Dr. N.K. Singh sir.
One question to audience, which is very critical. In every medical college all over the India, the moment PG is passed, they immediately start lab career, number one. Second, most of the CVD injury which we are getting, it is from them only. So what we should do in our teaching schedule, so that it will be reduced as much as possible. Because I am telling you, the moment you said CVD injury is various, cost is 5.5 lakhs, and it ends up in liver transplant, as you have seen. We have seen many patients, they are struggling with their life and their family on the economic forum. And everybody blames that this fellow is passed out from the system. What to do with that? What to do with their mentality? How you will change their mental setup? It's the biggest trouble for all the general surgeons as well as for GI surgeons. But nowhere in any teaching, thought-provoking options are there, how to train them in the last year so that they will not jump to the lab immediately. Just think over it. It is an appeal for all of us. Because I am saying, you see, within 6 months they are doing hundreds of lab programs without any, what you say, if and but. And result is very poor for all those patients. And we don't have any answer for that. जैसे मैडम ने कहा कि पीटी कर देंगे, सीवीडी नैरो हो गया, अभी क्या करोगे? आपने प्लान किया है हिपेटोकोसिस के लिए, डायबिटीज नहीं, कोलिंगाइटिस म्यूटेशन चला गया, आपको ड्रेन करना पड़ रहा है, आप सीवीडी के लॉट ऑफ प्रॉब्लम्स आते हैं. 30% केस में रीसिनोसिस हो जाता है. What about that? Out of all, even with the expert hand, if you go for the hepatocytosis, 30% stenosis is there. If the restenosis, the recurrent stenosis, patient will certainly end up in liver transplant. And cost of the liver transplant, again there is a problem. The problem starts It is a nitrogenic injury. It is not a natural or congenital process. And we as a professor, we as a teacher, we should think about this. Yes, sir.
Thank you, sir. I request Dr. Dhanesh Kumar, sir, to felicitate Dr. Dheeraj Palyan, sir. Moving ahead with next lecture, I request Dr. Akhil Gupta, sir, to chair the session. And Dr. M.K. Maheshwari, sir, to chair the session.
Topic for our next session is CT stone optimal management. Now I will request Dr. Devendra Singh, sir, Professor Surgery, AIMS New Delhi, to deliver the lecture.
So good afternoon, respected chairpersons, senior faculty members and dear colleagues. I am Dr. Devendra Singh, Assistant Professor in the Department of Surgery, AIMS Delhi, and it is my pleasure to be here with you today. I thank the organizers and also congratulate for organizing such a wonderful and insightful academic event and giving me the opportunity to present on CBD stones, the optimal management, which has very high morbidity and sometimes these may be fatal also, like pancreatitis, cholangitis or surgical optic jaundice. And CBD stone not only affects the poor people, it is a disease of, it can affect any people, like the most famous politician Bill Clinton and Edward Anthony, the president of UK, was also suffered from this. And we have to make decisions whether we have to go for ERCP or CBD, single stage laparoscopy CBD exploration. So we will dwell in this topic and at the conclusion we will decide in which situation what to do. So choroidiasis refer to presence of stones in the common bile duct, and it is the most common pathology, benign pathology of common bile duct. Mostly these are secondary stones which form, which means it are formed in the gallbladder and they migrate to the cystic duct into the CBD. And only 5 to 10% of cases these are primary CBD stones, which are usually pigment stones. The incidence of concurrent bone stones in CBD stones ranges from 10 to 20%. And the management of CBD stones depends on the timing of diagnosis in relation to cholecystectomy, whether they are diagnosed in the pre-operative period or post-operative period. In the era of open surgery, the management of CBD stones was straightforward and there was no debate, and it was open CBD exploration with or without T-tube drainage. But with the advent of laparoscopy, there has been a paradigm shift, and the various treatment available options include ERCP, the single-stage laparoscopic CBD exploration, or laparoendoscopic granulars technique, which means along with cholecystectomy, intraoperative ERCP is done, and the fallback option when everything fails is the open CBD exploration. Patient presenting with right upper quadrant pain and elevated liver enzymes in polycytic pattern can be categorized into high risk, intermediate risk, or low risk as per the American Society of Gastroenterology guidelines. The high risk predictors include, in the high risk group, the probability of CBD stones is more than 50%. In the intermediate risk, it is 10 to 15%, and low risk is less than 5%. The high risk predictors include CBD stones on ultrasound or any other cross-sectional imaging, features of acute cholangitis, or serum bilirubin more than 4 mg per deciliter, and the features of dilated CBD on ultrasound, which means a CBD more than 6 mm in a patient with gallbladder in situ, and if a patient has history of cholecystectomy, then we take the diameter to be 8 mm. For patients with intermediate risk, the predictors include abnormal liver function test, that means raised serum bilirubin and raised alkaline phosphatase, age more than 55, and dilated CBD on ultrasound or any other imaging. In these patients, MRCP should be done as the first line of investigation to rule out CBD stone. But if MRCP is negative for CBD stones and the probability of stone is very high as on per your liver function profile, then endoscopic ultrasound should be done in these patients, because endoscopic ultrasound has higher sensitivity in detecting small CBD stones less than 5 mm. And if the patient has no such predictor, then we can directly go ahead with simple cholecystectomy. So for patients with concurrent gallstones and CBD stones, we have two approaches, either the conventional two-stage approach or the single-stage approach. The conventional approach or two-stage include pre-operative ERCP followed by cholecystectomy, and this can be done in the reverse manner, where initially cholecystectomy is done followed by post-operative ERCP. But the major limitation of post-operative ERCP include, if the procedure fails, then the patient has to undergo the risk of general anesthesia and another intervention. So this procedure is usually not followed in most of the centers.
The single stage technique include laparoscopic reduced technique, the lap CVD exploration or open CVD exploration. The main advantage of laparoscopic reduced technique include here the contrast is given in the anterior manner. That means the contrast given to the cystic duct. And routinely ERCP we inject the contrast from the lower anal CVD. So there are chances the contrast may get into the pancreatic and lead to post-op pancreatitis. And second thing is that the CVD cannulation occurs selectively over a guide wire which is past the cystic duct. So there are very minimal chances that the guide wire going into the pancreatic. So the chance of pancreatitis is significantly diminished. So now let's see what the current literature suggests. This was the network meta-analysis comparing the 4 treatments for CVD stones. It included 20 RCTs with more than 2,500 patients. The 4 treatment modalities studied included the single stage laparoscopic reduced technique, lap chole with lap CVD exploration, preoperative ERCP followed by chole, and cholecystectomy followed by postoperative ERCP. And the author found that the single stage approach was associated with superior outcome in terms of primary duct clearance, the morbidity and length of hospital stay. And among the 2 single stage approach, the author found that the single stage laparoscopic reduced technique has marginal advantage over laparoscopic CVD exploration in terms of less bile, but the difference was not statistically significant. This another meta-analysis comparing the 2 single stage approach also found that the surgical success rate between the 2 single stage approaches is similar. The operative complication was also similar, and the operative time were also similar in both the arms. This meta-analysis compared the conventional 2-stage approach to the single-stage laparoscopic CVD exploration, and the author found that the single-stage laparoscopic CVD exploration scored over the conventional 2-stage approach in almost all parameters like stone clearance rate, the complication rate, retained stone, operative time, length of hospital stay, and mortality. So the author concluded that for patients with concurrent gallstone CVD stones, the single-stage laparoscopic CVD exploration is superior both in terms of perioperative safety and efficacy, and should be considered as optimal treatment of choice for patients with concurrent gallstone CVD stone provided the expertise is available. This study from our own center by Professor Bansal, here in the RCT we studied the 2-stage approach to the convention to the single-stage laparoscopic CVD exploration, and we found that the single-stage approach was associated with shorter hospital stay, need for fewer interventions, and cost effectiveness. Because in the waiting period, sometimes we clear the COD and we wait for interval cholecystectomy for 6 weeks, then CVD stone again recur. This meta-analysis from our center also showed that laparoscopic CVD exploration is superior to conventional 2-stage approach, but the thing is that the expertise should be available. This is the latest systemic review and meta-analysis on this debatable topic, published in 2024. And here also, the single-stage approach was found to be superior than the conventional 2-stage approach. Now coming to the downside of ERCP. ERCP is not free or immune to complications, and sometimes these may be fatal also, like pancreatitis, cholangitis, perforation, bleeding, or even mortality has been reported. And this is the data from latest Mango 13th edition. And sometimes the ERCP is not technically feasible, like in patient with post-bariatric surgery like groin gastric bypass or mini gastric bypass, patient after CS stomach surgery with Bilirod 2 reconstruction of stomach, patient with post-carcinoma cheek with inadequate mouth opening due to radiotherapy, proximal CVD stones or hepatolitiasis, and in patient in which CVD cannulation fails, then CVD exploration is the only or last final resort. The laparoscopic approach to CVD can be approached to 3 ways, either transcystic route, the transcorridocal route, or the laparoscopic reduced technique. In transcystic route, a nick is given on the cystic duct, then a balloon dilator is passed to the cystic duct and the cystic duct diameter is dilated. Then a guide wire is passed over which the colposcope or ureteroscope is passed. Then stones are localized and they can be removed either using copious suction irrigation, Dormier basket or Fogarty balloon catheter. Completion cholangiogram is done to ensure that the screen is completely clear, and then laparoscopic cholecystectomy is performed in a routine fashion. But the success rate of this procedure is only 80 to 90%, and it has some limited indications, like stone should be less than 5 mm, the size of the stone should be less than 5 mm, the CVD should be less than 10 mm, and the stone should be located in the distal CVD. The contraindication to this approach include tortuous or medial insertion of cystic duct, proximal CVD stones located at the level of hepatic hilum or above, and CVD stones more than 6 mm. So its role in the Indian setting is limited because we usually encounter patients with heavy stones, large stone size and heavy stone load, and sometimes due to repeated attacks of cholangitis, the cystic duct is usually fibrosed. So this approach is usually not followed in our scenario. Next is the advantage of transcystic CV exploration include, obviously it is less invasive and leads to less morbidity. The patient goes home in the second day as cholecystectomy. But the limitation include the success of this procedure is limited by cystic duct diameter and also depends on the size of the CV stone. The transfollicular approach is the more versatile and the commonly followed approach all over India. Here, after cooperation of duodenum, the CVD is identified and a choledochotomy of 1 to 1.5 centimeter is made in the supraduodenal part, depending on the size of the stone. And the stone is retrieved either using a blunt instrument like crochet forceps, Dormia basket or Fogarty balloon catheter. Then choledocoscopy is performed to ensure complete clearance of CVD. Then choledochotomy is closed. The relative contraindication to transfollicular approach include hostile abdominal from previous surgeries or radiotherapy, presence of portal hypertension with portal varices in the region of CVD, intolerance to major upper abdominal surgery or unfit to general anesthesia, lack of expertise, or small undilated CVD less than 8 millimeter. Because in such patient, if you plan for left CVD exploration, there is a high chance that the patient may go into stricture formation. The advantage include the success of this procedure is not limited by the diameter and it can be performed for large stones. Limitation is technically more demanding. You require endosuturing skills and there is slightly increased risk of postoperative bile leak and stricture formation if the procedure is not done meticulously. This meta-analysis shows the compare the transcystic versus transfollicular route and the answers were quite obvious. The transcystic approach was associated with lower duct clearance rate, shorter duration of surgery, less bile leak, and shorter hospital stay. And vis-a-vis the transfollicular approach was associated with higher duct clearance rate and higher bile leak. This image shows the layout of OT for patient planned for laparoscopic CV exploration, and the only difference from the conventional cholecystectomy include here the epigastric port is placed more toward the right side to facilitate cholecystectomy of the lower end of the CVD, and an extra 5 mm port is placed in the left upper quadrant to facilitate cholecystectomy of the upper end. And a surgeon planning for laparoscopic CV exploration should have following instrument in his armamentarium like nephroscope, choledocoscope, lithotripter, balloon dilator, Dormia basket, triflex and biflex instrument. So the first step, as I mentioned, is the cooperation of duodenum. Usually in some patients we encounter dense abrasion in the region of hepatocystic triangle due to repeated attacks of cholangitis. So meticulous and patient-full dissection is needed. And after cooperation of duodenum, we identify the CVD. Then choledochotomy may be performed either using a harmonic shear, hook cautery or cold knife, depending upon the availability of resources and surgeon preference. Next, choledocoscopy is performed either using a rigid nephroscope or flexible choledocoscope. The major limitation of flexible choledocoscope include it is more costly and it is more fragile. On manipulating through the angles of CVD, the fibers get broken and the illumination is decreased. So in our scenario, the nephroscope is a safer and cheaper alternative. The stones can be retrieved from the CVD either using a blunt instrument like crochet forceps, copious suction or irrigation, triflex, biflex instrument, or using a Perkins circle. Sometimes the stones may be badly impacted. At these times, the presence of lithotripter is a great boon, which help to disintegrate the stone into small pieces that can be easily retrieved. Another way to remove the impacted stone is using a Fogarty balloon catheter. The Fogarty is passed beyond the stone, then 0.5 ml saline it is inflated, and then we can retrieve, and sometimes it works, the stone gets disinfected. Then check cholecystectomy is performed. This is from the epigastric port. Here you can see the lower end of CVD, and now we are in the duodenal mucosa. You can see the pancreatic ampulla also in this. Now through the left upper quadrant port, the upper part of the cholecystectomy is performed. Right and left hepatic ducts are clearly visible, ensuring that our CVD is completely cleared of all the stones. Then cystic duct can be taken either using a conventional sutures, endoclips or hemlocks, or using an endo-GIA stapler, depending on the diameter of the cystic duct and the availability of resources. If the cystic duct is wide, then we can use suture or endo-GIA stapler, and if it is short enough, we can use hemlock or simple clips also. Then corticotomy is closed either primarily using a PDS or Michael suture, we prefer PDS, or it can be closed over antegrade biliary stent. The use of TTU is currently not recommended in literature because it significantly prolongs the operative time and length of hospital stay. This is a study comparing the T-tube drainage versus primary duct closure, and the author found that the T-tube drainage was associated with longer operative time, longer duration of hospital stay, and there was no overall benefit, so routine use of T-tube is not recommended. Similarly, this meta-analysis also showed that primary duct closure was associated with shorter operative time, less medical cost, shorter hospital stay, and less complication. So it is a proven fact that we can close the CVD directly. Now coming to some special scenarios, if you encounter a patient with asymptomatic CVD stones, what is the optimal treatment? So the current literature is in the favor of offering endoscopic intervention to such patient because in the waiting period it has been observed that these patients may have higher complication rate compared to the general public. On the same lines, the various international guidelines like American Society of Gastroenterology, the British Society, Japanese Society and European Society also recommend that if the patient is medically fit, he should undergo endoscopic intervention for asymptomatic CVD stones. Next, if we encounter a patient with CVD stones, but he has no gallstone, what is the treatment for gallbladder? So the current literature favors that gallbladder surgery should be done along with cholecystectomy because in the waiting period, the complication rate was higher in the patient in whom gallbladder was retained. So to summarize, if we encounter a patient with CVD stones and he or she has concurrent gallstones, we have three options: either the conventional preoperative ERCP followed by cholecystectomy, or laparoscopic radius technique, or the single stage laparoscopic CV restoration. The absolute indication of preoperative ERCP followed by cholecystectomy include patient with cholangitis, pancreatitis, or high serum bilirubin. The limitation of laparoscopic radius technique include in this we require the presence of both surgical team and endoscopic team in the operation theatre, which leads to various logical issues, and the patient needs to be positioned in the prone position for ERCP. So it increases the operative time also. If we are planning for laparoscopic or open CV restoration and on imaging and on intraoperatively we found the CV is grossly dilated, there is some distal narrowing and there are multiple stones, then some sort of drainage procedure should be added because these patients are at a higher risk of recurrent stone formation. So we can add choledochoduodenostomy if the duodenum is normal or hepatochoduodenostomy depending on the condition of the duodenum. And suppose we encounter a patient with CV stone in the post-cholecystectomy period, then if the stone size is less than 8 mm and located in the distal CVD, then ERCP is the first line of treatment. And if we encounter a patient with dilated CVD and stone size is more than 1.5 cm located in the proximal CVD, then laparoscopic or open CV restoration scores over the ERCP. So to conclude, ladies and gentlemen, the optimal management of CVD stone depends on the patient characteristics, the stone characteristics, biliary anatomy and the surgeon experience. If the patient is a good surgical candidate with favorable biliary anatomy and the surgeon has adequate experience, then single stage laparoscopic CV restoration always scores over the conventional two-stage approach. But on the contrary, if the patient is a poor surgical candidate, CVD is not dilated and the surgeon has less of expertise, then two-stage approach is a better alternative. So the treatment should be tailor-made as per the patient requirement and no single treatment can be conferred as a gold standard till date. Thank you very much for your patient listening. I am open for any questions.
Informative talk, but I have got two queries. How to address the problem of gallstone-induced pancreatitis? One. And secondly, there is a problem of retained stone in CVD. How to deal with that?
The retained stones after cholecystectomy or CV restoration?
No. Suppose that poly has been done and somehow a small stone is left behind in the alkaline phosphatase is borderline. In such a situation, what should be done?
Most of the time, sir, the size of CV stones, gallbladder stones are less than multiple stones 2 to 5 mm. In such patients, we try to perform the cholecystectomy on early basis. But if the patient, on the contrary, has large single stone, large gallstones, and we can wait. So by this, we can prioritize which patient should be taken earlier, because the small gallstones are higher risk of causing pancreatitis, gallstone pancreatitis. And secondly, when you are performing cholecystectomy, then it is wiser that you hold the ureter at the heartman and neck, so that on manipulation, sometimes the stone slips into the kidney, and which may later present as pancreatitis. And the second question, retain stone, usually these are missed stones which are not checked on colposcopy. We are performing left CV restoration. So good colposcopy, as I have shown you, the lower and the upper end, mostly the stones are not there. And the patient has elevated liver enzymes like you have protein, then we should undergo preoperative MRCP, and MRCP is also negative. And the cholestatic pattern, the liver enzymes are high and the bilirubin is raised, ALP is raised, then endoscopic ultrasound should be done, because it has more sensitivity to detect small severe stones which are missed on your MRCP.
Can't be subject for ERCP. It will prove therapeutic as well as diagnose.
Sir, I have shown in my one of the slides, ERCP is not immune to complications. We can subject, no doubt, but there is, you have to confirm first there is a definitely some severe stone is there or not. If the patient has no severe stone, there is some normal distal narrowing. And if we do ERCP and there is some complication, then how will we explain why we have undergone ERCP?
Any other question from the audience? Please.
Dr. Devendra, it was a wonderful presentation.
Thank you for coming.
Based on the videos, the way you assimilated it, it was very nice. What's your take on using endobiliary stents? Two things I need to know. One, what kind of stents will you place, and the details about, and what difficulty do you find in putting in those various types of endobiliary stents?
Sir, personally, I have used 10 mm stent, 7 French, 7 centimeter long, and we usually, there is a RCT ongoing, we place in one group the stent, one prime closer, and we are finding no difference. But if the stone is badly impacted, we have to fit in the CVD multiple times, and the procedure is long. In such patient, we expect there is some blood clot which will impact the distal clearance, there will be spasm of sphincter. Then for prophylactic purpose, we place the endoscopic stent. Otherwise, as per the literature and our experience also, there is no routine recommendation to place a endobiliary stent.
I'm saying in the cases in which you plan to put in, suppose it was badly handled, there was a lot of stone, there was a lot of mucosal edema. In those cases, in spite of putting in a tube, which we don't now, putting in what type of endobiliary stent do you use?
Sir, we place 7 French plastic endobiliary stent.
And straight ones.
Double pigtail.
Double pigtail.
Sir, it depends on the availability of supply in hospital, because we do not ask the patient to purchase. Sometimes the double pigtail are there, sometimes the funnel shape, the upper part is funnel shape, lower part is funnel. So it depends, not on our preference, it depends on the availability of resources in our hospital. But if I am given the personal preference, then the funnel shape are better over the double pigtail, because while inserting the upper end, the funnel shape, the smaller part goes easily upside, and then you can insert in the lower end. But for double pigtail, it makes it really difficult to insert in the upper end of the pigtail.
And apart from that, I think that once you use the double pigtail, the size or the diameter of that pigtail is a big one, and the CVD is not too much dilated, chances of trauma are going to be more.
I agree with you, sir.
Maybe a J1 is going to be better. Wonderful. Thank you.
Thank you.
Thank you so much, sir. Now I request Dr. Akhil Gupta, sir, to felicitate Dr. Devendra Singh, sir. Now I request Dr. M.K. Maheshwari, sir, to felicitate Dr. Akhil Gupta, sir.
So the next lecture, I would request Dr. Sanjay Pandey sir to chair the session and Dr. Madhubala Gaur ma'am to chair the session.
The topic of our next section is liver abscess and hydrated disease of liver, diagnosis and management. I request Dr. Gajendra Bhati sir, Assistant Professor and Consultant GI, HPB and Liver Transplant Surgery, IMSR, Bhatinda.
I will request the chairpersons to kindly restrict the time to 20 minutes.
So, good afternoon to all of you. At the outset, I would like to thank Dr. Rohit Khatta, Dr. M.K. Maheshwari sir, Subharti Medical College for inviting me and for this opportunity. So, today I will be discussing about the liver abscess, hydrated cyst, disease of the liver and diagnosis and its management. So, coming to the liver abscess, by definition, it is a collection of pus inside the liver, either caused by bacteria, fungi or the parasite. Clinically, we encounter two very commonly abscess. One is amoebic liver abscess and another is pyogenic liver abscess. So, amoebic liver abscess is caused by the protozoan called Entomycolitica, and it's still common in tropical world, including the India. In India, around 60 to 70% of the cases caused by the amoebic liver abscess, and the major source of infection is either contaminated food or the water by the cyst of the Entomycolitica. So, this parasite usually infect the cecum and the ascending colon, and the extraintestinal manifestation present as a liver abscess in around 3 to 9% of the cases. The peak incidences are seen in 30 to 50 years of the age group, and males are 4 to 5 times more commonly affected. And alcohol consumption is one of the risk factors for this amoebic liver abscess. So typically a patient, a male, consuming a history for a long duration of the alcohol, and especially coming from the endemic area. So right lobe of the liver is more commonly affected because of the streamline phenomenon of the blood from the gut to the portal circulation. And some around 30% of patients may have both right and left liver lobe abscess, and around 15% of the patient may have multiple liver abscess, but most of the cases it is a single abscess. So now coming to the presentation of amoebic liver abscess, there will be history to the travel to the endemic zone, and usually there is history of short duration of fever, acute illness with malaise and the right upper quadrant pain. Some patient may present with the diarrhea, and around 10% patient may have jaundice at presentation. A few percentage of patients can come with the pulmonary symptoms as well. So when we work up the patient, there is a leukocytosis on complete blood count. LFT is deranged most of the times with raised alkaline phosphatase, bilirubin and transaminases. Stool microscopic examination is present in around 10 to 40% of the cases, but only in the presence of intestinal amebiasis, otherwise it may be negative also. Serum-based tests, ELISA and all, they are more sensitive to detect, and they are posted on 95% of the cases. Experience from the amoebic liver abscess is very characteristic. This is an odorless fluid which contains acidular proteinaceous material. We call it anchovy sauce. It is a brownish color pus and characteristic. And antigen in this pus is seen around 95% of the cases. So when we image the liver, there is a USG which commonly used as a first line investigation, shows hypotonic lesion with some debris inside. CT is done, shows hypotense lesion with the thin rim of the enhancement in the periphery, and usually the single lesion is seen. The amoebic liver abscess can complicate, either it rupture into the abdominal cavity or it can rupture into the thoracic cavity. So some complication can occur because of non-rupture also. Commonly, if rupture occurs into the abdomen, there can be peritonitis, sepsis. Patient can present acutely in the emergency. Rupture into the thoracic cavity can lead to the empyema of the lungs. There can be pericardial rupture leading to the tamponade. And abscess can cause vascular thrombosis in the liver, leading to the portal vein thrombosis, hepatic vein thrombosis, portal hypertension. In some cases, these complications can be seen. And finally, if it can be superinfected, the patient can present with the sepsis, multiple organ dysfunction syndrome as well. So treatment of the liver abscess is primarily medical, given for all the patients. Drug of choice is metronidazole, 10 mg per kg body weight, 8 hourly, and 3 divided doses, and given up to 7 to 10 days. If abscess detected is very small, uncomplicated cases, medical treatment is only treatment which is required, and the recommendation is the treatment to be followed by the luminal herbicides like dialexone, furoate, 500 mg twice a day for up to 20 days. So coming to the indication for the percutaneous drainage for the sepsis, ECD is indicated and abscess is especially large, more than 10 centimeter, situated in the left lobe of the liver, and there is an impending perforation of the abscess. When abscess is covered by thin rim of the liver parenchyma, and either it is superinfected with the bacterial infection or already ruptured cases, sometimes ECD is indicated. You see in the right lower picture, characteristic color of the abscess is seen, the brownish color and curvy sauce liver abscess. So now I am going to discuss about the pyogenic liver abscess. So liver can be exposed by the multiple routes through the bacteria. Nowadays, in recent times, biliary tree is the commonest one through the ascending cholangitis. Multiple pyogenic abscesses are developing. Another route is portal vein route. Bacteria will migrate through the portal circulation through the liver. And in some drug addict patients, hepatic artery route is one of the common route. Sometimes there will be direct extension of the pus from the gallbladder. In cases of PIOC, GB, pus may extend to the liver. For some cases of trauma, there can be secondary infection and development of the liver abscess. The microorganisms involved most commonly are Klebsiella pneumoniae, but in many cases there are multiple microorganisms are involved, like E. coli, Pseudomonas species, Streptococcus, and Staphylococcus. Mostly pyogenic abscess is multiple, involving both the lobe of liver, and patient is usually elderly male, having immunocompromised status, already diabetic or multiple other immunocompromised morbidity. So treatment again for the pyogenic liver abscess is primarily medical. So we have to start antibiotics, the culture has to be sent. Aspiration or percutaneous drainage indicated for some selected group. Overall management of the liver abscess. In many cases, when we do the percutaneous drainage, either it's a pyogenic or liver, either it's the abscess is very large in size, usually more than 5 centimeter, and patient doesn't respond to the medical treatment. Both ECD or percutaneous aspiration is indicated, which give diagnosis and culture of the pus for guiding us the treatment. So now I am going to discuss about the hydrated disease of the liver. Hydrated disease of the liver is a zoonosis. It is transmitted to humans by the Echinococcus granulosus. There are two main forms of this parasite. One is Echinococcus granulosus, another is multilocularis. The most common is Echinococcus granulosus, which infects the humans. So there are around 1 to 3 million people affected worldwide, and the high incidences area are Middle East, South America, and Central Asia and India is one of the regions with the endemicity of this disease. So as we know, the dogs are the definitely host of the parasite, which harbor the larval, which harbor the adult worm. The sheep, cattle, and the humans are the intermediate host. The transmission of the parasite is by the contaminated food or water or very close contact with the pets. So this diagram is very popular. We have seen how the cycle of this parasite goes. Dog has adult worm which releases multiple cysts. They enter into intermediate host and develop the hydrated cyst. And when the dog eats the flesh of these animals, again adult tapeworm develops into the dog and cycle goes on. Humans are incidentally affected, and they are dead-end host, and the disease is not transmitted from humans to the humans. So very characteristically, hydrated cyst has the three layers. There is ectocyst, pericyst, ectocyst, and the endocyst. The outer layer consists of the host tissue reaction to the parasite. Ectocyst is laminated membrane and it is secreted by the parasite. And this is permeable membrane which maintains the nutrients to the parasite. The endocyst is the active layer. We call it germinal epithelium, which forms the scoliosis, daughter cyst, hydrated brood, and the brood capsules. So, aim of any intervention or surgery is to remove this endocyst and the ectocyst. Clinically, hydrated cyst remains silent for a long, sometimes detected incidentally. Usually the patient is a young age group. Most common symptom is upper quadrant pain, and the signs is sometimes palpable mass in the upper quadrant in case of liver hydrated. But sometimes patient present with the complication of cyst. In case of cystobiliary communication, there can be obstructive jaundice, there can be fever and cholangitis. Cyst rupture into the peritoneum can present as a peritonitis acutely in emergency as anaphylactic shock. There can be acute presentation of the cyst. So diagnosis of liver hydrated based on the history, examination, imaging and supported by serology. Finally, the microscopic examination for the cyst confirm the diagnosis. Blood investigation shows the CBC may show increased TLC counts in case of secondary infection only, otherwise it may be normal. Eosinophil count may be raised in around 20 to 30% of the patient. LFT may be deranged in case of cholestasis when there is a complicated cyst and cystobiliary communication is seen. ELISA for detecting of the IgG antibodies remains the main serological test for the hydrated. Imaging on X-ray, hardly 10% of the cyst which shows calcification may be detectable. Otherwise, the ultrasound of the abdomen remains the screening method of choice, and the diagnostic accuracy is around 90% for the detection of the liver hydrated. So USG has a very characteristic finding of the disease. In simple cyst can present as anechoic and well-defined cyst into the liver. The dependent debris may present as a hydrated sand, and there are signs very characteristically described as a honeycomb and cartwheel signs which suggest the presence of the multiple daughter cysts inside the liver. The detached membrane of the endocyst can present as a floating membrane, also described as the water lily signs, and calcified cysts may be seen with the high ecogenicity and posterior shadowing. So WHO has classified the hydrated to CE1 to CE5. CE stands for cystic echinosis. CE1 is unilocular cyst, a simple cyst which is active. CE2 is multivascular cyst which is also active cyst. CE3B, A and B are the cysts which is having detached membrane and the daughter cyst. CE4 and 5 are the inactive cysts of the dead cyst. For imaging of hydrated, CT scan is required when we are taking the patient for the surgical planning. CT will exactly tell us the location and the site and the number of the cyst. And it shows the usually hypotense and very sharply marginated cyst with the rounded borders with the thin rim density. And the information of the vessels, the nearby hepatic veins and portal veins, very well demarcated by the CT scan. Other investigations are required. MRCT may be helpful when there is a suspicion of the cystobiliary communication. ERCP, some cases it may be required, again in the presence of complicated cyst. For the cases of obstructive jaundice and cholangitis, ERCP will be both therapeutic and the diagnostic as well. Liver hydatitis complications are common, especially with the large cyst. Incidence of complication around 20 to 30% of the cases. Commonest is secondary infection by the bacteria, formation of abscess and pus. Another common complication is intrabiliary rupture leading to cholangitis, obstructive jaundice, and sepsis. Intraperitoneal rupture and intrathoracic ruptures can rarely occur. So now I will discuss the management of the hydrated. There are three modes of management: medical treatment, percutaneous techniques, and the surgery, which still remains the mainstay of the treatment. Surgery can be either laparoscopic or open surgery. Nowadays, most common surgical modalities used in laparoscopy DUP. Medical management, coming to the indication, is for very small cyst, single cyst less than 5 centimeters in diameter. For some cases, when disease is widely disseminated, or some selected case of ruptured cyst, or there is a recurrent hydatidosis after the previous pair or previous surgery, or very poor surgical risk patient which are not fit surgically, medical treatment will be done, and medical treatment is required for almost all the cases. The drug of choice is albendazole. The doses are used is 10 to 15 milligram per kg per day with 2 divided doses. The duration, it has to be started the pre-intervention or pre-surgery 1 to 4 weeks, and to be continued at least 3 months post-operatively. And the albendazole should be taken with the meals to enhance its absorption with the fatty meals. And the drug has some side effects in some around 5 to 10% of the patient, may cause GI symptoms, elevated liver enzyme and leukopenia. So patient to be at least followed 2 weekly for the LFT and CBC. Percutaneous technique has some role in some selected cases. Indications are active cyst, WHO classification CE1 and C3A, and cysts which are sometimes not amenable to surgery, poorly surgical candidate, not fit for surgery, having comorbidities, sometimes some recurrent cysts after the previous surgery, or some cases where surgery is not accessible, the route, and percutaneously the route is accessible. Percutaneous technique can be considered. Percutaneous technique usually contraindicated with the cyst with the multiple daughter cyst, any complicated cyst, when cyst has a communication with the biliary system for the risk of the secondary cholangitis and the bile leak in the post-procedure period. Any superficial cyst which is at the risk of rupture after the puncture. Calcified or inactive cysts do not need any treatment, CE4 and CE5. So there are multiple techniques described. Commonly used is PAR technique, puncture aspiration, injection and re-aspiration. There is a percutaneous evacuation of the cystic content technique, and there is a modified catheterization techniques also described. These techniques are more or less similar, depending upon the catheter size and the access route. A little bit of difference is there, but indicated for very selected cases. So now we are going to discuss about the main stage of the treatment, that is surgery. Surgery is indicated for large symptomatic cyst, which is usually more than 10 cm in the size. Any superficial cyst which is at a risk of rupture, cyst with the daughter cyst, and there are cysts which is infected with the formation of the abscess. All complicated cyst surgery is indicated as a mainstay of the treatment. Or when any failure of the percutaneous technique or medical therapy, again surgery will be indicated. As I told, the inactive cysts usually don't require any intervention, only medical treatment is suffice for that. So there are principles of hydrated cyst surgery. The main thing is avoidance of spillage of the cyst content. Any hydrated cyst fluid or the daughter cyst has to be prevented to spillage into the abdominal cavity. Another thing is complete removal of all infective component of the cyst. And if there is a communication between systems, biliary system, especially in case of hydrated disease, that has to be taken care during the surgery. And finally, the management of the residual cyst, residual cavity, which is done by the omentopexy in all the cases. Surgical procedure we divide into either conservative surgery and or radical surgery. Nowadays, most of the cases are treated by conservative surgery, which includes the drainage and DUP or partial pericystectomy. Radical surgery can be performed for some selected cases or experience is available, which include total pericystectomy or formal hepatectomy, lobectomy, left lateral segmentectomy, or right lateral segmentectomy, depending upon the location of the cyst. So now there is scolecidal agents. There are multiple which are used, but most commonly used is hypertonic saline, 20% strength. The duration of the action is around 5 to 15 minutes. This is most widely used. Other agents are ethanol, chlorhexidine found in iodine solution, but still the use of these are contraindicated when intraoperatively we get suspicion of the biliary communication for the fear of biliary cholangitis or sclerosing cholangitis. So now this trocar is designed, we call it Dr. C. Palanivelu's hydrated system, designed by Indian surgeon. So this is helpful in draining the cyst without any spillage, developed to minimize the spillage and anaphylaxis. So we can see the trocar size is around 12 mm. There is a side channel for the suction of the content of the cyst, and one channel is there for instillation of solicidal agent, and scope can be introduced to the port for visualization cavity for assurance of the complete clearance of the cyst or to look for any biliary communication. So I am going to show you around this 2-3 minutes video of the commonest procedure of the laparoscopy routine.
कैमरा घुमा भैया, कैमरा घुमा भैया।
So this was young male came to us with a segment for hydrated cyst evaluated and taken for the laparoscopic routine. Short time I will try to go to the conclusion. Videos are videos. So I am just concluding by the last slide. So for liver abscess, the treatment primarily is medical treatment. For amoebic, it is amoebicidal drugs and biogenic broad spectrum antibiotic. Patient to be diagnosed as early and antibiotic to be started to prevent sepsis and organ failure. For hydrated cyst, the diagnosis is by ultrasound and is supported by serology. And surgical principle of the hydrated cyst to be followed, reducing the intra-contamination. And any cystobiliary communication, if it is there, to be taken care at the time of surgery. And finally, ometopaxy to be added for all the cases to reduce the bile leak and reduce the cavity size. So thank you for patience listening. Any queries I would like to welcome.
We are running short. I can see many hungry faces even, and still a malignant session is there, so no questions are. If there are any queries can be tackled during lunchtime. Thank you.
Thank you, sir. Now I request Dr. Madhuvara ma'am to felicitate Dr. Devendra Singh sir. Dr. Madhubala Gaur ma'am to felicitate Dr. Gajendra Bhati sir. I request Dr. Sanjay Pandey sir to felicitate Dr. Madhubala Gaur ma'am. session of our conference, malignant hepatobiliary disease session. To chair this session, I will request Dr. Umang Mittal sir, Oncosurgeon, Subharti Medical College. Dr. Satendra Kumar sir, Professor HOD, Government Medical College, Noida. The first lecture in this session is on the topic Liver SOL, overview with special focus on diagnosis and management of hepatocellular carcinoma. It will be taken by Dr. Gaurav Kaushal sir, Associate Professor, GI Surgery, AIIMS, Bhatinda.
A warm welcome to Dr. Kaushal, and of course we are between you and the lunch, but I think we'll try to finish a little bit early. We'll try to finish other 30 minutes, maybe 20 minutes each session. And liver lesions actually are a very important part of malignancy. If you look at this metastatic lesions, the most common malignant lesions of the liver. SCC per se, look at incidence and death rate, 36,000 in India every year, and almost the same number of people die. It's one of the worst diseases to happen and increasing day by day, and I think Dr. Gaurav is going to give a very good talk on that.
Thank you, sir, for a kind introduction and kind words. At the outset, I would like to thank the organizers and especially Dr. Mehta for having me here. So I'll be talking about liver lesion, which is a very broad topic, and I was told that I'll have 25 minutes plus 5 minutes, but the time has been cut short. I'll try to rush through the, not very important things. I hope I'll be able to justify. So I'll be talking about classification of the focal liver lesions, the imaging techniques which are used to diagnose, brief about the commoner focal liver lesions, and then I'll talk about the hepatocellular cancer. So we classify focal liver lesions into two types, which is the solid ones and the cystic ones. So solid ones, the most common are hemangiomas, which is a benign lesion, hepatocellular cancer, which is the most common primary liver cancer. Then we have various other lesions like liver metastasis, which are very common, adenomas, then focal nodular hyperplasias, then intrahepatic cholangiocarcinomas, endotheliomas, angiosarcomas. Cystic simple cysts are most common. Then we have thyroid disease, which Dr. Hari has discussed already. Polylocal cysts, polycystic liver disease, then mucinous lesions of the liver. We'll talk about the important ones in brief while we go through this presentation. So the imaging techniques which we use for these patients, ultrasound is the first one in which we suspect, and then we plan on to go for other imaging techniques to characterize and classify the various lesions and to see the risk involved for the malignancy. So multiphase CT, which is a contrast enhanced CT in which we take arterial phase, portovenous phase, and delayed phase, which is the most common imaging for diagnosing liver lesions. Then contrast enhanced MRI, which is probably nowadays more in vogue and maybe a tad better than contrast CT for diagnosing cystic lesions of the liver and in a lot of cancers of the solid lesions of the liver also. So for MRI, you can use extracellular contrast, which is the most commonly used. Hepatobiliary contrasts are also important and helpful in certain lesions, but the availability is not very common. And usually we use extracellular contrast in MRI. Contrast ultrasound, in which we use the contrast, we inject it IV, small micro bubbles are formed. These are usually used for a problem solving tool in a single lesion. So like ultrasound cannot screen the whole liver in one go. So if we have a one lesion and we are doubtful and we want to know whether it's a malignant lesion or not, then we can do contrast ultrasound. But otherwise, most common are CT and MRI. So I'll be talking in brief about the various lesions which can be seen in these patients. Hemangioma is the most common benign lesions. If we take 100 random people out of general population,
20 patients may have this lesion in the liver on cross-sectional imaging. And it's basically a cluster of blood-filled cavity which is lined by endothelial cells. So the blood flow is very slow. So this is not a hypervascular lesion on ultrasound also. And two types are there, capillary and sclerosing, so we will not go into detail of that. So the first picture which you can see is of the ultrasound, and with the Doppler color modes on, you can see there is no color in the hemangioma, in this one. In this one. So there is no color inside. So basically we expect that it will light up on Doppler, but it will not. So on the right side we have CT imaging showing sequential filling of hemangioma. So it's like centrifugal filling. So first we see contrast on the periphery, it's progressively increasing. So hemangioma, once we diagnose, if it's small, not symptomatic, leave it there. Even if it's large, no symptoms, leave it there, and patient does not need any treatment. Resection is usually for symptoms if it's causing compression of the adjacent organs, if it's rupture or if there is interlesion, hemorrhage, or if there is consumptive coagulopathy, then we can do a resection. You can see on this picture there is very large hemangioma around 18 cm in size, so we just do we just remove along the capsule. We don't need to do a formal liver resection for these patients. For patients who have ruptured or who are not candidate for surgery, we can do embolization also. So adenomas are again one of the common lesions, benign lesions in the liver. So usually they are asymptomatic. Females, they have more preponderance of developing these lesions. Patients who are taking hormonal therapy, for males it will be anabolic steroids, for females OCPs, they have more chances of developing these lesions. Obesity and glycogen storage disease are also risk factors. So basically, these are benign, but certain subtypes, they are classified into four subtypes. We will not go into details, but men have this beta-catenin type of adenomas, which have higher chances of cancers. So these patients may need resection. So this is a typical imaging of hemangioma, in which you can see on arterial phase it's lighting up, and in the delayed phase it may show a washout. So when we talk about various liver lesions, usually all the vascular lesions including HCC will have a arterial phase enhancement, and they may have a washout on the delayed phases. But the probability of having hepatocellular cancer is higher in patients with cirrhosis. So all these features are diagnostic for hepatocellular cancer in patients with cirrhosis. But in normal livers, we should not diagnose these patients with these features with having hepatocellular cancer. I'll again discuss this thing later on. So basically, the treatment of adenoma, if there is a female who has a more than 5 cm adenoma, we stop the hormones, wait for 6 months. If the size decreases, we put the patient on follow-up. If the size remains constant, we have to resect the adenoma because of the risk of bleeding. For patients who have less than 5 centimeters, we just do a repeat imaging at 6 months. And we do it twice, and if it's stable in size, we just keep on following the patient. Resection can be done for the patients. Again, for pregnant females, more than 6.5 centimeters, do resect the patient lesion. For all males having an adenoma, you should always resect because cancer risk is high. And transplantation can be done for the patients who have glycogen storage disease with multiple adenomas, which is more than 10 adenomas in the liver. And embolization may be done for tiding over the initial phase after bleeding, and later on the patient undergoes resection. FNH is a benign lesion, always benign, there is no exception to that. And it's the second most common liver lesion, benign lesion, after hemangioma. So basically it's apparent hemodynamics in the liver, and it leads to nodule formation, just like regenerative nodules in cirrhotic patients. Females have high incidence, but there is no relation with the estrogen levels. So MRI with hepatobiliary contrast, if available, it's not usually available. If it's available, it retains this hepatobiliary contrast even after 2 to 3 hours of imaging. So just to see, this shows a CT showing the contrast enhancement. In the middle, you can see a hypodense area, which is a central scar. So this central scar is seen in FNH as well as fibronebular HCC. But as I told, if we have hepatobiliary contrast, imaging after 2 to 3 hours also will show contrast retention in the lesion. So you can see this is a typical USG showing a cartwheel appearance. So as compared to hemangioma, this will have vascularity and it will show a typical cartwheel appearance. So treatment, if confirmed diagnosis on imaging, no need to treat, keep the patient on follow-up. If the symptoms you think they are directly related to FLH, you may resect but still counsel the patient because the patient may still persist to have symptoms. So again, try not to operate. If you operate, then again counsel the patient that patient may persist to have symptoms. If surgery is not feasible, we can do an embolization if we think the symptoms are because of this. So metastasis, these are usually multiple lesions. Most of the lesions which are coming from adenocarcinomas, from the colon or small bowel or other GI tract, they will be hypotense, like in this CT, hypotense, multiple lesions. There may be ascites also. Hypertense lesions or vascular lesions are seen from neuroendocrine tumors of pancreas or carcinoids of the gut and RCC. So we manage the secondaries as per the primary. So it can be curable or not curable. For fibronebular HCC, these are rare lesions, but these are seen in normal liver backgrounds. And these are usually young men, non-cirrhotic liver, and they are usually incidental. AFP is typically not elevated. If at all it is elevated, it's a very poor prognostic marker. Diagnosis is confirmed on biopsy, although imaging will show hypervascular lesion. I'll show that in the next slide. And this is a typical lesion. Again, I told you central scar is seen in FNH as well as this. So, but if you have a hepatobiliary contrast, FNH will retain the contrast, but it will not. So, the surgery is resection. If there are nodes involved, you should remove the nodes. Again, the recurrence is seen very commonly. There is no role of, very controversial role of neoadjuvant or adjuvant therapy in these patients. Okay, now I come to cystic lesions. Simple cysts are the most common. Again, around 10 to 15% of the patients will have these cysts if we screen in the general population. If there is some septation or no contrast enhancement, these are simple cysts. We can just leave the cyst for wait and watch. Probably there is no imaging required also, no follow-up is required, but if the patient develops symptoms in these patients, if the patient has high-risk features like septations, calcifications, neural thickening or neural nodules, then these patients need further evaluation and because the chances of malignancy is there in these patients. So treatment, as I told, if symptomatic, you can just do a fenestration or deroofing of these cysts by doing a laparoscopy or open surgery. We can also do a percutaneous aspiration of sclerotherapy. Aspiration without sclerotherapy has a very high failure rate to the tune of 50 to 60%. Polycystic liver disease is different from polycystic kidney disease associated liver cysts. So that is ADPKD, autosomal dominant polycystic kidney disease, in which kidney also will be affected. Polycystic liver disease is only liver will be affected, kidney will be dominant. So in these patients, multiple cysts are there. Symptoms can be there because of the compression. Patient may eventually may have hypoalbuminemia, malnutrition. For larger cysts, we can do sclerotherapy and deroofing. For multiple cysts and leading to liver failure, we may have to do a transplantation. Okay. So, mucinous cystic neoplasms, these were previously called biliary cystadenomas or cystadenocarcinomas. Now the term has been changed in 2019 by WHO. Now these lesions are basically neoplasms which are lined by cuboidal epithelium or mucinous epithelium, more common in females. In segment 4 is the most common. And basically these lesions will show septations in the cyst on imaging, on ultrasound as well as MRI or CT. As I told you initially that MRI is a better investigation to see the septations or neural nodules as compared to CT. So usually now, like when 12-13 years back when I joined my MCH, we were more inclined towards CT, but now more and more MRIs are being done and we are also becoming more comfortable with MRIs. So these are usually multilocular and there is around 10% risk of transformation into a cancer. So these patients usually should be resected. And As I told, a female with a lesion in the segment 4, usually these are biliary cystic neomas or business cystic neoplasm of the liver. And we should do a complete section. De-roofing is not an option. If we de-roof, these patients are going to recur to the tune of 80%. So hematomas or this von Melba complexes, you will see ultrasound reports suggesting these lesions, and the patient will come to you regarding the management. These lesions are benign. These do not convert to cancers. Extremely rare. Like there are few case reports. So if ultrasound is suggestive of this lesion, or if you get a CT done and you confirm with this lesion, no need to worry. Just reassure the patient. No need to follow up also. Just send the patient home and relax. So IPNB is biliary IPMN, which is like similar to the pancreatic IPMN. These are the biliary lesions which are present inside the liver. Similar to the IPMN in the pancreas, this will cause ductal blockage and dilatation. And the chances of cancers is more than 50%. Whenever you see this lesion, go and resect this lesion. Corticosteroids, I think already has been discussed. I will not go into the details. So type 1 and type 4 will have anomalous biliary or pancreatic junction. So these patients need excision of the extrahepatic biliary tree of the cyst. And these patients require a lifelong follow-up because the chances of cancers in the rest of the biliary tree are also there. It's not like once we remove the biliary tree, the cancer chances are gone. The intrahepatic biliary radicals they may also develop. And other, I think management has been discussed, so I will not go into detail. Hydrate disease has been very elaborately discussed by Dr. Bharti, so I will not go into the detail of hydrate cyst. So options again, management again have been discussed. So HCC, so hepatocellular cancer is the most common primary cancer of the liver, and the risk factors are basically cirrhosis. Cirrhosis, the most common etiology is hepatitis B or C infection. So etiology in Western countries it's Hep C, which is most common. In India it's hepatitis B, but from the region where I come, IV drug abuse is common, and hepatitis C is the most common etiology for viral hepatitis and cirrhosis. These patients, alcohol, obesity are also one of the more common factors. So if we prevent, we take care of these factors, we may prevent cirrhosis, but if the cirrhosis develops, these livers are very much prone to developing cancer. So diagnosis is by doing a contrast CT, which is pancreatic CT, as I told earlier, and FDG PET is not a usual investigation because these HCCs which are well differentiated, they do not take up the FDG contrast. LIDATS is the imaging modality, reporting modality which is used, which is liver imaging reporting and data system, which just like BIDATS in breast. And as we go from low grade to high grade, the chances of cancers are very high. So LIDATS 5 is definitely HCC, and we have to manage accordingly. This is the imaging system which is used for patients who have liver lesions in cirrhosis, not for non-cirrhotic patients. Again, these are the high-risk features, which is this non-peripheral contrast enhancement, non-peripheral washout. They can be a capsule, and they can be, if there is a growth in between two imaging features. So we categorize the patient as having high risk. So tumor markers, AFP is the most common marker which is seen if usually the cutoff is more than 20, and then we should suspect HCC. If it's more than 400, it's a poor prognostic marker. More than 1,000, it's a contraindication to transplantation patient. L3 fraction of AFP is more sensitive. PIVKA2 is also an important factor, and if we combine all these three, the sensitivity and specificity, the sensitivity will go down, but specificity will go very, very high. So staging is not like TNM staging. The factors which are involved is the tumor factors, the patient's liver status, and performance status. All three things are important. So when we talk about staging, the BCLC, this is Barcelona Clinic Liver Cancer staging, is the most commonly followed in the world. TNM is usually not followed, but it's a post-operative staging, and it does not include the liver status and performance status. So management options are ablations for smaller lesions and early cancers, which can be radiofrequency ablation or microwave ablation or cryoablation. Embolization can be blind embolization, it can be hemoembolization, or can be a drug-eluting bead embolization. That is, surgery can be resection or transplantation, and radiation can be selective radiation or can be a stereotactic radiation. So systemic therapy, sorafenib was the previous drug. Now it's less commonly used, and atezolizumab and bevacizumab are the first line therapy for this patient. Best supportive care is the most common treatment which we employ because most of these patients become child C, and surgery or other therapies are not possible. So these are the various slides. BCLC, again, very early stage and early stage. These are amenable to sections or ablations. And when we move on to advanced stage, C or terminal stage, it's mostly systemic therapy or palliative care or best supportive care. So I'll again skip these slides in the interest of time. Everybody's hungry. So transplantation basically takes care of the whole liver. So we replace the liver. So liver cirrhosis is taken care of. The liver which is at risk of developing cancer is taken care of. But again, the transplantation livers are very limited and centers are very limited. No, not everybody can afford. So we have to strike a balance between transplantation and resection. So it's the approach to FCC. So I will not again go into these for the interest of time. So in the summary, I would say the most lesions in healthy liver in patients who are not cirrhotic, these are benign lesions. So no need to rush for a resection of these lesions. Cross-sectional imaging, which is MDCT or CMRI, should be done for all the suspicious lesions when we suspect on ultrasound. Cystic lesions, whenever we see any signs of complexity in the form of nodules or septations, we should do a cross-sectional imaging, CMRI preferably. And in cirrhotic background, any new lesion, we should think of HCC and work up accordingly. Management of any suspicious lesion should be discussed in multidisciplinary team. It's not individual decision usually. We should have in our armamentarium of the various modalities of treatment like ablation, embolization, resection, and transplantation to deal with this patient. Thank you. A very well presented talk, and what is important to understand that SCC often is diagnosed late. So all patients with cirrhosis should have 6-monthly ultrasound and FFR protein, because that's the only way you can actually maybe diagnose them early. And today, even in bad cases, SBRT is coming as a very good tool for patients who cannot be operated or cannot be provided ablation. So I think that is what we need to understand. Any patient with cirrhosis need to have 6-monthly ultrasound. Absolutely. Ultrasound and maybe AFP also. As you told that probably I see around 60 to 80 cases of HCC every year, but we operate maybe around 6 to 7 HCCs in a year. So like very few, maybe 10% of them are actually candidates for surgery. Speaking only if less than 3 centimeter and less than 3, that actually is the indication of surgery. Otherwise, you go for transplantation. Any questions from the house? So with no questions, I think we can move on. Thank you.
Thank you so much, sir. Now I request Dr. Satendra Kumar sir to felicitate Dr. Gaurav Kaushal sir. I request Dr. Sanjay Pandey sir to felicitate Dr. Umang Mittal sir. I request Dr. Shashank Mishra sir to felicitate Dr. Satendra Kumar sir. So the last lecture of our CME, after it will proceed for lunch. To chair this session, I request Dr. Devendra sir. I also request Dr. Ritik Bansal sir, Onco-Surgeon, Subharti Medical Hospital. The topic for our session is gallbladder cancer, burden of diseases, clinical presentation, diagnosis and staging, surgery and adjuvant therapy. I request Dr. Kailash Pradesar, Assistant Professor GI Surgery and Liver Transplantation, AIMS New Delhi.
I have a request for our delegates, especially residents. This is the most important topic surgeons will encounter, even general surgeons will encounter. So please be patient for 20 minutes. See you all better. Hello, good evening everyone, and I want to say thank you organizer, especially Professor Maheshwari and Dr. Rohit Bhatta for inviting and giving me this opportunity. So, so I am giving the brief review of gallbladder cancer, and we should know this is one of the most common malignancy of especially our country. So. So this is a part of biliary tract cancer, and there are biliary tract cancer which are include intrahepatic cholangiocarcinoma, extrahepatic biliary cancer, and gallbladder cancer is the part of biliary tract cancer. So gallbladder cancer can have type of hepatic bed type in which the lesions are located in the body and fundus, and they directly infiltrate into the liver or maybe nearby structure like colon, duodenum. And another type is the hepatic hilum type, in which the tumor is located at the cystic duct or infundibulum. These are tumor are prone to invade the biliary CBD and CSD, and also this is the one of the most anatomical busy area. So these tumors involve the vascular structure, and sometimes the patient have combined hepatic bed as well as hepatic hilum type of cancer. So this is the fifth most common GI tract cancer, but most common biliary tract cancer worldwide. And around 0.5 to 1.5% of the patient present as an incidental gallbladder cancer. So incidental gallbladder cancer is the true incidental gallbladder cancer is those patients those don't have specific symptom, and there is no any suspicious finding on the imaging as well as intraoperatively. These patients underwent cholecystectomy and final histopathology came out that this is the gallbladder cancer. So these are the true incidental gallbladder cancer. So see, this is one of the more very lethal disease, and 5-year survival is very less, around less than 5%, and only around 21 to 69% of the patients may can achieve R0 resection. So what is the epidemiology of gallbladder in India? So this is India is one of the high incidence area for gallbladder cancer, and it accounts around almost 10% of global of the GDP. And in India especially, with very high incidence in the North India, especially Uttarakhand, UP, Bihar, and then we go to the northeast area. This is a very common malignancy, and usually affect in the younger age group than compared to West. And around 80% of the gallbladder cancer patients have gallstone disease. So what are the various risk factors? So there is a epidemiological trial which include the susceptible host. So these are the especially female patients, those are multiparity, early age of pregnancy. These are the susceptible host, and there are multiple factors which are included cholelithiasis, porcelain gallbladder, especially the focal calcification. These are the various risk factors for gallbladder cancer, and obviously these are the environmental and other toxic substances which can lead to gallbladder malignancy. So there are various pathogenesis of gallbladder cancer. Mostly these patients develop metaplasia, dysplasia, carcinoma sequence. So with these sequence, the most of the lesions usually remain flat. So these are very difficult to, sometimes very difficult to diagnose even on imaging. And another sequence is the adenoma carcinoma sequence. In these, the tumor develop as a polypoidal lesion. And recently WHO nominated it is as a intrapolycystic capillary neoplasm. So what are the various clinical presentations? Most of the patients in early stage remain either asymptomatic or there is no specific symptom. These are similar to gallstone disease. Or most of the scenario, these patients present either incidental gallbladder cancer, as I told you on the we diagnose after cholecystectomy, or sometimes discovered intraoperatively and suspected before surgery. So there is a this is the study from PJ where previously I was working. So there are many patients, we label them as incidental gallbladder cancer, but these are not a true incident in our scenario, because we saw those patients referred as incidental gallbladder cancer. Many of the patients when we thoroughly evaluated from the clinical history, preoperative imaging, many of the patients, they have some indicator. These patients have malignancy, like patient having weight loss, ultrasound some thickening, and sometimes marks which are missed on the by the treating surgeon. So abdominal, if the patient is symptomatic, abdominal pain is the most common symptom, and other symptoms are jaundice, weight loss, or anemia. But these, if the patient develop these symptoms, these patients are always advanced disease, mostly unresectable or metastatic disease. So how to diagnose these patients, gallbladder cancer? As I mentioned, most of the patients in early stage gallbladder have asymptomatic or symptoms similar to biliary colic. And there are some differential diagnoses of these are the genitourinary cholecystitis, patient have Mary syndrome, gallbladder cancer. So there are radiological variants of gallbladder cancer. These can be asymmetric wall thickening, mass replacing the gallbladder GG, and intraluminal mass. So ultrasound is the most important investigation, and it should be interpreted carefully. And so it can reveal a thick wall gallbladder. So what is the definition of thick wall? Any gallbladder, whether it is focal or symmetrical, wall thickness is more than 3 mm, these should be considered as a thick wall GE. And these patients should be thoroughly further evaluated by cross-sectional imaging, CT scan, MRI. And around there are a study published by in IGBJ group. There are around 3% of the patients those having thick wall disease may have gallbladder cancer, and also those patients in the genitourinary cholecystitis, there is an increased risk of gallbladder cancer. So, like to the LIRATs, BIRATs, there are recently GB rates also mentioned. So I will not go in the detail, but this is the one of the very important thing by on ultrasound finding which can give some clue to whether patient have high risk for malignancy or not, and then treat accordingly. So that few salient points is if there is a we saw loss of layer pattern in the ultrasound, as well as if there is some thickening which is infiltrating into the liver. These are the patients which have high risk for gallbladder cancer. So what is the role of tumor marker? So there is no role of diagnosis in the gallbladder cancer. But these tumor markers like CA, CA99, CA125, these are prognostic role if the patient has diagnosis of gallbladder cancer and the tumor marker is elevated, and also help in the follow-up if the patient develops recurrence. So for staging workup, we should do the once the patient has suspicion or in the ultrasound, we should do the cross-sectional imaging. Mostly we do the CT scan, and there is no metastatic on the CT scan. Then we do the PET scan, and just before the surgery, we do the staging laparoscopy. So these are the few images which show that there is a asymmetrical thickening, mass, and which are in favor of gallbladder cancer. This is the imaging as well as intraocular cost of picture of the patient which of genitourinary cholecystitis. If you see that there is these are the characteristic feature of genitourinary cholecystitis. We see the hypodensity in the wall. So these are in favor of genitourinary cholecystitis. Because of there is a pathogenesis of degenerative foamy macrophage which lead to the hypodensity. So coming to the what is the role of whether we should do or not routine PET CT. So there are now there are many literature showing by doing the PET CT in the resectable cancer, we still there is around 10 to 25% of the patient may have up-stage disease. And if there is a metastasis, then there is no any role of palliative surgery. So if there is definitely there is role of PET scan in staging work. Another important thing if we should whether we should do or not routine staging laparoscopy. So again I say if there is a metastatic gallbladder cancer, there is no role of palliative surgery for gallbladder per se, and gallbladder cancer is associated with very high incidence of occult metastatic disease. So around 1/3 of the patients we can avoid the unnecessary laparotomy, and these patients can go early palliative treatment. So there are Indian experience around 25% to 33% of the patient can die, have metastasis on staging laparoscopy. So coming to the staging, so there is I will not go in the detail regarding this. So especially there is a now in staging there is a stage T2A and T2B lesion. So T2A lesion are those lesions having location toward the peritoneal side, and T2B lesion those lesions having the lesion toward the hepatic side. So there is this have prognostic role. So if the patient having the peritoneal side, the prognosis of the patient after surgery will be certainly good. Now coming to the ones we do the staging workup and there is no metastasis, we plan for surgery for in the resectable patient, and extended cholecystectomy or we say radical cholecystectomy that surgery for these patients. And the steps for that we do first the staging laparoscopy. If there is no metastasis, then we go usually we do the open surgery by using the Makuchi incision. Then after the incision, then again confirm that there is no metastasis. We first do the duodenum pulverization and do the autocaval lymph node sampling. This is the area of autocaval area just below the left renal vein. So if these lymph node we send routinely for frozen, if there is a frozen comes to the positive, then to take the recommendation is that we don't proceed the surgery because these patients don't do so good. But there is coming literature after neoadjuvant treatment we can improve the survival if the patient respond after chemotherapy have good response or stable disease. Then after autocaval sampling and frozen comes to the negative, then we do the parenchymal resection as well as lymphadenectomy. So parenchymal resection we do the either segment 4A, 4B formal resection or liver wedge resection. So there is a multiple meta-analysis and as well as systematic view. If we achieve the arterial resection, whether it is 2 cm margin or formal segment 4A, 4B, both are equally good. There is no difference in the survival. And what should be the minimal lymph node dissection in the gallbladder cancer? So there are these are the areas. The first echelon, which is around the cystic duct and pericortical lymph node. This is the after the recent lymphadenectomy section. This is the CVD lymph node around them. And second echelon, which include the posterior superior pancreatic retroportal and right up to the right side of the celiac trunk and hepatic artery. So these areas should be lymphadenectomy should be done. And
For staging, minimum 6 lymph node is required for the proper staging. So just going what is one is that sometimes we find there is equality, and depending on what is the suspicion of malignancy, whether it is low or high, and if still there is a suspicion but is not high, then sometimes we can consider anticipatory extended cholecystectomy, which include, because if we do the simple cholecystectomy, there is a possibility of we breach the plane and there is possibility of bile state. If that is turned out to malignancy and bile spleen is there, then these patients have very poor prognosis. So in these cases we first do the gallbladder with the 2 centimeter ratio resection. So we should not breach the plane and avoid the gallbladder perforation and bile leak. And then send the specimen for frozen. If it is negative for malignancy, then we should not do the lymphadenectomy. But if it turned out the malignancy, then we should proceed further with lymphadenectomy. So these are two intraoperative pictures of the thick gallbladder. This is showing the thick gallbladder underwent anticipatory extended cholecystectomy, and this is the looks unhealthy mucosa, but this is because of infection of system, and then on frozen section that patient there is no malignancy, so we did not give the lymphadenectomy. This is again another patient showing the normal mucosa, and in this patient if we see there is an ulcerated lesion, so this turned out the malignancy, then we give the formal lymphadenectomy. Just about incidental gallbladder cancer, if the patient underwent cholecystectomy found there is a gallbladder cancer, if that it is that T1B and above disease, we should further do the completion extended cholecystectomy. So after surgery, we stage the disease, and then according to the stage of what should further management. So if the patient have stage 2 and above disease, all patients should receive adjuvant chemotherapy, and if there is a margin is positive, then consider for radiation therapy. So there are multiple studies which compare single agent versus double agent for the adjuvant treatment, and there is a most of the research found that double agent is the improve the survival. Now till date the gemcitabine with cisplatin or gemcitabine with oxaliplatin is the current. So there are some debatable issues in the gallbladder cancer, whether we should do routine CVD resection or not. So the patient don't have any infiltration or cystic margin is negative, then there is no role of routine CVD resection. But there are two situations like multifocal disease, sometimes the papillary tumor which also having focal in the CVD, or maybe patient need lymph node clearance. In that situation, CVD resection may be needed. Or if the patient needs routine bit of antibiotic. So this is a very morbid as well as very associated very high mortality. So if the patient having very penetrating lymph node and young patient, so and radio we know in these finding on radiology. So these patients first subject to the neoadjuvant treatment. If these patients respond to the neoadjuvant, then we can consider the major surgery like bit of antibiotic. Another debatable issue is whether we should do routine port-site resection or not in incidental gallbladder cancer. So again, there is no role of routine port-site resection in incidental gallbladder cancer. And last is the whether is the role of minimal invasive radical cholecystectomy. So if there is an expertise, previously it was considered absolute contraindication for gallbladder cancer, but now with the expert, if the expert is available, so it can be done by minimal invasive approach. So finally, this is the flow chart. So if the patient has suspicion of gallbladder cancer and there is no evidence of metastasis, these patients should be further staged by using CT, MRI. Then if the patient there is no metastasis, do the PET scan. Again there is no metastasis, then staging laparoscopy, and then if there is no finally the patient with surgical resection. And so how to follow these patients? So there is no clear guideline, but we routinely follow these patients as initially for 2 years, every 3 months with clinical history and clinical examination, ultrasound and tumor, margin CA and CA99.
And after 2 years, we follow this patient every 6 months, and every 1 year we do the cross-sectional imaging. So with this, I conclude GBC is the most common biliary traction worldwide. Especially, this is one of the cancer in our part of country, and most of the gallbladder cancer present with local advance or metastatic disease because these patients don't have specific symptoms in early stage of disease. So in high incidence area, especially North India and Northeast of India, if any suspicious finding, clinical or radiological, these patients need thorough evaluation. And the minimum staging evaluation of each patient with suspected or proven gallbladder cancer include cross-sectional imaging and diagnostic laparoscopy. And primary resection of a patient with early T stage, this should include envelope resection of adjacent liver parenchyma. And in case of incidental gallbladder cancer with T1B and above, should undergo resection. So, following RGO resection of stage 2 and higher disease and annual gallbladder cancer, these patients should receive adjuvant chemotherapy or chemoradiotherapy. And there is a literature is shown that these patients managed in the multimodality treatment setting, these patients have improved survival. And there is if the patient having T3 or T4 N1 disease, these should be considered for clinical trial of neoadjuvant chemotherapy. So nowadays we are moving in gallbladder cancer. If the patient has bulky lymph node, if it is involving more than one organ, then we are subjecting the patient on the neoadjuvant treatment. And if the patient has a good response, then we go for surgical treatment. Thank you.
I must say it was a very informative session comprising of starting from incidents, going to the conclusion, the management, the follow-up, covering almost everything in very short time. For our junior residents, this is the most common malignancy you will come across in your day-to-day life as a part of general surgery practice. I being from South India, teaching from South India, I rarely came across GBCs, but when I came back to North India, my every fifth patient is a GBC, and out of 10 cases only one is operable. But correct diagnosis and correct pre-op evaluation is must, which sir has nicely highlighted, especially in that flow chart. That's a take-home message I would say for all the residents in our CMU. Any questions?
Very nice and comprehensive presentation, sir. I want to just ask, if you encounter a patient with intraluminal JB mass, there is no infiltration into the JB side, then what is your plan? You plan for preoperative FLA, or you directly go ahead with radical cholecystectomy or do simple cholecystectomy? What is your plan?
So this is a very good question, because we see that many of the patients have, when we see the in OPD, many of the patients have FNAC with their first presentation. So if the imaging showing there is a resectable disease, never try to prove this by FNAC, always go upfront surgery, because even though there is no risk, these patients, if we do the FNAC, there is a risk of perforation and seeding, and these patients don't do good if we do the surgery in these patients. So never attempt to FNAC in resectable disease.
The yield of FNAC is also very less. It will come positive only 20-30% of cases. But sometimes we have observed intraoperatively in during diagnostic laparoscopy, there is simple clear-cut gallbladder, and we have done only simple cholecystectomy, and the biopsy was ICPN. So the literature is evolving. In ICPN, I think there is no role of additional lymphadenectomy as per the current literature. Maybe after some time the guidelines will come.
Yes, again it will depend on the, what is the T stage of disease. If there is T1, B and above, still whether it is intrapolycystic neoplasm, still there is we should do the lymphadenectomy. This is depend on the T stage of the disease.
Thank you.
Thank you, sir. Now I request Dr. Devendra sir to felicitate Dr. Kailash sir. I request Dr. Mohan Mehta sir to felicitate Dr. Devendra sir. I request Dr. Mohan Mehta sir to felicitate Dr. Ritik Bansal sir. Now, the fun part of CME will start, food. So from here we'll proceed to lunch, and post lunch in council hall there will be PG quiz and PG paper presentation, and in the same floor lecture theatre there will be e-poster presentation.
Lunch is only for 15 minutes.
All the teams kindly
मैं बता रही हूँ सर। सर इन द क्वेश्चन उसमें हेडिंग्स दी हुई हैं, हर हेडिंग्स पे कैंडिडेट को आपको 0, 1, 2, 3 में से मार्किंग करनी है एंड यू कैन मेंशन द नेम ऑफ द कैंडिडेट हेयर इन द ब्लैंक सेक्शन. The judges of the paper presentation will be Dr. M.K. Maheshwari sir, Dr. Hemant Nautiyal sir, Dr. Priyanka ma'am. In place of Dr. Maheshwari sir, there will be Dr. Rohit Bhatta sir. So I will call the first candidate, Dr. Manroop, for paper presentation. Who is present here in paper currently? Dr. Manroop, Dr. Parth, Dr. Yash, Dr. Arpit, Dr. Rahil.
जी सर. मैम
पे जाओ ना, ये लोग हो गया. For paper presentation, 5 minutes will be given with 1 minute question.
Good morning, sir. My name is Dr. Arpit Singh. I am from the SRMS Bareilly. My topic is a comparison between fistulotomy and fistulectomy for low fistula in NO. Introduction. Any anal fistula is a surgical condition characterized by the abnormal tract between the perianal region and anal canal. The annual incidence is 1 to 2 per 10,000 individual. Predominantly affected are male between the age group of 20 to 40 years. The condition typically originates from the cryptoglandular infection, where obstruction and infection of the anal gland located in the anal crypts lead to the abscess formation. If inadequately treated, these abscesses can develop into the persistent communication tract between the anal canal and perineal skin. Parkes classification. This is the most widely accepted classification for anal fistula. First is intersphincteric. The fistulous tract is between the two sphincters, external and internal. Transsphincteric. Fistulous tract crosses the external and internal sphincter both. Suprasphincteric. It tract goes above from the sphincter, and and next is extrasphincteric. In this tract connect to the high in the rectum. Traditional surgical management primarily involve the two approaches, fistulotomy and fistulectomy. Fistulotomy consists of gold standard, which involve the opening of the tract followed by curettage and allowing secondary healing, while the fistulectomy involve the complete excision of the tract. Despite numerous advances in the surgical approaches, the optimal treatment strategy for low anal fistula remains subject of considerable debate within the surgical community. Both fistulotomy and fistulectomy carry their own set of advantages of potential complication. Making of choice between the two of them is crucial. The decision-making process must carefully balance the goal of complete eradication of the fistulous tract while preserving the sphincters and minimizing the risk of recurrence. Methodology. This is a prospective observation study conducted in SRMS IMS from May 2023 to October 2024. A total of 66 patients were taken, in which we have divided into the two groups, fistulotomy and fistulectomy group. Each contained 33 patients. Pre-operative assessment include the detailed history, physical examination, and necessary investigations. Both procedures were performed under the spinal or general anesthesia in patient with the lithotomy position. In fistulotomy, the fistulous tract was probed open along the length and curettage done, leaving the wound open for the secondary healing. In fistulectomy, entire fistulous tract was removed. Post-operatively, all patients receive standard pain management, prophylactic antibiotic, stool softener, and wound care instruction. Follow-up study were conducted after 2 weeks, 1 month, and 3 months, assessing wound healing, incontinence, and recurrence. Data were analyzed using SPSS version 23 with student t-test for qualitative variable and chi-square test for qualitative variable. P-value of less than 0.05 were considered as statistically significant. Aim of the study: to compare the outcome between the fistulotomy and fistulectomy in low anal fistula. Objective: to study the epidemiological profile of fistula in ano, to study the post-surgical complication of low anal fistula in terms of incontinence and recurrence, to compare the outcome between the fistulectomy and fistulotomy. Results: after 2 weeks of post-surgical period, there were this is the comparison. This is the study comparison of post-operative period in between these two procedures. We have found that fistulectomy group were significantly better in early wound healing in compared to the fistulotomy group. Incontinence were initially higher in the fistula group, though this difference was not statistically significant. By the end of 1 month, healing rate were improved in the both cases.
quickly show us the results.
Sir, initially there were low transfemoral fistula is the most common in fistulectomy group, and fistulectomy में this is same. मतलब low transsphincter fistula is common between the fistulectomy and fistulectomy group, and in fistulectomy group.
Next table. Time is over already.
Sir, duration of surgery.
Next
is both. Initially, sir, wound healing and incontinence were present in. Wound healing was better in fistulectomy group. In later, there was a incontinence. There was one case of incontinence in fistulectomy group.
Next. Conclusion, please. What is your conclusion?
Sir, fistulectomy emerges as an advantage in several ways, including significant shorter hospital stay, faster overall wound healing, and reduced postoperative pain. It showed the trend over higher overall success rate, lower recurrence rate, though these differences were not statistically significant. Fistulectomy demonstrated better early wound healing at the 2-week and excellent continence preservation, with no patient experiencing persistent incontinence at the 3 months. However, it was associated with the longer hospital stay, increased postoperative pain, and non-significant trend toward the high recurrence rate. The choice between this procedure should be individualized based on the specific patient factor, including fistula anatomy, patient preferences, surgical expertise, and available healthcare resources. For many cases of low anal fistula, particularly there were the shorter hospital stay, reduced pain are the priorities.
Okay. How did you randomize these patients? Which technique did you use?
जी सर.
Randomize कैसे किया था इन patients को? क्या method use किया to randomize the patient between the two groups?
Sir, simple computerized based randomization करा था.
Computerized means? Can you explain? क्या किया था उसमें?
Sir, random.
उसमें use होते हैं ना, उसमें apps use होती हैं या नाम होते हैं उसके randomized methods के जो होते हैं. कैसे किया था? कंप्यूटर में क्या किया आपने? क्या डाल के क्या निकला कंप्यूटर में क्या किया? ऑनलाइन कुछ किया या क्या किया? आपने खुद किया था randomize कि?
जी सर.
क्या किया था? नहीं.
सर ये रैंडम था, कोई सर इसके लिए अलग से नहीं था. मतलब हाफ पेशेंट सर उनमें से हाफ पेशेंट फिस्टोटमी के लिए, हाफ पेशेंट फिस्टोटमी के लिए देखा था सर.
Was it a simple comparison you mean?
ऐसे you cannot divide half patient. Randomization में तो एक में ज़्यादा भी आ सकते थे. How you can prefix कि आधे इधर डालने आधे इधर डालने. चलो, what was your definition of low anal fistula?
Sir, any fistulous tract which open below the anorectal ring.
Anorectal ring, that one.
What perioperative investigation did you do in this patient?
Sir,
before confirming fistula tract.
Sir, initially clinical examinations करा sir, external opening दिखी, and then sir for fistulogram कराया sir, and for the next sir MRI fistulogram कराया sir.
Okay.
Next is Dr. Rahil. Five minutes presentation, 1 minute question.
Good afternoon, everybody. My topic for paper is technical modification for laparoscopic choledochal cyst excision. It was conducted in SRMS Bareilly. Introduction. Choledochal cyst is a rare congenital disorder with an estimated prevalence of 1 in 1,50,000 live births. Laparoscopic correction is either by laparoscopic excision followed by Roux-en-Y hepaticojejunostomy or hepaticoduodenostomy. Laparoscopic excision is quite challenging as there are inflammatory adhesions, difficulty to rotate the large cyst to obtain a good visibility, difficulty to dissect the lower end of the cyst into the pancreas, especially posteriorly. Then the classical approach. In classical approach, circumferential freeing of the cyst is done with complete posterior dissection from the portal vein until the upper neck of the cyst is reached. Then there were the certain modifications, like in paper in 2014, which proposed an open excision of choledochal cyst, in which the posteriorly the middle of the cyst is dissected free from the portal vein in the middle, then elevated on an umbilical tape. At this point, the anterior wall of the cyst was incised, and dissection continues superiorly and inferiorly. Then there was another modification. Which suggested that in case of a large cyst, a transverse incision was made on the anterior wall. The transverse incision over the anterior wall was enlarged towards the left to dissect the medial cyst wall from the right hepatic artery. In our technique, this was achieved by posteriorly extending the transverse incision on the middle cyst wall. The portal vein, which is located posteriorly, was separated from the entire length of the cyst. The posterior wall of the cyst was retracted with a grasper from the epigastric port to aid in its part of dissection. The modification which we did was little peritoneal dissection over most prominent part of the cyst. Then Callot's triangle was dissected and cystic duct dissected up to the cyst. Then cystic duct as a landmark, cyst was excised transversely. Transverse incision was gradually increased circumferentially along the dissection of the cyst up to posterior border. Once cyst completely divided into two portions, the lower portion was dissected off the portal vein under vision. This is a small video, 3D animation. This is we took a transverse incision over the anterior border of the cyst. We extend it circumferentially towards the posterior border, and we divide the cyst into two curves. Then the anterior, then the proximal and the distal curves were separated. This reduces the chances of injury to the portal vein, which is located posteriorly. This is intraoperative, in which we can see this is the cyst. Which we are dissected. The both curves are divided separately. The cyst is transversely incised towards the posterior border. And separated, the two cups are separately dissected. We did an ambidextrous study from July 2015 to July 2022. Laparoscopic choledochal cyst excision with modified technique were compared to the classical approach. The variables which we consider were time, blood loss, and successful excision. As we can see in the table, the p-value is found to be significant for time and the blood loss. The time required in modified technique is less, and blood loss was less in modified technique. Conclusion. Modification decreases the blood loss and duration of the surgery significantly, and it is better for operators in early learning curve.
How did you measure the blood loss?
So total number of pad showcase we
pad. Laparoscopy में can you put a pad inside the
total number of
बैक स्लाइड पे चले जाओ जो रिजल्ट्स वाली स्लाइड थी आपकी. यस हाँ बताओ. ब्लड लॉस हाउ डिड यू कैलकुलेट इट? नहीं किया हुआ. Did you assist in few of these cases or not? Then how the blood loss was measured?
So we gave the wash. Ma'am, along with suction, we gave the when we dissected completely, there was bile leakage, so we used to do continuous wash also in between.
So, okay, what was the duration of this study? How, these cases you did in?
So duration was from July 2015 to
22. Okay. Time, blood loss, successful exercise. Results पे चले जाओ.
Ma'am, we
all were
took only type 1 colorectal cyst.
Only type 1.
Only type 1 colorectal cyst.
Okay. How you diagnosed before the collecting your cases that type 1 cyst? क्या imaging कौन सी use करी?
Ma'am, MRCP and
MRCP. Okay.
And these techniques were done by different surgeons or the same surgeon?
Different surgeons.
Different surgeons. Okay.
When the colical cyst is densely adherent to bile duct, what do? There is a specific procedure name for such conditions. When the colical cyst is densely adherent to portal vein, क्या करते हैं उसमें? What is that procedure called? Specific नाम है उसका.
What is your recommendation at end of this paper?
When there are dense adhesions, when we dissect the cyst posteriorly in classical approach, there is we don't incise.
That is right. What do you recommend? But you see the p value is not significant.
What time and
Oh, it is not time mates. You said will consume less time. That may be due to experience of a surgeon because they are done by different surgeons.
Sir, and mainly there are higher chances of portal vein injuries during posterior dissection. In these cases, the chances of portal vein injury is less.
You mean to say in some cases there were portal vein injury?
If we go through classical...
No, in these cases.
In these cases, there were no portal vein injury.
No portal vein injury. No? How you can say that conventional leads to more portal vein injury?
More portal vein injury.
वैल्यू क्या ली 0.0 क्या सिग्निफिकेंस होता है ना उसका
0.0
सिग्निफिकेंट वाला लिया था
0.05 less than 0.05
वाला तो किसमें सिग्निफिकेंस लग रहा है आपको कौन सा वाला ज़्यादा सिग्निफिकेंट है दो ग्रुप्स आपने कंपेयर करे तो 0.05 लिया तो किसमें सिग्निफिकेंट ज़्यादा लग रहा है टाइम में सिग्निफिकेंट डिफरेंस आया तो कंक्लूड दैट मॉडिफाइड टेक्निक में टाइम बस कम लगा बाकी सब ठीक रहा.
हाँ ब्लड लॉस भी कम
तो दो चीज़ें कंक्लूड कर यू वांट टू कंक्लूड द टू थिंग्स ओनली कि टाइम एंड
ब्लड लॉस And portal vein injury.
और portal vein?
Portal vein injury, there was no portal vein injury. For that reason, we did this modification.
नहीं, अगर सर ने भी पूछा ना, portal vein पे densely adherent होती है sometimes the cyst,
हाँ.
है ना? तो you cannot separate it by giving even the 2 incisions that you have mentioned. So in that your things, the modified technique even changed. ठीक है? तो you have to exclude these cases from your study, है ना?
जी.
तो conclusion एक बार और दिखाना. Show me your conclusion also. And duration of surgery seen well better for the operation at early learning curve. और टेक्निक क्या ओपन यूज करी सर? लैप्रोस्कोपी में. ठीक है. और पोर्ट्स क्या उनसे डाले थे?
4 पोर्ट नॉर्मल पोर्ट.
4 पोर्ट्स नॉर्मल. किसी में कन्वर्जन की जरूरत नहीं पड़ी?
नहीं.
कन्वर्जन हुआ है?
ओनली 1.
अच्छा, एक में लिखा था. कन्वर्जन हुआ तो नहीं?
कन्वेंशनल केसेस में 2 हुए थे, वो मॉडिफाइड में.
आउट ऑफ 8 2 में कन्वर्जन था. वह 50% कैसे हुआ ये?
That wasn't because of the any intra-abdominal. That was because of.
No. How it is 50% of the N?
2/8 50% नहीं हुआ ना.
You have written 50%.
So for that 50% is for conventional method. In modification only.
Out of 8, only 2 were converted. So how much it is? 25% होगा ना ये.
सही नहीं निकाली आपने.
चलो ठीक. नेक्स्ट बोलो.
Next, we call upon Dr. Mandru for paper presentation.
Good evening, everyone. Today I am Manroop Singh here to present the topic: a comparative study of combination treatment of tamsulosin and dutasteride with monotherapy of tamsulosin in lower urinary tract symptoms due to benign prostatic hyper. A comparative study of combination treatment of tamsulosin and dutasteride with monotherapy of tamsulosin in lower urinary tract symptoms due to benign prostatic hyperplasia. Introduction. Benign prostatic hyperplasia is a common condition in aging men, often leading to lower urinary tract symptoms such as increased frequency, urgency, and weak urine flow. These symptoms negatively impact quality of life and, if untreated, can lead to complications like acute urinary retention, bladder stones, and renal failure. Medical management, including alpha blockers like tamsulosin and 5-alpha reductase inhibitors like dutasteride, is an effective approach for symptom relief. Aim and objectives. This study aims to compare the clinical effectiveness of combination therapy tamsulosin and dutasteride with tamsulosin monotherapy in alleviating LUTs due to benign prostatic hyperplasia. It also aims to assess the reduction in prostate volume, post-void residual volume, and improvement in peak urinary flow rate. Materials and methods. This study included 200 male patients aged 50 to 80 years presenting with obstructive lower urinary tract symptoms. Randomization was conducted using a lottery system, where patients were assigned to either monotherapy or combination therapy groups based on the lottery draw. Patients with obstructive LUTs symptoms within the age range of 50 to 80 years were included in this study. Exclusion criteria. Patients were excluded if they had any of the following conditions: a history of urinary retention requiring catheterization, suspected or confirmed prostatic carcinoma, define neurological lesions affecting the brain or spinal cord, associated urinary bladder pathology such as stones, malignancy or diverticulum. Medical therapy patients are assigned to one of the following treatment groups. Monotherapy group, tamsulosin 0.4 mg per day for 3 months. Combination therapy, dutasteride 0.5 mg per day and tamsulosin 0.4 mg per day for 3 months. Patients were evaluated before being included and after the completion of study. CBC, KFT, prostatic specific antigen were evaluated. Subjective evaluation was done using American Urological Association Symptom Scoring Index. Objective evaluation was done using ultrasound, whole abdomen to confirm the diagnosis, assess pre and post treatment prostate volume and post-wide residual volume to rule out any associated bladder or urinary tract pathology. Uroflowmetry was done pre and post treatment to measure peak urinary flow rate. Cystoscopy was done to support the diagnosis, assess prostate size and rule out any associated bladder pathology. Follow-up and compliance. All patients underwent pre-treatment evaluation and were followed up fortnightly for 3 months to monitor treatment compliance and assess their progress. Post-treatment evaluations were conducted to compare outcomes. So this table highlights the improvements according to American Urological Association scores. Mild, moderate, severe. This first combination therapy was given in mild patients, 48%. Which is the significant p-value was less than 0.05, and in monotherapy 39% patients with mild symptoms improved with p-value less than 0.05. Ma'am, value was 0.0001, that is p-value is value is less than 0.0001. Specific p-value.
हमने अपनी स्टडी में less than 0.00001 लिया है, include किया है.
हाँ मैम, मतलब ये वैल्यू आई है मैम, जो इंक्लूडेड वैल्यू 0.05 रहती है उससे इतनी कम आई है.
p वैल्यू को कंपेयर किया है.
सेम भी कंपेयर किया
This is the table comparing mean pre and post treatment AUS score of combination and monotherapy and p-value of post treatment score. Combination therapy, the pre-treatment percentage was 7.7 and monotherapy was also taken as 7.78. Post treatment the AU score was 10 and in monotherapy it was 12 with the error of specific plus 7. And in this also significant value was obtained. Table presents the significant reduction in prostate volume after both combination therapy and monotherapy. A noticeable shift to lower prostate volume categories was observed post-treatment in both groups with a p-value less than 0.001, indicating the efficacy of both treatment in reducing prostate size. On comparing combination therapy and monotherapy, combination therapy was more effective than monotherapy in reducing prostate volume. This table represents the reduction in post-wide residual volume after both combination therapy and monotherapy with a p-value less than 0.001, indicating the effectiveness of both therapies. This table shows the peak urinary flow rate following the both combination therapy and monotherapy, indicating the efficacy of both treatment approaches in enhancing urinary flow. The present study found that the combination therapy of tamsulosin and dutasteride significantly improved AUS scores in patients with benign prostatic hyperplasia. A shift from severe to mild symptoms was observed in 48% of combination therapy patients as compared to 39% in monotherapy group. Combination therapy with tamsulosin and dutasteride significantly reduced prostate volume compared to tamsulosin monotherapy. Post-treatment, 27% of patients in combination group had a prostate volume less than 25 cc compared to 24% in the monotherapy group. Combination therapy with tamsulosin and dutasteride significantly reduced post-void residual volume compared to tamsulosin monotherapy. In the combination group, 28% of patients achieved a post-void residual volume less than 50 ml post-treatment compared to 24% in the monotherapy group. The mean residual volume in the combination group decreased from 5.942 ml to 68 ml, while in the monotherapy group it decreased from 148 ml to 92 ml. Combination therapy with tamsulosin and dutasteride significantly improved peak urinary flow rate in comparison to tamsulosin monotherapy. In the combination therapy group, 26% of patients achieved a flow rate greater than 20 ml per second post-treatment, while 24% of patients in monotherapy group. The mean peak flow rate increased from 10 to 18 in combination therapy group and from 10 to about 16 in ml per second in the monotherapy group. Conclusion: based on both existing literature and the current research, medical interventions for BPH have proven effective in alleviating symptom and slowing disease progression, while reducing the risk of complications like acute urinary retention and need for surgery. Both combination and monotherapy have demonstrated their effectiveness as a medical treatment for BPH, but on comparing between the two, combination therapy is more effective. However, the present study's 3-month duration limits long-term conclusions. Uncertainty remains regarding the duration of pharmacotherapy necessary to achieve sustained improvement and whether symptom relief will persist once treatment is stopped or if patient will regress requiring alternate interventions. While pharmacotherapy may not offer a permanent solution to BPH, it plays a crucial and effective role for patients who either decline invasive procedure or are unsuitable candidates for surgery due to high risk.
Go to your results section. Yes. So this p value you have given before treatment and after treatment in one arm. Where is you have compared both these groups?
Sir.
Where is the data that you have compared both outcome in both these groups? Whether that was statistically significant or not. You see in the results both are having just difference of 2 or 3 units. Prostate volume, urine flow, metry rate. How you can say one is superior to other? There is no table here to show that between the two arms. Yes, this you have given for prostate volume combination. Yes. Okay. 0.03. ठीक हो 0.05 ही लिया होगा उसने. ठीक है. What were the adverse effect? Did you notice any? Because you have added one more drug to the one arm. Because it is a common sense, if you add 2 drugs, you may add 3 drugs that will further improve the situation medically, but they are not prescribed because they add to the adverse effects of the drug, tolerance of the drug. So did you note these points in your study that the patients who are on double drug therapy, they are having some difficulties or sort of that?
What are the adverse effects of tamsulosin and related contraindications? ये बता दो.
ड्यूटेस्राइड के बताओ ऐड करने पे.
Can you understand to everybody? Heart disease.
For it effects, adequate effects, ड्यूटेस्राइड. चलो कोई वो तो ठीक है.
Have you measured the PSA before starting the dutasteride?
Yes.
हाँ सर, before and pre and post.
Okay. So what was the post PSA after starting the dutasteride? कितना? तो देखा है इसके बारे में आपने?
ठीक है. ओके. नेक्स्ट कैंडिडेट प्लीज.
Now I call upon Dr. Parth for paper presentation.
बंद करना डॉक्टर पार्थ ये ठीक है
कर्सर कर रहा है पर वो स्क्रीन शेयरिंग नहीं चलता।
Good evening, sir. Myself, Dr. Parth Agarwal. My paper presented efficacy of single dose versus multiple dose prophylactic antibiotics in elective hernia repair, a retrospective study, sir. So, brief introduction, sir. Elective hernia repair surgeries typically performed to address conditions like inguinal, umbilical, and femoral hernia. Surgical site infections being the major concern in hernia repair procedures, as they are resulting in the prolonged hospitalizations, higher healthcare expenses, and in severe instances, potentially life-threatening complications. Prophylactic antibiotics administered before or during surgeries to prevent post-operative infections. However, optimal dosage regimens for antibiotics, specifically whether a single dose or multiple dose regime is more effective, has been a topic of ongoing debate. Single dose regimes involves administering, sir, basically in this study, I have taken two groups, group A and group B. First group being administered single dose, prophylactic dose, and group B being administered multiple dose, one prophylactic and two post-op doses. So, proponent being single dose regime argues that a single dose is sufficient to provide adequate protection, particularly in clean surgeries like hernia repairs where risk of infection is low. And for being using the multiple dose regimes, my defense being believe the extending antibiotic coverage into the post-op period offers additional protection, particularly where surgery is prolonged or complications arise that increase the risk of infection. So, materials and methods being is a retrospective comparative study in order to assess the outcome of single dose and multiple dose prophylactic antibiotics for patients who were undergoing elective hernia surgery. Total of 183 patients were operated for open inguinal hernioplasty in the chosen period of 1 year. Categorizing being two groups. Group A who received single dose IV pre-op prophylactic antibiotic, whereas Group B considered patients receiving IV pre and post-operative antibiotic prophylaxis.
Which antibiotic you used?
Ceftriaxone was used. I will tell in further slides. IV injectable cephalosporin was used. Third, G. Inclusion criteria being adult patients 18 to 70 years of age, patient who underwent elective inguinal hernia repair, patient with according to American Society of Anesthesiologists grade 1 and 2. Exclusion criteria being history of hypersensitivity to antibiotic, that we used ceftriaxone. For that we did firstly antibiotic sensitivity testing was done on each patient. Patient with immunosuppressive disorders or those on immunosuppressive therapy with active infection at the time of surgery, who had received antibiotics within 1 week prior to surgery, or emergency hernia repair cases or hernia other than inguinal. Methodology used was patient who underwent open inguinal hernioplasty in last 1 year were categorized into two groups. Total 183 patients were enrolled, of which 160 were fulfilled the inclusion criteria. Those patients who received single dose IV injectable ceftriaxone 1 gram IV start dose half hour prior to incision were grouped in Group A, and other received 1 dose half hour prior to incision and 2 doses in post-op period 12 hours apart, were including Group B. Patient data was assessed from the database, discharge summary, and subsequent OPD visits for surgical site infections in post-op period on 3rd, 7th, and on 30 days post-operative day. Other than this, they were also assessed for other outcomes like length of hospital stay and post-op complications. The rest other demographic details were also collected and used as per need in our surgery. All patients included were operated under spinal anesthesia. Sterile measures were being taken. First outcome of the study was rate of surgical site infections within 30 days of surgery. Secondary, we also assessed for duration of hospital stay, post-op complications, whether they were in the form of wounds that opened or formation of seromas, like wound dehiscence, and reactions elicited by the antibiotics used. For assessing post-op wound infections, wound diagrams has been made according to the CDC guidelines on 3rd, 7th, and 30th post-operative day. Moreover, any side effects of the antibiotics that the patients may have been had was also noted for both groups. So statistical analysis के लिए SPSS software version 25 was used, and on the same note, chi-square test was also used to compare the SSIs between the two groups, and descriptive measures were also taken. Significant level में इसके अंदर p value less than 0.05 consider किया गया है. Results being, I will show the tables. Firstly, demographic characteristics of the patients were considered for group A and group B. Age, gender, BMI, ASA grade, and type of surgeries being inguinal, femoral, and umbilical hernias were all assessed in both groups. P value, basically both groups were taken into consideration, and after the thorough consideration, and as per P value suggests, significant difference मैम नहीं आया था मैम दोनों ग्रुप्स के अंदर. So as per the ASA grading described, the physical status of the patients before surgery were also nearly equal in two groups with no significant difference between them. Secondly मैम surgical site infections का incidence भी हम देखा गया था on 3rd, 7th and 30th day. Like in group A and group B, P values also were not significantly found. As per इतने ज़्यादा changes नहीं थे मैम दोनों के अंदर. And in length of hospital stay was also considered. इसके अंदर हम mean age ली गई थी. Group A के अंदर 3.85 plus minus 1.24 days था, and for group B 2 to 5 days का P value है. So basically P value is also not significant in this parameter also, ma'am. And in post-op complications, wound dehiscence and seroma formation was considered, and in this also in both groups, in every parameter, minor like ma'am slight positive difference was found in multiple dose group B than group A, but P value was not significant. Then ma'am adverse effects were also taken into consideration, like nausea, diarrhea, rash, and in this also P values as we can also see are more than 0.05, so also not significant, sir. So in my discussion, antibiotic prophylaxis recommended for elective surgeries involving prosthesis implantation, as the risk of infection can occasionally be life-threatening. However, benefit in elective surgeries like inguinal hernia repair is often debated. The demographic characteristics of study population were well matched between group A and group B in terms of age, gender, BMI, and ASA grades, and this similarity in these variables ensures that the outcome of study are not biased by any demographic differences, allowing for a more accurate comparison between the two groups. Primary outcome of the study was incidence of surgical site infections at various time intervals. Results showed no statistical significance differences between single dose and multiple dose groups on day 3, 7, and 30. Although group A had slightly higher SSI rates compared to group B by day 30, the difference was not statistically significant. The length of hospital stay is often considered an indirect measure of post-operative complications and in recovery. In this study, average length of hospital stay in group B was 3.62 to 1 plus minus 1.12 days compared to group A, though the difference was not statistically significant. Marginally shorter hospital stay in the multi-dose group could be due to slightly fewer SSIs and no ma'am. Ma'am, हम ये ma'am conclusion being because in this study we see that हमने multi dose भी use करके देखा, but उसके बावजूद इतने significant changes नहीं आ रहे हैं, so we should prefer single dose in the pre-op period. ये इससे मैम basically cost effective भी है patient के लिए, and resistance भी build up नहीं होगा.
Which infections do you expect in a inguinal hernia surgery? Gram positive, gram negative.
जी sir.
Gram positive group of organisms or gram negative for surgical site infection in hernia surgery? What do you expect?
Sir, हमने सेफ्ट्राक्सोन इसीलिए चूज किया था because of its broad spectrum conclude.
No, but my question is which group of organisms?
Type of bacteria. एक gram positive होते हैं, gram negative होते हैं.
जी sir.
और third group है anaerobes.
जी sir.
इस किसका इन्फेक्शन सब पूछ रहे हैं कि इन्वायरल हड्डियाँ में किस बैक्टीरिया के इन्फेक्शन ज़्यादा मिले?
Gram positive.
So why you have given a gram negative cover? Ceftriaxone is a third generation. According to which guideline you have used this as a profile? Ceftriaxone is not recommended for superficial surgery like breast or these inguinal hernias. So it has to be first generation cephalosporin, cefazolin, cefuroxime, even amoxicillin is recommended, but not ceftriaxone is recommended. कहाँ से लिया आपने ये एंटीबायोटिक?
वो डिफरेंस आई इसीलिए नहीं रहा क्योंकि you use the broad spectrum. If you use an augmentin like amoxicillin, compared it with some another group of, then there way you can expect the significant difference.
आपके रिजल्ट में जाना
और ये बताओ ये रेट्रोस्पेक्टिव में you have taken 80-80 है ना?
जी सर.
It's a retrospective study. How it is possible that 80 cases received? These must be cases from the different units.
जी.
One surgeon practicing single shot, another surgeon practicing multi-treater, है ना? So how you can, from the past record, you can get equal distribution?
और बैक जाओ. इसमें दिखाओ इसमें यस. नेक्स्ट स्लाइड. femoral hernia 15%, 12.5% दोनों तरफ लिखे हुए हैं. Is it so common? What is the incidence of
femoral hernia
among groin hernia?
सब
मुझे लगता है 12 लाइफ में हमने
हाँ 12 One mistake you make, don't think when you have to compare two groups, they should be equal number. Equal number होना जरूरी नहीं है. आप जो थीसिस में बनाने की कोशिश करते हो कि रैंडमाइज कर रहे हो तो भी इक्वल नंबर रखना और रेट्रोस्पेक्टिव कर रहे हो तो भी इक्वल रखना है, प्रोस्पेक्टिव कर रहे हो तो भी इक्वल रखना है. इट इज़ नॉट पॉसिबल. दैट इज़ द रोल ऑफ स्टैटिस्टिक्स.
15%, 12%.
और ये फेमोरल हर्निया का जो सर बोल रहे हैं, इट इज़ नॉट पॉसिबल टू हैव 15% इंसिडेंस ऑफ इंग्वाइनल हर्निया आपका फेमोरल हो. देखते हो ओपीडी में हर 10 में से एक फेमोरल हर्निया. साल में एक भी नहीं दिखता फेमोरल हर्निया इतने केसेस के. कहाँ से लिया आपने ये डेटा फेमोरल हर्निया का?
और जब मटेरियल और मेथड डिस्कस करते हैं ना तभी बताते हैं कि हम क्या एंटीबायोटिक यूज कर रहे हैं. मेथडोलॉजी इज डिफरेंट. मेथडोलॉजी में तो आप तरीका बताते हो. मैंने ऐसे ही इस टाइम पे यूज किया. जब मटेरियल और मेथड का बता रहे थे ना जब उसने तभी नहीं बताया आपने एंटीबायोटिक. तो एट दैट टाइम यू हैव टू सेलेक्ट कि दिस एंटीबायोटिक दैट यू आर यूजिंग. ये सारी चीज़ें मैं यूज करूँ इस स्टडी में.
Thank you. Next candidate, please.
I request Dr. Sankal to come and present. Presentation. कौन सा है आपका?
Hello. Good afternoon, everyone. I'm Dr. Sankalp Agrawal, Junior Resident, Sri Ramurthy Smarak Institute of Medical Science, Bareilly. The topic of my paper presentation is going to be splenic trauma, a clinical presentation, evaluation, and management options, a cross-sectional study. A brief introduction. The spleen is the most frequently injured solid organ following blunt abdominal trauma, and it represents up to 50% of all the solid organ injuries. The majority of cases are observed in the second to third decade of life when movements in motor vehicles and outdoor work are frequent, which increases the risk of trauma. The advent of CT scan has made conservative management a more practical option for patients of splenic injury. And due to the emergence of non-operative management with rapidly evolving diagnostic modalities, preferred management options are shifting towards the conservative management. The surgery remains an effective and tested arrangement option if a patient is not a suitable candidate for conservative management. The aim of the study is to study the clinical presentation, evaluation, management options in a patient of blunt splenic trauma. Objectives were to study the demography, mode of injury, clinical presentation in a case of splenic trauma, to evaluate diagnostic modalities in patients of blunt abdominal splenic trauma, to study various management options and outcomes of splenic trauma according to AAST grades, and to study the incidence, complications and cause of mortality in a patient of splenic trauma who has been managed operatively or non-operatively. This was a cross-sectional study conducted in Department of General Surgery, Sri Ramurthy Smarak Institute of Medical Sciences, Bareilly, for the period of 1st May 2023 to 31st October 2024. The study included all the patients admitted in the patient in general surgical ward with blunt splenic trauma on the basis of predefined exclusion and inclusion criteria. The inclusion criteria was all the patients above 12 years of age presenting to the emergency and the ward with blunt trauma to the abdomen with splenic injury. All the patients with pre-existing hematological disorders, congenital anomalies, so penetrating injury to the spleen and infections or neoplasm of the spleen were excluded from the study. The sample size was taken of 82 after taking prevalence as 24.59 with calculation by a relevant formula. And so data collection was done through a structured pro forma and the data was collected directly from the patients. Results. So according to, in our study, the demography revealed that 87% of all cases lied in the age group of 17 to 44, of which most of the cases were of the age group 17 to 24 years of age. The mean age was 32 years and males were predominantly affected as compared to female. 81% approximately were males and 18.3% were females. Sir, in patients, in male patients, most of the patients suffered from splenic injury due to road traffic accidents, whereas in females, fall from height was seen as the most common cause of injury. Signs and symptoms in a patient of blunt splenic trauma. In our study, all patients presented with pain in abdomen and left upper abdomen tenderness, whereas vomiting and abdominal distension were second and third most common symptoms, whereas guarding rigidity and features of shock were presenting signs. Associated injuries in patients with blunt splenic trauma. In our study, sir, 46.3% of patients suffered from isolated splenic injuries. Among others, thoracic injuries were found to be most commonly associated with blunt splenic trauma. Ma'am, on presentation, first of all, with the primary resuscitation, a fast examination was conducted, and if the patient was hemodynamically stable after our primary resuscitation, patient was taken for CCT whole abdomen. And if the patient was not getting hemodynamically stable, even after adequate resuscitation, patient was taken for laparotomy, ma'am. So our diagnosis was based either on CCT or on the intraoperative findings, ma'am. The final diagnosis. In our study, grade 3 injuries were most prevalent, accounting for 29.3 cases, cases, and followed by grade 2 and grade 4. The final diagnosis, as I mentioned, was made on the basis of either CCT findings or intraoperative findings, depending upon whether the patient was hemodynamically stable or not. Grade 5 injuries were observed in 18.3 patients, whereas grade 1 injuries were found to be least common, comprising of 7.3% of cases. Distribution of associated injuries. Bowel injuries were exclusively observed in grade 5 and showed a strong association. Basically, 61.5% patients had thoracic injuries and were present in grade 4, which also revealed a statistically significant correlation. And head injuries were more common to be found in grade 2 injuries. Ma'am, rest of the Ma'am, those were operated. The patients who needed operative management for any other associated injuries were operated. So they were counted as surgical management only in the.
Grade 1 splenic injury, understand?
Yeah.
Saying कि non operative management और उसमें bowel injury grade 5 की है तो कौन से group में रखा आपने?
Ma'am, then the patient, if there was any other associated injury which required laparotomy or any operational procedure, then they were taken for as in the surgical arm of the study.
थोरेसिक इंजरीज आपने लिखी है।
Yes, ma'am.
ये बहुत हाई परसेंटेज है। हर चेस्ट के कितने ट्रॉमा में आपने स्प्लेनिक ट्रॉमा देखा?
Sir.
61% केसेस में आप कह रहे हैं कि चेस्ट इंजरीज अगर है तो उसमें स्प्लीन की इंजरी मिलेगी।
thoracic injury में क्या था?
Sir, thoracic injuries out of 82 patients, it was observed in 13 patients. So 15.9%, sir, not 61.
61.5% thoracic injuries occurred in grade 4.
So my mistake, sir. There was error. According to the table, out of 82 patients, 13 suffered with the thoracic injuries, which comprised of 15.9%, sir.
Out of those grade 4, 61 had thoracic injury.
Yes, sir.
It's okay.
Sir, mode of injuries were found to be statistically significant when association was between severity and the grades. The proportion of RTA-related injuries increased with severity from 33% in grade 1 to 76% and 73% in grade 4-5 respectively, indicating a strong correlation between RTAs and more severe injuries. So mode of management, in our study, sir, conservative management was carried out in 69.5% patients, whereas 30.5% patients were managed surgically. Post-operative complications, most patients did not suffer from any post-operative complication, whereas among others, surgical site infections were most common, followed by subphrenic abscess, hemorrhagic shock, and septic shock. Excuse me.
Regarding splenectomy, na?
Yes, ma'am. Yes, ma'am. Ma'am, ma'am, fluid resuscitation and. Yes, ma'am. Yes, ma'am.
तो कंजर्वेटिवली जो आप स्प्लीन का कर रहे हो मैनेजमेंट कंजर्वेटिवली तो उसमें पॉलीट्रॉमा एसोसिएटेड है तो फिर उसको कौन से ग्रुप में रखा?
Ma'am, if the patient was not taken to surgery for any cause, the patient was taken, kept in the conservative arm of the study.
You are studying the for splenectomy or not? Yes.
No, sir, no, sir. Grade 1 or 2 injuries were.
No, if suppose one patient was operated for head injury.
Yes, sir.
But he was having grade 3 spleen injury. He was
Understood,
not
sir.
operated for
Yes,
that,
sir,
so it was
so that was kept in conservative arms.
That is
Yes,
what
sir.
she is
Yes,
asking.
yes,
You know,
yes.
Madam is asking this thing.
Yes, understood, ma'am. Yes.
आपने एज को मीन लिखा हुआ है. Is mean a good measurement for age?
ग्रुपिंग नहीं है आपके ठीक से देखो ग्रेड्स तो बता दिए बट ग्रुप्स नहीं बनाए आपने ठीक से टेबल्स में कंफ्यूजन हो रहा है.
Yes, sir.
चलो कोई नहीं. ये एनिमल इंजरी दिखाई आपने.
Yes, sir.
10 पेशेंट को एनिमल इंजरी की मतलब उसको लेसरेट वुंड होना चाहिए ना.
Yes, sir. Sir, didn't understand, sir.
बोल से होगा सर. Mainly
Sir, there were many cases that animal attacked the horn attack and hooves. They kick the patient, so patient suffers from blunt abdomen trauma due to that, sir. Yes, sir. Commonly, sir, jungli sores, sir. जी.
आपने 80 सैंपल साइज में मीन एज लिखा हुआ है. Is it a good measurement of central tendency for low small sample size?
Sir, the mean was calculated in the 32 our age group was.
Is mean a good central tendency for central tendency measurement?
Sir, there was plus minus standard deviation of 11.8 years also, along with the I mentioned in my slide, sir, 32 years plus minus 11.8 standard deviation was there, sir.
वही मैंने देखा. Is it a good measurement? Sample size 80 है. Extremes बहुत हो सकते हैं. 15 साल से लेकर 70-60 कितने आपके हैं. In a small sample size, you have to use median values. Median values is not affected by extremes of.
ये multivariable study होती है, इसमें बहुत tables बनती है, and you have to group them and then compare all these.
Conclusion में जाइए थोड़ा. I think we should.
Sir, conclusions?
Data बहुत लंबा हो गया आपका ना.
Sir. The majority of the patients belong to the age less than 30 years and males grossly outnumber females. The most common cause of splenic trauma was RTA and it was associated significantly with higher grades of injury. All patients presented with pain and tenderness over the left upper abdomen. 46.3% patients had isolated splenic injuries, whereas thoracic injuries were most commonly associated with splenic injuries, which were 15.9% and showed a statistically significant association with higher injury severity. Most patients presented with grade 3 splenic injuries. 69.5% patients underwent non-operative management, whereas 30.5% patients underwent surgical management. Duration of hospital stay showed a statistically significant association with the grade of injury, and 96.3% of patients in our study improved, whereas there was a mortality of 3.7%. Clinical outcome of the patients was found to be significantly associated with the grade of splenic injuries. Thank you.
In how many patients you had to change the plan from conservative to surgical intervention?
Sir, conversion rate. Sir, conversion rate, I haven't mentioned in my slides, sir. It was 3 patients were converted to surgical due to failure of non-operative management, sir.
3 patients were
Yes, sir.
converted. What was the grade of those injuries?
Sir, grade 4 and grade 1, grade 4 and grade 5 there was. Not.
Grade 4 and 5. CCT abdomen was done in all cases or
No, sir. Sir, if the patient after primary resuscitation was hemodynamically stable, only then it was carried out, sir.
Do you think it's a right approach in a polytrauma case or a severe solid organ injury decision to manage conservatively without doing a CT scan?
No, sir.
Ideally,
There should
CT
be
should
yes,
be
sir.
done if you are managing
Yes,
the
sir.
patient
Yes, sir.
conservatively
Yes,
to
sir.
document the extent of the injury.
Yes, sir.
for the chance. What is your message through this?
Sir, message through this is that if a patient with blunt abdominal trauma, first of all, there should be high suspicion, high risk, high degree of suspicion, and aggressive primary treatment should be done. FAST should be utilized as a primary tool, and if the patient if the patient is a candidate for non-operative management, then non-operative management should be carried out. Not every patient should be taken for laparotomy and splenectomized, sir.
What are the parameters you use to take a decision for a conservative?
Sir, the patients who were for laparotomy, sir, the patients who were non-responders had a sustained systolic blood pressure of 90 millimeter of mercury. Sir, if there was clinical evidence of intra-abdominal hemorrhage and increasing abdominal distension, serial HBs were getting lower and lower. Sir, these were few of the indications, sir.
कितने % पेशेंट में ग्रेड 5 इंजरी था?
Sir, around 7. Sir, total there were 18.3% patients with grade 5 injuries, sir.
तो इन पेशेंट में किसी में भी pancreatic injury नहीं था?
Sir?
None of these patients had pancreatic injury, even in grade 5 splenic injury.
I included, sir, solid organ injuries in the in my associated part. So that also included pancreatic injuries also, sir.
कितने थे? वही तो पूछ रहा हूँ मैं.
Sir.
And what was done for those cases?
Sir, I haven't taken exactly as pancreatic injuries. All group during the laparotomy, every measure that was to be done was done. I haven't included individual organs as.
वो सबसे important काम वही होता है.
Yes.
What are the complications of splenectomy? Immediate complications.
Immediate complications, sir. There is thrombocytosis, sir, which may aggravate the risk of thromboembolisms.
Postoperative day 1 to 3 में क्या देखोगे, क्या advise करोगे?
किसमें sir?
POD 1 to 3
yes,
after splenectomy.
Sir, there could be immediate fever, risk of sudden onset of breathlessness due to thromboembolism, and similarly, sir, other thromboembolic events should be also be looked for. For example, myocardial infarction or deep vein thrombosis or yes, sir, basal lung atelectasis also, sir. Sir, spleen lies in very close proximity to the left dome of left hemidome of diaphragm, sir. So during surgery and dissection, the diaphragm is affected. Hence, immediately post-op, there may be atelectasis in the left lung, sir. Basal atelectasis. Ma'am, these are the incidences in the individual grade of splenic injury. For example, ma'am, grade 1 injury, there was one patient with solid organ injury, grade 2 injury 1. Similarly, there were, in grade 5 injuries, there were 3 patients with solid organ injuries. No, ma'am. Solid organ, apart from spleen, there's liver, pancreas, and such. Yes, ma'am. Yes, ma'am. Yes, ma'am. Thank you, sir.
Now I call upon Dr. Sarfaraj Ahmed. कहाँ भेजा था आपने? अगर आपने ऐसे इसी को भेजा होगा तो होगा। कौन सा वाला? आपका नाम क्या है? नाम से ना एक सेकंड चार्जिंग you don't have any pen drive? Next बुला लो आप डॉक्टर यश
Good evening, everyone. Topic of my paper is a prospective study to assess the incidence of surgical site infection in patients with gallbladder content spillage during laparoscopic cholecystectomy. I'll start with the introduction. First introduced in the 8th decade of the 20th century, laparoscopic surgery, also known as minimally invasive surgery, quickly emerged as the preferred surgical method for several procedures. The gold standard for treating symptomatic gallstone is currently laparoscopic cholecystectomy, and the most prevalent biliary disease, cholelithiasis, affects around 10% of the people worldwide. The possible rise in surgical site infections as a result of gallbladder leakage after laparoscopic cholecystectomy is the issue this study attempts to address. It is essential to comprehend the prevalence and risk factors of various SSIs in order to enhance surgical procedures, patient safety, and overall results. By offering information on the incidence and etiology of the SSIs in this particular setting, this study seeks to close the knowledge gap. So aim and objectives. So aim of my study is to assess the incidence of surgical site infection in patients with gallbladder content spillage during laparoscopic cholecystectomy, and the objectives are to assess the occurrence of SSI in patients with spillage of gallbladder bile or pus, and to assess the occurrence of surgical site infection in patients with spillage of gallstone with or without bile or pus. Material and methods. So this study was conducted in the Department of General Surgery at SRMS Institute of Medical Sciences, Bareilly, as a part of a prospective observational design over a period of from the 1st of May 2023 to 31st of October 2024. And the study design was a prospective observational study, and the study populations were patients with gallbladder content spillage, and the inclusion criteria were patients with acute cholecystitis of less than 3 days with cholelithiasis, and patients that were excluded were patients with sepsis or multi-organ dysfunction syndrome, acute cholecystitis of greater than 3 days with cholelithiasis, evidence of uncontrolled diabetes mellitus, conversion to open cholecystectomy, patients with immunosuppressed conditions like HIV, SCID, or taking immunosuppressive drugs, etc., and histopathologically proven malignant in the post-operative period. The sample size, 110 patients were taken during this period. The sample size estimation was obtained using a prevalence P equals to 50% based on the data from the study done by Kumar P et al. And the following formula was used to calculate the gap. And this resulted in a sample size of 100 with an additional 10% included to account for potential dropouts, making the total sample size of 110 patients. The data collection procedure, each patient's clinical profile, history, examination results, and investigation finding were recorded using a systematic proforma, and data was collected and classified regarding intraoperative gallbladder content spilling and its correlation with the postoperative surgical site infections. Plan for data analysis, the statistical package for social sciences SPSS version 26.0 for Windows was used to analyze all patient data. And the arithmetic mean and the standard deviation was used to display quantitative data, and frequencies were used to display qualitative data. The two groups category variables were compared using chi-square test, and intra-group variation over time was evaluated using ANOVA. And p-values of less than 0.05 were regarded as statistically significant. So the observation and results. The table and figure show the age distribution of 100 individuals, with the largest group of being 31 to 40 years, which were 35%, followed by 41 to 50 years, which were 30%, and the smallest group being less than or equal to 20 years, which were 1%. And the mean age group of the patient was 46.65 years, with a standard deviation of 12.41 years. This particular table and the figure shows out of 100 individuals, 35% of the patients were males and 65% were female. And this shows a higher representation of females in the sample, with nearly twice as many females as compared to males. The table shows that the average weight was 60.02 kg with a standard deviation of 9.95 kg, ranging from 40 to 84 kgs. The average height was 160.28 centimeters with a standard deviation of 14.79 centimeter, ranging from 69 to 178 centimeters. The average BMI was 22.59 with a standard deviation of 2.8, ranging from 16.02 to 30.8. This particular table and figure shows the majority belong to middle class, that was 48%, followed by the lower class, those were 43%, and a smaller portion were from the upper class, that counted for 9% of the patients. This particular table and figure shows the most common symptom was abdominal pain experienced by 87% of the sample, followed by fever, that was 47%, and vomiting, that was 13%. Other symptoms included abdominal distension, loss of appetite, and gallbladder lump. This particular table and figure shows that 32% of the sample were smokers and 9% consumed alcohol. Regarding diet, 84% followed a vegetarian diet, while 16% had a mixed diet. In terms of water sources, 65% used tap water and 35% used RO water. This particular table and figure shows the distribution of the studied cases based on the intraoperative findings, and it was found that majority of the cases, intraoperative finding was that gallbladder was edematous in majority of the cases, that was 65%, followed by the presence of pericholecystic fluid and gallbladder perforations in 10% of the patients. This particular table and figure shows that bile only spillage was most common, occurring in 72% of the cases, and the mixed content was seen in 28% of the cases. This particular table shows that the surgical site infections and complications occurred in a total of 25 cases, that counted for 25%. Out of 25 patients, 22 patients had superficial SSIs and 3 patients had deep SSIs. And this particular table shows that the surgical site infection was most common in 18, that is 72% of the patients, and 16% of the patients had port site sinus among superficial SSIs, and in deep SSI patients, intra-abdominal abscess was seen in 3% of the patients. This particular table shows that among those with bile spillage, 13.8% developed SSIs, while 86.2% did not. In mixed, 15 patients had SSIs and 13 patients did not. The difference between bile spillage and mixed among SSIs and no SSI patients was statistically higher, that is, and was significant. That was p-value was less than 0.01. Moving on to the conclusion, a rather typical issue after laparoscopic cholecystectomy is gallbladder perforation, which can lead to lost gallstones and the spilling of bile and stones. This study comes to the conclusion that a greater incidence of surgical site infections is linked to gallbladder content spillage during laparoscopic cholecystectomy. Even though they are rare, these stones can easily can cause serious problems either early or late, which can make diagnosis difficult and result in serious patient morbidity. The result highlighting how crucial careful surgical methods and timely spill cleanup are to be reduced in the risk of SSIs. Clear documentation and a high index of suspicion for complications should be maintained in the event of spillage in order to identify and treat surgical problems as soon as possible. The study highlights the need for heightened vigilance and possible prophylactic measures in patients experiencing spillage to improve post-operative outcomes and reduce infection rates. These insights can guide surgeons in refining their practices and protocols to enhance patient safety and care quality. Thank you.
What was the diagnosis for these patients? All patients are of acute cholecystitis, chronic cholecystitis, recurrent biliary colic. क्या था?
All the patients were diagnosed cases of ultrasound diagnosed cases of.
Clinical diagnosis क्या था? There is a difference in infection rate between biliary colic patient versus acute cholecystitis versus chronic cholecystitis versus complicated case. So if you are taking all cases as same,
go to the inclusion criteria.
So.
No inclusion. Patient with you have not taken polylithiasis cases. Only acute cholecystitis you have taken with.
Yes, sir.
Less than 3 days.
And
Yes, sir.
कितने में स्पिल हुआ? 100% में, सब में?
सब में नहीं हुआ सर. हमने जो
आपके डेटा में तो सबके दिखा रखा लग रहा है. दिखाइए मेरे को स्पिलेज.
हमने जो सब पेशेंट्स लिए हैं, those were 100 patients जो on table, जिनमें सर.
Did all patient has bile spillage during surgery?
Yes, sir. The study starts when there is bile spillage of gallbladder content spillage, sir. Either it can be bile or it can be stones or both, sir.
To see the infection
Okay.
Why you have taken acute cholecystitis? This infection could be due to simply acute cholecystitis also, not due to spillage of the bile.
That is one of the limitations of the study.
Why didn't you take? What was in your mind to see the? Why didn't you simply took polylithiasis cases, and then in which cases there is a bile spillage, you could have compared that whether there is increased incidence of SSI or not. Why specifically you went for cholecystitis of less than 3 days duration? What is the purpose of that?
What is the method of removal of the gallbladder from the ports? If you remove the ports, gallbladder from the ports, then it also causes the infection. So that you also have to bias this infection rate. Either you have to place the gallbladder in the bag.
Yeah.
Then you
Domia bags were used, ma'am.
डॉर्मिया
Yes, जो जिसमें गॉल स्टोन का रिट्रीवल इन ऑल द पेशेंट्स जिसमें स्टोन्स का स्पिल हुआ है मैम, डॉर्मिया बैग्स वर यूज्ड एंड फिर ही हमने आगे का स्टडी परफॉर्म किया है मैम.
Culture was done in all patients?
Culture was done in all the patients.
What was the common organisms?
So culture that was done in the patients जो कि हमने जो study की है on the 7th day if the patient presented to us with symptoms of inflammation, signs of inflammation, उसमें हमने culture लिया था सर.
नहीं, in every case before documenting it as a case of SSI, or there was definition you counted them as SSI even
According
based on the clinical symptoms.
According to
What culture was done?
What was the organism you found?
So CDC criteria के according हमने उनको पहले तो classify किया था and if there was a need to open the sutures or if there was any active discharge that was present.
What was your definition of SSI?
So CDC criteria के according ही
what was
like
that?
superficial SSI and deep SSI we differentiate.
What was that? Discharge coming through that, serous discharge, purulent discharge, inflammation, all cases must have a documented culture sensitivity report. What criteria did you use?
So, signs of inflammation that came under superficial, sir. If there was any active discharge, so that we counted them as deep surgical site infections, and if there was a need to open the suture sites, उनका हम लोगों ने culture भेजा था.
What was the organism culture?
Most commonly found was Staphylococcus aureus.
Staphylo, you think Staphylo should be the most common organism?
E. coli.
Bile
E. coli.
How come you have Staph aureus? It means the reason of that infection was not proper using a aseptic technique rather than the bile spillage into the abdominal cavity. नहीं? Staph तो फिर ऊपर के उससे आ रहा ना ऊपर की.
Yes.
Pain drape अच्छे से नहीं था, hand scrub अच्छे से नहीं था, instrument autoclave नहीं थे. Rather than the bile, if bile is causing the infection, it means it has to be gram negative.
Staph कितनी बार आता है? How many percent? लिखा होगा ना आपने study में किया है.
Thank you. नहीं, बाइल का कल्चर नहीं भेजा गया था सर. थैंक यू सर.
बस एक बार डाउनलोड करेंगे बेटा मेरे को नेट डिस्कनेक्ट.
Good evening all. My topic for paper presentation is extensive study on incidence and risk factors of deep vein thrombosis in asymptomatic patients after prolonged surgery. So introduction of the disease. Deep vein thrombosis is a serious post-operative complication that can lead to life-threatening conditions like pulmonary embolism and is major components of venous thromboembolism, the third leading cause of cardiovascular death. DVT develops due to venous stasis, endothelial injury, and hypercoagulability, collectively known as virtuous triad, and typically forms in the lower limbs or near venous valves. Major surgeries, especially orthopedic and abdominal procedures, significantly increase the DVT risk, with incidence rates ranging from 15 to 40% and often remaining undiagnosed due to asymptomatic presentation. Although previously thought to be less common in Asia, Indian population emerging data show comparable incidence rates, indicating a need for greater regional awareness and study. This research now come to the main point, aims and objectives. So aim of the study to study the incidence of deep vein thrombosis in asymptomatic patients after prolonged surgery in our institute. The objectives of the studies are to identify the risk factors of deep vein thrombosis in asymptomatic patients and to assess the efficacy of the effect of surgery, duration, blood transfusion, nature of surgery, and type of surgery on incidence of deep vein thrombosis. So materials and methods are it is a prospective observational study conducted in the Department of Surgery at RMRI Institute for a period of 12 months of period. Additional data was gathered through patient history, surgical details, hematological investigation, lipid profile, and intraoperative blood loss assessment. Statistical analysis was performed using Excel with categorical variables presented as frequency and percentage. And also handheld Doppler on post-op day 2 and 5 and 7 was also done, which is also included in materials. Inclusion criteria. So the patients includes all patients aged from 18 and above who underwent elective or emergency surgeries lasting more than 2 hours with a final sample size of 100 patients. So exclusion criteria includes patients with pre-existing DVT, those on anticoagulant therapy, and those who underwent cardiac or vascular surgeries. So the result, the study analyzed 100 patients to determine the incidence and risk factors of DVT. It examined demographic, surgical related factors, including Doppler and duplex fan findings. Results highlighted DVT occurrence patterns, associated risk factors, and treatment. Data is interpreted in the tables and graphical forms. So it includes the number of patients who underwent more than 2 hours of surgery according to age, how many number of patients were assessed. This indicates the number of elective and emergency surgeries which are performed, and time duration of the number of patients, more than 120 and 180, and mostly the patients are involved in the time duration of more than 240 to 300 minutes. Number of days of immobilization, sir, it's also included, sir. It shows that most of the patients are mobilized on 4 to 6 days of the studies, and few patients are mobilized more than 15 days, after more than 9 days. The handheld Doppler is also done, which indicates on post-op day 2, 5, and 7, which shows six patients are having DVT out of 100 of the patients. So discussion: deep vein thrombosis is a major post-operative risk, particularly in middle-aged and older adults, with studies showing highest incidence in patient age between 40 to 59 years of age. While 77% surgeries were elective, both elective and emergency procedures carried DVT risk, highlighting the need for individualized risk assessment. Most patients were hospitalized for 6 to 9 days with extended stays linked to complications like DVT, while Doppler ultrasound showed progressive vascular recovery by post-op day 5. The overall DVT incidence was 6%, aligning the previous studies and reinforcing the importance of early detection and tailored thromboprophylaxis. Risk factors such as advanced age, blood transfusion, and prolonged ventilation further support the need for target prevention strategies to reduce the morbidity and improve outcomes. The conclusion: the study was found that 6% patients developed asymptomatic deep vein thrombosis detected through duplex scanning. Most affected individuals were middle-aged with a high number of male patients, suggesting possible gender, age, and age-related risk factors. Delayed post-operative mobilization, especially beyond 9 days, appeared to be contributed to DVT development. Doppler scan shows gradual increase in abnormal findings, with 6% cases identified by the 7th post-operative day. The results emphasize the importance of early screening, timely mobilization, and preventive measures for DVT, especially in high-risk surgical patients. Thank you.
Any data on type of surgery?
Yes, sir. Sorry, sir.
What different kind of surgical patient you have included?
Sir, mostly, sir, patient who are the laparotomy, intestinal obstruction.
Is the risk of DVT in pelvic surgery versus risk of DVT in breast surgery versus orthopedic surgery फर्क है ना?
Yes sir, yes sir.
So you have not categorized those groups.
Sir, but my नहीं sir, my data is based on all those patients who have done surgeries for more than 2 hours, and previously they don't have any risk of they don't have any DVT. I am just assessing whether they have had a risk of developing a DVT or not, regardless of the surgery.
Type पे भी होता है, and you have taken the risk factors in those patients. You have not shown any chart showing that what type of surgery you have done. The patients were having these risk factors who developed this.
Sir, actually I have taken almost 13 parameters in my study, but यहाँ पे थोड़े मैंने 5-6 कम कर दिए थे, मतलब जिसमें हमारा डायबिटीज, COPD.
काम के चीज तो कुछ नहीं हुई है भाई, काम के डेटा आपने लिखा ही नहीं है.
What are the risk factors for DVT? अच्छा ये बताओ.
Sir, risk factor DVT sir, prolonged surgery, immobilization, and sir pregnancy, sir.
What is provoked DVT? What is unprovoked DVT? Provoked versus unprovoked DVT. ट्रीटमेंट क्या करते हो, किसी का हो गया बता दो.
Sir, first of all, sir, low molecular weight heparin देते हैं sir, 25,000 units for 7 days. After that, warfarin is started.
WS 25,000 units.
So, heparin देते हैं sir, 25,000 units for 7 days. Per day 25,000 units देते हैं sir.
25,000 per day. कैसे देते हो? How?
Sir 5,000 की एक वाइल होती है सर, पर 5,000 की एक वाइल होती है सर, उसको हमने सर 100 ml एनएस में सर डिवाइड कर 5,000 मतलब 2 सर
एक वाइल में कितना यूनिट्स होते हैं?
सर 5,000 पर ml वाली वाइल होती है, 5,000 पर ml वाली वाइल होती है सर.
एक वाइल में कितने ml वाली?
सर 5 ml की वाइल होती है, 5 ml की होती है सर.
तो
उसको सर हम सर 100 ml एनएस में सर 500 ml एनएस में सर
you are giving in infusion.
Yes sir.
How do you monitor?
Sir, via prothrombin APTD and PT time देखते हैं सर.
PT देखते हो हेपरिन के लिए. What else? और क्या ट्रीटमेंट देते हो? इतना दे दिया, हो गया खत्म?
नहीं सर.
आपने दिया होगा ना?
Yes, sir.
क्या दिया फिर?
और सर उसका सर मैकेनिकल मेथड लगाते हैं सर, इसमें सर अर्ली मोबिलाइजेशन कराना हो गया पेशेंट को.
DVT होने के बाद? मैं तो ट्रीटमेंट पूछ रहा हूँ ना, प्रोफिलैक्सिस नहीं पूछ रहा हूँ, प्रिवेंशन नहीं पूछ रहा हूँ.
सर DVT होने के बाद सर एक तो हमारा ये हेपेरिन देते हैं और स्ट्रेप्टोकाइनेज देते हैं सर, स्ट्रेप्टोकाइनेज या यूरोकाइनेज.
कैसे?
सर वो सर जो क्लॉट बन जाता है उसको डिसलॉज करने के लिए सर 2 लाख to 6 lakhs यूनिट देते हैं सर ओवर फॉर ऑरली. 2 lakh to 6 lakh यूनिट ऑरली देते हैं फॉर 1 day, एंड देन आफ्टर दैट 1 lakh यूनिट देते हैं एवरी 24 hourly.
जिसको हेपेरिन दिया था उसको डिस्चार्ज करते हो तो क्या देते हो, कब तक देते हो हेपेरिन?
सर हेपेरिन फॉर फर्स्ट 7 days देते हैं, उसके बाद हम वारफेरिन स्टार्ट कर देते हैं. वारफेरिन सर 3 to 6 months तक चलती है हमारी सर.
कितना, कैसे
सर?
डोज मॉनिटरिंग. डे 7 तक हेपेरिन दिया, डे 8 से वारफेरिन दे दिया, ऐसा?
नहीं सर, वारफेरिन सर फ्रॉम डे 1 से स्टार्ट कर देते हैं हम.
अच्छा.
क्योंकि सर वारफेरिन का टाइम ऑफ एक्शन इट्स टेक टाइम टू एक्ट, तो हेपेरिन हम के साथ साथ हम वारफेरिन दे देते हैं. वारफेरिन हम सर 7 days से स्टार्ट करते हैं पेशेंट में.
कैसे मॉनिटरिंग करते हो वारफेरिन?
सर
व्हाट इज द यूजुअल डोज यू गिव?
सर 10 to 20 milligram.
बस हो गया.
Now I request Dr. Zishan to come and present.
टीम्स खुलवा लीजिए आप अपनी।
मेरा बच्चा है मेरा।
सर इसका बच्चा है। सर एक कैंडिडेट का बच्चा है।
Good evening, judges. I'm presenting a paper on a comparative study of modified Alvarado score and Zensky score for the diagnosis of acute appendicitis. Introduction: acute appendicitis is the most common and the frequent. Zensky score. Sir, Rama Medical College, Hapur. Introduction: acute appendicitis is the most common and the frequent abdominal surgery emergency encountered worldwide. It is associated with high morbidity and occasionally mortality related to failure of making an early diagnosis. In the classic presentation, the patient describes the pain as beginning in the periumbilical or epigastric region and then migrating to right iliac fossa. This is associated with fever, anorexia, nausea and vomiting, and the classical symptomatology only occur in 50 to 60% of cases, making the diagnosis difficult. Various scoring system has been described for diagnosis of acute appendicitis. Of these, modified Alvarado score has been the most commonly used. It consists of symptoms, sign and inflammatory marker. Out of 10 score, a score of 7 or more is considered as acute appendicitis requiring surgical treatment. Zensky score is another score which is combination of clinical evaluation and inflammatory markers and ultrasound. Out of 50 score, a score of 8 or more is considered as acute appendicitis requiring surgical treatment. Aim of the study is to compare the efficacy of modified Alvarado score and Zensky scores in diagnosing of acute appendicitis. Material and method. Study design is prospective, non-randomized study. Study population is, this study includes 50 patients between the age of 12 to 75 years with a clinical diagnosis of acute appendicitis who underwent laparoscopic or open appendicectomy. Study place is Rama Medical College and Hospital and Research Center, Hapur. Study period is from March 2022 to August 2023. Method include all cases had undergone through history and detailed clinical examination at the time of admission. Routine investigation like complete blood profile. Patient underwent ultrasonography of whole abdomen and well-established USG criteria were applied to differentiate an acutely inflamed appendix from normal one. Selection criteria, inclusion criteria include patient with between the age of 12 to 75 years of both genders, patient with suspected acute appendicitis based on the history and clinical examination. And exclusion criteria include patient with age of less than 12 and more than 75 years of age, and those with appendicular abscess or appendicular mass. Sonography criteria for appendicitis is non-compressible appendix of size more than 6 mm and anterior posterior diameter, and a hypoechoic thickened appendix wall more than 2 mm and target sign. Presence of appendicolith, interruption of submucosal continuity, and periappendicular fluid. Zensky score includes sign of appendicitis in USG, which scores 6. Right iliac fossa pain leads to 4 score, and positive lumbar sign, which is 3 score. WBC count more than 12,000 is 2 score, and modified Alvarado score include clinical feature migration of pain, which give 1 score, anorexia 1, nausea and vomiting gives 1 score, tenderness in the right iliac fossa, which gives 2 score, rebound tenderness, which is score 1, elevated temperature is 1, and leukocytosis, which gives 2 score, and shift of neutrophil to left is 1. Total is 10. Both modified Alvarado score and Zensky score were done for all patients at the time of admission and prior to surgery. Final diagnosis was confirmed by histopathological examination of the specimen by the pathologist. Data were analyzed to compare the efficacy of both scoring systems in diagnosis of acute appendicitis. Result: during the year March 2022 to August 2023, 50 cases were diagnosed as acute appendicitis, of which 36 patients underwent open appendicectomy and 14 patients underwent laparoscopic appendicectomy. In present study, most common position of appendix is retrocecal. Histopathological analysis of the appendix: there were 42 cases in which inflamed appendix was present and 8 cases have normal appendix. Modified Alvarado score versus histopathological diagnosis. In modified Alvarado score is more than 7, then it have acute appendicitis in 39 patients and normal appendix was found in 1 patient. If modified Alvarado score is less than 7, acute appendicitis was found in 3 cases and in which normal appendix is found in 7 cases. Based on Zenke's score, between out of 50 cases who underwent appendicectomy, 40 patients were found to be true positive, which was confirmed by histological examination. Similarly, 1 patient has scored equal to more than 8 were false positive. In addition, among 9 patients with less than 8 score, the number of true negative found to be in 7 cases. The sensitivity and specificity of Zenke's score was 95.20% and 87.5%. respectively, with positive predictive value of 97.5% and negative predictive value of 77.77%. Overall negative appendicectomy was 16%. Comparison between modified Alvarado and Zenke's score system. Sensitivity: modified Alvarado score sensitivity is 92.85, whereas Zenke's score is 95.2. Specificity is 37.5 in Alvarado and 87.5 in Zenke's score, which is similar. Most predictive value in modified Alvarado score is 97.5 and Zenke's score is also similar. And the negative predictive value in modified Alvarado score is 70 and Zenke's score is 78. Conclusion: this study shows Zenke's score system can be used as an effective modality in the establishment of accuracy in the diagnosis of acute appendicitis. There is an increased sensitivity and diagnostic accuracy in Zenke's score when compared to modified Alvarado score.
स्कोर दिखाओ बच्चों, स्लाइड दिखाओ जिसमें आपने दोनों स्कोर दिखा रखे हैं।
Which score system is better?
इसके Zenke आ गया इसके। Yes, this one. इसमें एक चीज देखो, more parameters were used in Alvarado score.
Yes,
right? More parameters. Then how it can be less specific than the score which is using less parameter? And why you label it as a modified Alvarado score? What is missing from the original Alvarado score? Alvarado score तो है ही 10 marks का, पूरा आपने modified नाम रखा है, उसमें क्या modification है इसमें? नहीं
एक स्कोर सिस्टम और रिपासा स्कोरिंग सिस्टम। तो इस तीन में क्या फर्क है?
नाम ही गड़बड़ कर रखा है। मॉडिफाइड क्यों रखा आपने इसका नाम?
कुछ मॉडिफाइड है या ओरिजिनल यही दिया था?
How it is different from original Alvarado score? Modified में क्या बताऊं? This was my thesis actually, when it was still not in the books. Bailey Lab में आने से पहले I did the thesis on this, and modification which we did because shift to left was not available in the emergency situation. So I labeled it as modified Alvarado score in my thesis. आपने तो original Alvarado score लिखा हुआ है, उसके नाम रख दिया modified उसका.
Yes, sir. Yes, sir.
What are the complications of appendectomy? ये बता दो.
So splinters of suture, some bleeding, recurrence of appendicitis if stump is long. Sir, when we palpate the abdomen, patient doesn't wince, but when we lift up the hand, the patient winces. This is called a Blumberg sign. Yes.
Anyone else left for paper presentation? Name?
इसमें है ही नहीं।
तुमको भेजा था।
कोई बात नहीं सर, अब तो हमने सेंटर पे नई स्कीम लगा दी। हाँ? आपकी बात करो, लगा दिया। तीनों मार्क्स दे दिया आपने।
क्यों मन कर रहे हैं? यार किसका खुला हुआ है? ना ना सुनीति मैम को भेज देता हूँ मैं। क्या करूँ? आया इसमें? इसमें आया नहीं। सुनीति मैम का ही है।
the hepatobiliary hustle. The quiz will consist of 3 rounds: the anatomy pass, then the surgeon's cut, and lastly the rapid fire. The quiz will be conducted by our quiz master, Dr. Harinder Sandhu sir, Dr. Nikhil Bhati sir, Dr. Anu Kohli ma'am.
Now starting with the first round, the anatomy pass. The question will be presented for each team on the screen and 15 seconds will be given to answer. Each question holds 100 points. In case the team is unable to answer, it will be passed to the next team in order and 50 points will be offered to the answering team. In case none of the teams could answer, the question will be open for the audience.
Sir, one of the person will want to play akela without a partner.
तो लास्ट वाली टीम को तो एडवांटेज होगा वो आंसर दिए रॉन्ग एक ही बार पास
समझ में आ गया? कोई डाउट तो नहीं है? एक ही बार पास होगा वो क्वेश्चन ना. अगर ये पास हो गया तो इसके बाद इसको पास मिलेगा, फिर उसके बाद वो क्वेश्चन इसके लिए दूसरा आएगा क्वेश्चन. कोई डाउट है? क्लियर? एनीबॉडी हैज डाउट इन इश्यू? ठीक है. ये ए टीम बी डी एफ जी. So the 3 rounds of anatomy pass है ना आपने? Anatomy pass के क्वेश्चन है ना? पहला क्वेश्चन. This is the first question for the team A. Which artery runs on the superior border of the splenic artery? Splenic artery is the correct answer. So marks are out. So the question for the team B now. Boundaries of Pesaro's triangle, also called the thickness. Boundaries of Pesaro's triangle.
Time up.
Pass to team C. ठीक कोई आंसर मैं करूँ? Next question.
For team C,
Time up.
for team D,
क्या? Yes, correct.
next question for team E. Next question for team F.
Correct. Now question
For next team.
आपके लिए.
Time up.
Wrong.
अब next. ठीक है, next. These teams will stay. Prince, Akhil, team A will stay.
एलिमिनेट हो गए, 2 एलिमिनेट बाकी एलिमिनेट है। चलो ठीक है, चलो ठीक है। तुमने आंसर कर दिया था ना, कौन सा क्वेश्चन है? कोऑर्डिनेटर आंसर कर बुला ले, एक और राउंड, एक और राउंड, एक और बना रखा है, एक और ले ले, एक और मैंने कहा कर लो 14 ठीक ठीक 14 क्वेश्चन नेक्स्ट क्वेश्चन टीम ए के लिए।
Question for team A.
Time up.
Pass to room B. Huh? No. Next question for team B. Type political system.
Time up.
ठीक है।
Question for team C.
Time up.
Yes, correct. No, next
Team D.
Team D.
Question for team D.
Correct.
Next question.
Time up.
क्या? मेन बैंक
Next question.
Next question for
Time up.
Next question.
Identify the anatomical variant. So this ends up the anatomical round. बताओ तो नंबर ऊपर हो सकता है।
Team A, Prince Akhil. Team B, Subharti.
मैम सब मना कर रहे हैं कि मैं सर एलिमिनेट प्लीज बता दीजिए आप। एलिमिनेट प्लीज आप हाँ ठीक। नाउ अब सर्जन्स का हाँ राउंड पूरा फिर से एक और राउंड ठीक है। आप काउंटिंग करते जाइए।
15 सेकंड।
ठीक है कोई ऑर्डर नहीं।
कुछ नहीं होगा।
चल
Starting with team A.
Identify the type of biliary injury. ठीक है, टाइप ऑफ biliary injury you have to identify for team A. Type.
Time up.
It's not wrong. चलो ठीक है.
भैया जो हाउ मच है रोज इसका नाम बता दो. लॉट हो गया तो और ऐसे की तैसे बताया चाहूँगा देखिए मैं तो लाइट चल रहा है जो आप आम बात ना चल रही मैं ढंग से गलती बैठती
So third round, so it was in the most common benign tumor of the liver is. EP is the best imaging modality for detecting liver metastasis. And 15C, which segment is paired in right hepatectomy? The options are 5th, 6th, 7th, or 2nd. Right hepatectomy, 2nd. Which tumor marker is TB? Which tumor marker is usually elevated in colorectal cancer? Most common type of colorectal cancer. Most common type of
बैठ जा आराम से
Pringles manure involves the occlusion of next question for what is the classification for allied cholangiocarcinoma? Name of the classification for allied cholangiocarcinoma. Classification for the cholangiocarcinoma. Name of the classification for cholangiocarcinoma. This one classification.
बोर्ड बहुत दिक्कत का है इसमें रेड हुआ गया रेड वो तो मैंने ध्यान कर लिया कि अगर ध्यान नहीं करता ना चलता था बस नहीं चल रहा था वो जब सेकंड में चल रहा मैं आया बस मैंने बैटरी लगाई बैटरी तो ऊपर देखा मैंने साइड में निकाल रहा था कितनी देर सारा अभी तो जैसे अब मैंने तो ध्यान नहीं दिया मैं तो सीधा बैटरी लगाई ऊपर चार्जर तो मैंने चार्जर भी लगाया चार्जर नहीं लगा तो सिर्फ बैटरी लगाई चार्जर में
conducted by our quiz master, Dr. Harinder San.
For the final round, each team will be provided with a questionnaire and 2 minutes to answer it. The team with maximum number of correct answers will be announced as the winner. Started. Thirty seconds left. Time up. Starting with team
सेकंड से खत्म हो गया
Second prize for best paper presentation goes to Dr. Sankal. I request Dr. Sanjay Pandey sir. On behalf of the Parth will take the prize. First prize in paper presentation is Dr. Manroop Singh. I request Dr. M.K. Maheshwari sir. Dr. Manroop है यहाँ पे? I call Dr. Harinder Sandhu sir for prize distribution of quiz. Now the prize distribution for quiz. The first prize goes to tell a second बताऊंगी. Second prize goes to Dr. Subhalakshmi and Dr. Swati. Dr. Swati. First prize in quiz goes to Dr. Akhil and Dr. Prince. Thank you, Dr. Rupali. Now we end the CME. पोस्टर के प्राइसेस वहीं पे मिलेंगे क्योंकि अभी पोस्टर कंपटीशन इज गोइंग ऑन.
मैम खत्म हो गया ना उसके बाद नहीं खत्म हो गया ना फोटो सेशन मतलब ग्रुप फोटोज